Good morning.
Morning.
Welcome to the second hearing of Portfolio Committee Number 2 Health for the Inquiry into Budget Estimates 26-27. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name's Dr. Amanda Conn and I'm Chair of the committee. I welcome Minister Park and accompanying officials to this hearing. Today the committee will examine the proposed expenditure for the portfolios of Health, Regional Health, the Illawarra and the South Coast. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today, however it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. To our witnesses, welcome and thank you for making the time to give evidence. All witnesses will need to be sworn prior to giving evidence. Minister, I remind you that you do not need to be sworn as you've already sworn an oath to your office as a Member of Parliament.
Thank you.
For all other witnesses, could you please state your name and position title and swear either an oath or an affirmation? We'll start with my left and then at the end we'll go to the overflow seating area as well. Go ahead.
Thank you. Good morning. Fatima Abbas, Deputy Secretary, People, Culture and Governance. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning. My name is Alfa D'Amato, Deputy Secretary and Chief Financial Officer, New South Wales Health. I swear the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Good morning, Elizabeth Wood, Deputy Secretary, Health Systems Strategy and Patient Experience, New South Wales Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
My name's Susan Pearce, I'm the Health Secretary. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Dr. Kerry Chant, Chief Health Officer and Deputy Secretary, Population and Public Health. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Claire Beach, Interim Chief Executive, New South Wales Ambulance. I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Emma Skulander, Deputy Secretary, Infrastructure and Asset Management and Chief Executive of Health Infrastructure. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Luke Sloan, Deputy Secretary, Rural and Regional Health. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Morning. Matthew Daly, Deputy Secretary, Systems, Sustainability and Performance. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
We'll go to the witnesses in the overflow area and I remind you that when you come forward to please bring your nameplate with you and place it in front of you at the table, which assists Hansard in ensuring the correct witness is identified in the transcript. Yes, please.
I'm Wendy Hoy, Chief Executive, Justice Health and Forensic Mental Health Network, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning, my name is Deborah Wilcox, I'm the Chief Executive of Sydney Local Health District. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. Thank you.
Good morning, I'm Emma Field, I'm the Chief Executive of the Murrumbidgee Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Good morning, I'm Tracy McCosker, Chief Executive, Hunter New England Health. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Dr. Catherine Taylor, Director of the Public Health for the Central Coast Local Health District. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning, Michael Nicol. I'm the Chief Executive for the Clinical Excellence Commission. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning, lucky last. Kate Marr, Deputy Secretary, Premier's Department. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thanks, everyone. Today's hearing will be conducted from 9:15 to 5:30. We're joined by the Minister in the morning session from 9:15 to 1 with a 15-minute break at 11 o'clock. In the afternoon, we'll hear from the departmental witnesses from 2 to 5:30 with a 15-minute break at 3:30. During these sessions, there'll be questions from the opposition and crossbench members only, and then 15 minutes allocated for government questions at 10:45, 12:45 and 5:15 p.m. And we'll begin with questions from the opposition. Mrs. Mitchell.
Thanks, Chair. Morning, Minister, and to your many officials who are here with us. Good to have you all here this morning. Minister, mould at the Mater again. Not good, is it?
No, it's not good, all right. It's probably another example, this time under a former Labor government, of a PPP that is not working for the people of New South Wales. We have intervened at that site now multiple times. You would know, and you've had a very close interest in this, is that we've been able to do and commence the cladding work that we hope will make a difference. We've been able to do a building inspection report and then soon commence a number of pieces of work on the HVAC system. At the same time, we've got to try and make sure that we hold that private operator to account, because it's taxpayers' money and they've got a responsibility under the contract. But you are right to say that it's frustrating. You are right to say that this is not a situation that I wish the people of the Hunter were dealing with, nor do I wish that for the staff, but we are trying to work through this as quick as we can. Probably not quick enough for the community, and I understand that, but I've also got a responsibility with a complex contractual arrangement to make sure that while we work through and have a look at our options through that contract process, that we also take into consideration that we are dealing with taxpayers' money, and I've got to make sure I get that balance right.
So if I can just take you to the specifics of the announcement or the statement that came out yesterday, specifically in relation to the aspergillus found in the ICU. Why didn't you issue that statement?
It was a couple of things. It was an issue that the health department and the agency normally issue, because it's a very operational one. You will note that I immediately made myself available, I think, the following morning for interviews. I spoke to NBN through Channel 9 yesterday about it. I don't think I was contacted directly from the Herald, but I note their reporting and long-time reporting on this. This is an issue that is near and dear to my heart. I've probably got the government more involved in this contract than perhaps at times we would have liked, simply because I'm not happy with the pace upon which these things are being dealt with, and I've been pretty clear. I'm not happy with the way in which at times the private operator has honoured their end of the bargain. Now, I've got to continue to work through that. You would know from your role as a minister, when you're dealing with complex PPPs and infrastructure, you've got to get the balance right of making sure that the services are delivered safely and effectively. That's my top priority, and the staff and patients are safe, but at the same time I've also got to navigate holding a private operator to account who's responsible for their end of the bargain of a private of a PPP arrangement they entered into.
So when
under
were
a
you
former
told
government.
about the new issue of mould in the ICU?
I'm going to say Monday.
Okay. And do you know the exact
Monday,
date?
Tuesday,
that
sorry.
August air quality test
Yeah.
was conducted, and when those results were confirmed.
Yep.
Can you give me a date?
I got a briefing, Ms Mitchell, yesterday morning, I think it was. Just getting my days, I'll just double check that. But in the last day or two from the team at Health Infrastructure and Tracy McCosker and the team at Hunter New England Health, 12th of August, I think, was when the testing was carried out. I'll just make sure. Emma,
If Ms McCosker wants to come up to the table, that's
Okay,
fine. If that would
yeah.
assist you, Minister, I'm happy with that.
I'm
Not to tell you what all Ms
No, no.
But yeah.
I
I'm just
wanna
keen
make-
to understand when health knew and when
Yes,
you
I
knew.
just want to make sure I get that
Yeah.
date right. I think it was 12, the testing.
So the 12th of August was the date the testing was conducted, but it takes some time to receive the results. So the results were received by the Hunter New England team Monday the 24th of the afternoon, and I was aware that evening that there had been some results received. The Minister was briefed first thing the following morning.
Thank you. And then how long after those results were confirmed were any impacted patients and families notified, Minister?
Probably, Tracy, is that all right? I just want to get the timeline
That's okay.
right.
I'm happy for.
Yep, sorry.
No,
I'll try and get through it.
So as soon as we heard about the results, it was 3 rooms out of 6 at the ICU. Someone was about to be discharged anyway, so we kept that room empty and we did some deep cleaning, and then we rotated the next patient into the clean room after it was tested, cleaned that one, and then did it again. So really over a number of hours, we had the ICU operational again.
Okay, but impacted patients, I think the statement said yesterday that impacted staff, patients and families have been contacted directly. I'm just wondering
That's
if that
right,
happened.
sorry. So
and what
yes.
was the time frame between the testing results coming back in and potentially impacted patients
So
being
as we were cleaning, we were then going back and talking to the staff, and then the staff were talking to the patients in the ICU.
Okay, thank you for that. Minister, I appreciate what you're saying about the complexity of the PPP. This committee knows it well, having done the inquiry. We've handed down the recommendations.
Yep.
A very simple question to you. Are you going to terminate the PPP? What is the government actually going to do? Because people in Newcastle and staff and patients are fed up. You know that. We know that.
Yep.
I think the time for talk is fast running out. What is the government actually going to do here about this hospital and what's happening?
Yeah, so a couple of things. It's a good and fair question for a start on behalf of the people of the Hunter region. We've made a number of interventions into the contract already, so I don't want people to think we're sitting still and idling time. We've done the cladding and done a range of other issues in terms of trying to intervene in that. 2, government is at the moment working through with the private operator the options around and taking legal advice around our options in relation to that contract. I'm not in a position today to say government has made a decision on that because they haven't, and that'll be a part of a cabinet process, a future cabinet process, if that is the pathway that we determine or go down. Firstly, I've got to look at a number of things. The delivery of services safely and efficiently is a top priority. And when I say safe and efficiently, I mean safe and efficiently for staff, patients and visitors. Secondly, I've got a responsibility as a Cabinet Minister to be responsible around the use of taxpayers' money. So I can't just hand this over. What I won't do is do what the opposition made out I should do, which is allegedly buy this back for $2. Now that is completely wrong. The liabilities on the state, if we did that, would be tens if not hundreds of millions of dollars. So we are working through a complex piece of contractual arrangements. I'm not in a position yet, because I've not been advised yet of what those options are going forward. Once I do get that and I make a pathway through the Cabinet and ERC process, subject to what happens there is when we will inform the community of a way forward. But this is not complex, this is not easy. I know it's frustrating, I get that. I'm trying to intervene as much as I can on the way through, but we're not in a position today to determine and to announce what pathway that the government is going to do in relation to this, because I just don't have that information in front of me.
Thanks, Minister.
Morning, Minister.
Morning.
Minister, 113 senior medical staff council members voted to proceed towards a vote of no confidence in the New South Wales Health Ministry leadership. What does that figure tell you about staff morale at Concord Hospital?
Well, I want the health leadership to know from me that I have full confidence in them. We're not a perfect system, but we're a very, very good system. And Secretary Pearce leads a great team, both within the ministry and through chief executives across New South Wales, of a system doing pretty remarkable work. It's an important question about Concord, and it's one that I'm happy to address. I want to do it in the context, though, that we need to see Concord in a piece of totality. And what I mean by that is I've had a number of discussions with some of those clinicians. Ms Pearce has worked with the Chief Executive and been out to Concord a number of times with the Medical Staff Council. What we also need to know about Concord is, though, it's also a very, very good hospital. So the People Matters survey that has been going on for a long time, employee engagement has increased by 4 percentage points
Minister, I
to
take
69%.
those points, and you're right, Concord is an excellent hospital, but staff morale, you've got 113 senior medical staff council members voting to proceed towards a vote of no confidence. You've indicated you've had discussions with clinicians, Ms Pearce has had discussions. Minister, why did you let it go this long? Why are you only taking action now that a vote of no confidence is imminent? Why no action before?
I just want to clarify, though, you talked about morale, and what I'm providing you with some objective data to say that employee engagement, an important part of morale, is up 4% to around 70-odd percent, 69% I think it is. Job satisfaction, an important part of morale at that hospital, is up.
So what I'm hearing, Minister, with you quoting these figures, is that you are discounting entirely the voices of the senior medical staff, and you're asking us to look at other things. Are you serious about the inquiry that you've launched into Concord Hospital?
I'm not saying that. In fact, I've had an opportunity to meet with those clinicians, with Ms Pearce, and then individually a number of times, and I appreciated their frank feedback to me. What I can tell you is that no one's discounting that at all. What I'm just trying to present is some context around Concord. What I don't want staff at Concord to think is that I'm talking that place down because there are issues. Yes, there are issues. We've identified that. The Chief Executive knows that. The Secretary knows that. We're doing a piece of work with the Auditor General. The Auditor General is doing an independent piece of work that they will commence when they see fit, and sometime soon. So I don't think to say that I'm discounting it. We've had pretty extensive engagement, as has the Secretary, as has the Chief Executive. What I'm just trying to provide a little bit of context is that there's a lot of good things at Concord. That's not to dismiss
Agreed, Minister.
some of the
Absolutely
issues.
agreed.
That's all.
And with respect to the review by the Auditor General, will that also investigate whether disciplinary policy is being used to silence staff who raise legitimate concerns? For example, the action taken against Dr. Rael Pope, a leading neurosurgeon, apparently because of his use of social media.
So, just from the outset, I obviously can't and won't be commenting about individuals' HR issues that they have.
The general issue about silencing staff.
I just don't want my comments to be linked to someone's personal circumstances, because I wouldn't want that if I was an employer.
I am now inviting you to comment about the general issue, Minister, of policy being used to silence staff raising concerns about Concord or any other hospital.
Yeah, so in relation to the general issue, and I think you're referring what I'd loosely call to the social media policy, perhaps. I don't want to put words in your mouth, Ms Carter, but if that's the case, that policy is consistent with a whole of government policy around the use of social media. We've got a responsibility, and I imagine this is similar in portfolios like education and family and community services and others, that we've also got a responsibility to make sure that people don't lose confidence, not in the minister or the ministry. That's not our issue. They can criticise me or Susan or the system. That's not the problem. I just don't want people losing confidence to go to the hospital because someone's gone out and made claims that may or may not be accurate. So that's consistent. That policy is consistent with a whole of government view around the use of social media by public servants. We've always had these types of policies in place under previous governments, as they should be, because...
But is its application subject to review in the current inquiry?
Well, the Auditor-General is an independent statutory office holder. They will determine the nature of the work they do. What I can tell you is that in discussions, not myself, but that the Ministry and Ms Pearce has had with the Auditor-General about these broad issues, we've encouraged them to engage with staff and through the Medical Staff Council. That has been part of both written correspondence and things that we've talked. We want them to engage with staff on this. We're not doing this. Ms Pearce hasn't done this because we want to try and get a sanitised version of some of the challenges at Concord. We're doing this because we want arguably the most independent office holder that works across government agencies to give us another look at a hospital that continues to get some feedback from clinicians, not all clinicians, but some clinicians, that we could be doing things better. And but we also think we've made a number of big steps in that hospital, particularly around cultural interventions that we've done, particularly around leadership changes in different roles. We have not sat still. Yeah.
113.
Yeah. I get it, and I understand that vote didn't proceed. I understand that vote didn't proceed, and I think that was a good path. It was up to them how they went about it, but I made it clear to clinicians that what I'm interested in is engaging with people that want to improve the culture at Concord and want to make sure that hospital remains a really good part of the health services delivered to that community. And people who have got that frame of mind are always welcome to speak with the Secretary, the Chief Executive and myself.
Thank you.
That will always be the case.
Keeping on the topic of staff feeling like they can't raise issues and that flowing onto impacts onto patients, are you aware that a number of specialist GP obstetricians have temporarily withdrawn their services at Queanbeyan District Hospital?
Yeah.
What do you know about that, Minister?
I'm aware of issues at Queanbeyan. So we have had some issues in relation to maternity services at that hospital. I was down there probably, I'm going to say, the last few weeks, and I had an opportunity to speak with some staff around that. I'm not going to say that we've sorted Queanbeyan out, because...
No, I don't think you have.
Just so I say, I don't want to give any impression that that issue is over, but I just want to give you a sense of what we have done. We've established a task force to oversee improvements to that service. The maternity service is staffed, as you know, by highly trained clinicians and midwives. We have put a temporary obstetric consultant, I think is the right term, which is the head of department. I think they commenced there around about the 17th of August in relation to that. The Ministry and the Clinical Excellence Commission are also providing support to the district, and the recommendations as a part of the task force from the maternity staff force are being implemented. But I do want to just emphasise this, because this is important. There are contingencies in place. We've also done a redesign, or doing a redesign of the amenities and some of the patient spaces in that area. But I'm going to describe it as a work in progress. I'm certainly not going to describe it as job done.
But Minister, you've got a situation here, and this has come from concerned residents in the community, women who have raised this with me. You've got 4 specialist GP obstetricians who are no longer offering their services because they've raised concerns about clinical workplace safety at the maternity unit. You've got expectant mothers coming to one of the most important times in their life, who are anxious, who are asking to be transferred to other hospitals, women moving to other areas because they don't feel safe birthing there. This is a bit bigger than a task force, with respect, Minister. What are you going to do to restore confidence? Why have these staff effectively been stood aside because they raise safety concerns? That's not a very good system, is it?
Yeah, well, I'll get Ms Wood to add some more detail. I just wanted to highlight that the service continues to operate and is supported by a locum workforce, as well as what I said, a temporary...
That's not continuity of care, with respect. You know, we've raised this in maternity issues with you before.
Yeah, well, your government also closed or paused
14 This is about you and Queanbeyan, Minister. This is happening now under your
I mean, I
watch.
just want to highlight that.
You've got women who are anxious in Queanbeyan now. They want to hear from you about what you're doing.
Sure, and I'm just trying to tell them what we're doing. We've set up a task force to examine some of the concerns raised by those clinicians. We have put in place a specialist obstetric head of department. As I said, I think that was around about the 17th of August, for want of checking that date. We've got some locum coverage there. That is maintaining that service, and we will continue to engage with the staff, the midwives and the management to try and work through that issue.
But it's the same as Concord, with respect, Minister. It's this constant thing where staff speak up because they're concerned about things and they get shut down, they get told that they can't work there anymore. It's not a great culture that we're dealing with at the moment, is it?
I'm not shutting down staff, and that's the thing. I'm not saying that I don't want to hear from them. I'm just trying to make sure that whilst we work through these issues, we've got a service maintained, that it's safe and effective. I had an opportunity to speak with management about that a couple of weeks back. I was really upfront that I said that we needed to work through this issue, and that's what we're trying to do. That's not me or the Secretary or the Deputy Secretary shutting down staff. I'm not interested in that at all. The last person who thinks that we've got a health system that's perfect is me. I go to bed at night wanting to do better tomorrow than I did today. That's the way I think. So I don't think that ever have an attitude that this is a perfect system, and I don't ever think that the workforce speaking up is not appropriate. I always think that, but it doesn't mean that I can resolve an issue straight away. I've got to work through it as well.
Minister, continuing on from this theme, it's very clear that the issue of staff being suppressed or punished when they raise concerns about patient safety or their workplace are not isolated. We've had questions this morning about Concord Hospital and Queanbeyan Hospital. But frankly, at this point, it would be easier to count the local health districts from which I haven't heard directly from staff rather than the ones from which I have. There are serious concerns amongst the workforce that when they raise those issues and they're not heard, that they are subsequently punished for doing that, or they become desperate enough to raise concerns on social media or with members of Parliament, which is really going above and beyond their frontline work as health workers. Where do you expect people to raise these issues? If they go through the appropriate channel, you know, their manager or the appropriate committee at their hospital and their issues not heard, what do you expect them to do next?
Well, I want to be clear about this to the workforce, and there's, just for argument's sake, about 180,000 workforce staff in our system, one of the biggest health systems in the world that we are responsible for as the system manager. So from time to time, people in a system that diverse are not going to be happy. So we are always going to hear from staff who want changes, who believe things need to happen different. I want you and the committee to know this, that's not one time in my 3.5 years, and there's not one time in that time where I've seen Ms Pearce or anyone else try and shut down staff advocating for improvements to services, improvements to funding. These are meetings that I have all of the time. I would challenge anyone who meets more staff or more staff representatives through the union movement than I do. I have regular engagement with the union movement through organisations like the HSU, the Nurses and Midwives and ASMOF. I'm constantly engaging with staff around these things, as you would in a complex system and one that is staffed by so many people. But at the same time, public servants also have a responsibility as well as carriers of important public policy and public deliverers of public services to make sure that our communities have real confidence in our system. That doesn't mean that we're saying that everything is perfect. Why would I expect staff to say it when I don't say that everything is perfect? That would be silly, because people would have heard me see and speak many times from the moment that I took this job on is that I want to do better tomorrow than I did today, and that's the attitude that our executive team have. And if staff have that view and they're about doing that, then I'm quite happy to engage with them. But equally, we've also got a bit of responsibility when staff sometimes engage in social media that attacks other staff or that perhaps is not always accurate. I've also got a responsibility to make sure people don't lose confidence in a world-class health system. And so it's striking the balance.
Yeah, Minister, can we come back to that point? So you said twice this morning the social media policy is important to make sure people don't lose confidence to go to hospital. Your frontline clinicians are trained in open disclosure. When something's not going as well as it should, they know that the best thing to do is be honest with people, to say, this didn't go as well as it should, or a mistake was made, this is what we're going to do to fix it, this is what we're going to do to make sure it doesn't happen again, and to apologise. When you've got frontline clinicians saying one thing and hospital or local health district management saying, actually everything's fine and there's nothing to see here, do you accept that it might actually build more community and staff trust to acknowledge those issues and talk about what you're doing to fix them rather than have them swept under the rug?
Yeah, I suppose we instituted a special commission of inquiry into health funding and health resources in the first year of our government. Something was advocated by the Health Services Union on behalf of workers. That's a pretty big deal. I don't know many other agencies who have gone through that. That's as comprehensive of an inquiry as you can. Some of the cultural issues at things like Concord, for instance, there was actual opportunities in that inquiry for people to speak directly with commissioners and the staff around that. And in fact, Ms Pearce and others made it very, very clear that there would not be any silencing of concerns or issues. That's a pretty comprehensive inquiry to go through. In addition to that, we and I have tried to make it pretty clear in all of my public commentary that, and I would say this is for ministers from across the political aisle, we would never want our agencies to have staff that feel as though they can't speak up. And if staff do feel like that, of course that's a concern of mine. But equally, I've got to balance the requirements of central government policies that apply to all of our public servants. I've got to make sure that there's still opportunities for frontline staff to engage in feedback, and there are a range of mechanisms for them to do that. But I've also got a responsibility that to the people of New South Wales to make sure that if they get a piece of information on their daily feed about a particular hospital that may or may not be accurate, or about a particular person in a hospital, I've also got a bit of responsibility to make sure that they have good confidence in a world-class health system, not a perfect system, not a system that can't improve, but it's still a world-class health system. By
Minister,
any
do you
measure.
accept that these problems aren't isolated? I mean, we've talked about Concord and Queanbeyan, and there's been a highly publicised issue with the gastroenterologist who's no longer working at Port Macquarie. Surgeon John Stutchbury is still not operating at Albury Hospital. There are patients missing out on care across the state because of clinicians who've either withdrawn their services or been stood down because of public comments they've made in the public interest to try to improve the health system. Is that okay?
I completely accept that in a staff of 180,000 across the length and breadth of this state, that you are always going to have issues with people advocating for improvements and people advocating for change and people advocating that they're frustrated that something hasn't happened. I'm not going to ever pretend that we will have a system where people don't do that. In fact, I would be worried if we were managing a system where that didn't happen, because that would indicate to me that perhaps we're not getting a real perspective on the ground. I suppose what I'm saying is that my belief is you'll always have, in a diverse employee population like ours and the volume that we have, people who speak up. I want them to speak up. I've just got to make sure it's done in a way that protects patients, it protects their colleagues, but also doesn't lose confidences in the delivery of some important health services for the community. And
but Minister, you've said you want people to speak up. When you've got very senior clinicians being stood aside or stepped down because of their public comments, it's very clear that the message that sends to the rest of the workforce, and particularly to more junior members of the workforce, that they'll be next if they speak up. Do you not accept you've created a culture where that's not seen as supported?
Without, again, just because I don't want people to apply this to individual cases, without going to an individual case, I would be highly surprised if someone was simply stood down for speaking up about wanting to improve their place of work, and it was only and solely based around that. We have a code of conduct, as does every agency, as does ministers, as does members of parliament. We have a code of conduct. We have a social media policy that is consistent with central government policy around social media use. Their minister, their secretary has said we want people to speak up. I'm not stopping people speak up, and I'm not doing that because I spend a lot of time on the phones and in meetings and in email exchanges with clinicians. So it would be unusual for me to be saying it when I say that frequently we don't have a perfect system, but we've got a very, very good one, and B, that I don't want a system where people, and the Secretary doesn't want a system where people don't feel they can't speak up. I've just got to get the balance
Minister,
right.
There's currently a draft out of a secondary employment policy that would be the highest standard of secondary employment disclosure of any public sector workforce in the state. This goes above and beyond what any department is doing. It would require New South Wales Health employees to seek approval every 12 months for not just secondary employment, which every senior doctor would be engaged in, whether that's teaching or private appointments, but also things like volunteering, being elected to local government, involvement in community supports and other groups, sporting groups. What do you think that's doing to morale of the staff?
Well, I've had an opportunity to speak to a number of clinicians in about the last 10 days about that. I emphasised that it was a draft policy, and I just want the committee to be emphasise and understand that it's not a policy that we're implementing yet, because we're out in draft having a conversation about it. We want to make sure that it works within our health system and doesn't become onerous on doctors and clinicians, as you say, and rightly say, Ms. Bond, who do a range of other appointments in a range of different things. But I've also got to make sure that it is as corruption-proof as I can. I've got to make sure that it is appropriate in relation to codes of conduct and the way in which people are engaged in other employment, and how that may or may not impact on their employment with New South Wales Health. Now, I've got to do that because that's important, as is an issue that you've also raised in the past, Ms. Conn, the issue around fatigue management, i.e. I want to make sure that our clinicians and our frontline staff, given the demanding job that they do for us, are not burning themselves out by trying to do other work. So it's in consultation, it's not locked in yet. I've had an opportunity to speak to some senior clinicians who raised concerns, so I just want to be transparent. They did raise concerns with me about it. We've just got to try and get the balance right around those other things that I also said.
Thank you, Minister. I'll come back to this later.
Yep.
I'll go to Ms Fairman.
Thanks, Chair. Good morning, Minister.
Good morning, Ms Fairman.
Minister, the annual rate of unplanned emergency department presentations mentioning methamphetamine is higher now than it was when then Premier Gladys Berejiklian established the Special Commission of Inquiry into ICE. So the annual rate of unplanned ED presentations, this is to the 88 public hospitals, mentioning meth in New South Wales, increased to 3.6 per 1,000. In 2016, it was 2.8 per 1,000. Just before the ICE inquiry, it was 2.7. So last year, just in terms of figures, that was 8,500 unplanned presentations. 25% were actually admitted to hospital. So it's a significant.
Of those 8,000,
it's a significant figure. So why is your government failed then to address the ICE crisis? There's been $500 million, actually more than that, put into tackling and addressing some of the recommendations, but it's going up under your watch.
Well, drug misuse in our community is a big concern. It's not just a big concern for individuals, but it's also a big concern for systems and communities, and health bear the brunt of that at some times, as do our paramedics. We have invested pretty significantly in drug and alcohol rehabilitation services. We've invested pretty significantly in mental health services, but that I don't think any country around the world has got the answer yet to the impacts of illicit drug use, particularly on health settings, as you described it. But you are right, I can assure you, and having spoken to some security staff last week, they described, Ms Fairman, a very different intoxicated or under the influence patient now than perhaps 25 years ago, when they were under the influence of a different type of drug.
Yes, so it's
methamphetamine.
Things are getting worse. There's still some key recommendations from the ICE inquiry that have been rejected by your government, but I wanted to turn to one that was implemented, and it was around, obviously I've asked about this a number of times at budget estimates, but it runs in parallel to the $500 million, and that's the Early Drug Diversion Initiative. And I'm aware that much of this rests with the police, but I'm asking you now, because a significant portion of people who are caught by police with a personal quantity of drugs or using, let's just stick with ICE, the vast majority of them, probably around 93% of the thousands that are caught each year, are sent to court rather than being offered that hour phone call, that intervention, which was a key pillar of that $500 million. What are you doing as Health Minister to get the EDI scheme reformed?
Yeah, I mean, I've just got to be very...
Are you speaking with the police minister about this?
Yeah, sorry. So let me say broadly, as a part of the discussion that went into the drug summit, and this issue was raised, certainly we as a government have had a number of discussions discussions, for want of a better term, around a range of measures in relation to diversion. I don't want to go into those discussions here because government hasn't made, and particularly the police or Attorney General Minister have not made announcements in relation to that. So it's not my wheelhouse to be able to do it. Other than to say this, we had a very, very comprehensive drug summit. That drug summit examined a range of issues. We've moved on a number of reforms in relation to those issues that were raised. That doesn't mean that the work of the drug summit is over.
Okay, thank you, Minister. So what responsibility will you take to get those statistics, and they're not statistics, they're real people, but to get that down? I mean, it rests with you, doesn't it? The fact that we're seeing increasing numbers of people presenting to EDs with drug issues, particularly ICE issues. Doesn't this fall within your portfolio to ensure these people get treatment first before they're sent to court?
Well,
do you have influence on this?
Yeah, well, yes, I want to try and get people the right treatment, and I want to try and reduce ED presentations, and I want to particularly try and reduce ED presentations of people who are under the influence of a dangerous substance like methamphetamine. But I've equally got to make sure that as a government minister that we are working with police and Attorney General who also have a view and a perspective around appropriate punishments for those who do the wrong thing and use an illicit drug. So you've also got to get the balance right around, yes, of course, I don't want people in my emergency departments causing problems who are under the influence of illicit drugs.
Not least of which is I think you need some room freed up as well, some beds freed up, not least because of that.
But I suppose there's the other aspect of government policy, which is sending a very clear message to users and suppliers of this drug that it is an illicit drug, it is an illegal drug.
That is just absolutely ridiculous. I am talking to you about the fact that ICE use has increased. There are more people presenting to emergency departments and being admitted to hospital, and you're here telling me you're trying to send a very clear message not to take drugs. Drugs are illegal. Are you seriously, as the Health Minister, sitting here telling me that today?
Well, what I won't tell you is that we're going to go soft on illicit methamphetamine drug use. I mean, I'm not going to be doing that.
Even the police minister at the drug summit was actually better on this, Minister. Well, the police minister, I was in a workshop with her. She admitted that the early drug diversion initiative scheme wasn't working. It had to be. It had to be changed. There were too many requirements for people to meet. I mean, there's a basic understanding within your government, isn't there, that people should receive treatment. The basic harm minimisation theory is that people should receive help if they need it, rather than be sent to court. Can we agree on that?
What I'm trying to say is, I understand the importance of EDI. It's a very important scheme.
It's not working.
What I'm trying to say is that the police who work within that scheme have also got to make a decision. I'm not the police minister or the police commissioner. They've got a role to play to make a determination. Of course, I want to see less people under the influence of drugs coming into our ED. I want to see less people in the community on illicit drugs.
You're failing, Minister. You're failing in that job.
Well, we've also got to make sure that we send a message to people using illicit drugs that it's not a free-for-all either.
God.
I mean, I'm not going to.
Really?
I don't know. If we disagree about the use of methamphetamine,
it's hardly that's what's happening with sniffer dogs all over the streets and in the clubs. I mean, hardly.
Sorry, Ms. Fairman, we're into opposition time. Mrs. Mitchell.
Minister, how many of the recommendations from the Special Commission of Inquiry into Healthcare Funding have been implemented as of today?
I'd need to take that one on notice just to get an accurate answer. They were pretty comprehensive, but
do you have an implementation plan, timelines, expected delivery dates that you could table as well?
We've got an implementation group that works through those things. I can probably get all of that information. It's a regular part of our discussions around at Minister and Secretary meetings each week.
Sure.
It's
pretty comprehensive. But
All
but
right.
I just want to make sure that
That's all right. Well, could you
I-
table what you can in terms of implementation plan and
I'll take that on
milestones and
notice,
delivery
yeah.
dates? That'd be great. Thank you. How many of the 600 hospital beds that your government promised for Western Sydney have been delivered as of today?
Well, one of the things that we are delivering that the previous government talked a lot about but didn't do, which is Rouse
Yeah,
Hill
not what I asked
Hospital.
you, Minister. I asked you how many of the 600 hospital beds that you promised for Western Sydney nearly 4 years ago, how many have been delivered as of today?
Well,
the answer's zero, isn't it?
Well, hang on. Let me. No, it's not zero, but let me.
It's not zero.
Well, no. Well, if you let me. So let me.
Sure.
If you let me
I'd
get
love
out
to-
of
I'd
an
love to
answer,
know which ones are open and operating today.
I'll do my best to try and answer it, but I've got to try and have 3 seconds to answer it. So, one of the big things we are doing is in Western Sydney a number of big investments in health infrastructure. So, a brand new hospital at Bankstown. Our previous government couldn't pick a site for it.
With
A
respect,
brand new
Minister, I'm
hospital
asking
at
how many of the
Rouse Hill,
600 have
government
been
took it
delivered.
to
It was a pretty
three-
direct question.
took
It was
it
a
to
pretty
three
direct
elections
question. It's
and
not
There's been a
you
point
can
of
have
order.
government time
Order.
if you want to spruik your thing.
a brand new redevelopment at Fairfield and Canterbury. So when we say not getting anything done, that's in 3 and a bit years. We've moved on all of those projects.
But none of them, nothing's been delivered as
Well,
of
sorry,
yet.
you had 12 years,
Right.
and Rouse Hill was announced 3 times. No one
Minister,
has ever seen anything.
Well,
I mean,
you've
let's-
announced 600 beds and no one's
we-
seen those.
okay.
You haven't delivered anything, have you?
Okay, well, we've had about 82 beds delivered, but we've also delivered a range of other hospitals that had come online over that time.
Yeah, and a lot of them were funded and left for you to open, cut the ribbons by the former government.
The world started in 2023. I get it under your view, but that's not the actual case. So there's been subsequent budgets where governments have made a decision to invest heavily into things like the Westmead Hospital redevelopment, particularly for the children's component, Randwick Hospital redevelopment. We're investing significant amounts in regional and rural hospitals, including a level 4 hospital at Eurobadalla, the first time that
I'm
we'll have an
asking about,
ICU
with
in
respect,
the far south
I've asked
coast.
about the 600 beds in Western Sydney. So you just said, did you say 82 have been delivered of
Around
those
82,
600?
I think it is, yeah.
Around 82?
Yeah.
Okay.
But I'll get clarity.
Yeah, clarity in the breakdown on notice
Sure.
would be good, thank you.
Sure.
And the 30 beds for Blacktown Hospital, I think you said earlier on radio this week that they would all be delivered by the end of this year. So will we expect to see patients in those beds by the end of this year?
Yeah, that's the aim. What's also very interesting about that hospital, that the former coalition, to their credit, they built it. To my dismay, they built a hospital shy of what needed to be built in one of the fastest growing areas in the country. So we've had to expand that by an additional 30 beds.
Right, and they'll all be open by the end of the year.
Yeah, well.
So with the 82 beds, sorry, Minister, that you just mentioned, would you be able to, and I'm happy if you need to do it in the morning tea break, come back to me with where the breakdown of where those 82 beds are located, please?
I'll take it on notice and
Okay.
have a look. Where we've delivered 82 beds is in places which I did mention, Chair, the Children's Hospital at Westmead, the Nepean, I think this is the right name, but something along this line, the Child and Adolescent Mental Health Service at Mount Druitt Hospital, in addition to not Mount Druitt and Nepean. In addition to that, what you may or may not realise is that more than 1 in 10 patients who present to Westmead or Blacktown emergency departments are doing so because of the failure to build Rouse Hill Hospital.
Yeah, Minister, I've read your media release this morning. You must be quizzing people in the 20 hours that they're sitting waiting at Westmead Hospital for treatment.
Well, no, I'm saying
I want to ask you, I want to
hospital
move
should
to
have
the
been
issue
built.
of bed block, which you've spoken about a lot since you've been the Minister. Again, we've had a lot of talk. You're at the Greater Western Sydney Future Health Forum back in August 2024, talking about the federal government's role, saying it's not a system that's sustainable, and I've made it very clear to the federal government that this isn't something we can continue to operate with. You said that 2 years ago, but in recent weeks you're still saying to people, don't come because hospitals are full, the Commonwealth aren't getting their aged care patients out. So is that an admission of the failure that you've made absolutely no headway on this issue in 2 years?
No, it's a direct observation of a failure in the federal government to deliver adequate home care packages, adequate NDIS packages, and adequate support and residential aged care places. You've got, as of recent times, over 1,300 patients who are stuck. I would challenge anyone who's advocated more than I have at a health ministers meeting.
But nothing's been achieved with respect, Minister. You can have all of the advocacy in the world, but years later we're still dealing with the problems and it's actually worse. So nothing's being achieved by your advocacy. That's your admission.
Well, a couple of things. We're investing in the most recent budget about $35 million over the next 2 years or so to deliver more interim aged care services and allied health. We think that'll support about 750 odd older patients. We think that'll free up about 180 beds. So that is the state investing in an area that traditionally is not our responsibility. 2, our advocacy led to funding of additional capital in places like the Illawarra and other areas from the Commonwealth recently that will in the medium term see additional beds, but you will never get out of my mouth that I am satisfied with the way in which the Commonwealth's interface, i.e. aged care and NDIS, is having an impact on our bed base. To be losing 1,300 beds every morning is remarkable, but Ms Mitchell, I'll be brutally honest with the Commonwealth, that 1,300 beds is not the accurate figure. If the state did not invest the tens of millions of dollars that we've done in things like hospital in the home, geriatric outreach, a range of those particular issues, using our ECP paramedics to be able to get people the care in their aged care home. If we didn't do that, my view is that number would probably be double what it is now. And that is the bigger issue that we're trying to deal with.
So I just want to take you to those federal negotiations. The Federal Health Minister did a press conference in February in Shell Harbour, and he was asked about some of the issues with funding and the challenge, I guess, of diverting older patients from hospitals into residential aged care, and he was talking about the negotiations between obviously the state and federal government, and he said that they offered to put $2 billion of tied funding to help particularly with the issue of longer stay older patients. And then he went on to say, now state governments decided instead that they'd prefer the money to go into the general hospitals bucket rather than to targeted programs to alleviate pressure for long stay older patients. They can explain their reasons for doing that. So Minister, can you explain New South Wales's reasons for doing that?
Yeah, very simply. That would be like my son wanting pocket money for doing his homework. That is their job. Their job is aged care and NDIS. That is their job under the federated model. That is not my job. My job is hospitals and emergency departments. That reform agreement was about funding for hospitals and what their contribution to that funding as a part of a federated agreement. What they were trying to say is, well, we'll give you less money for hospitals, wait for it, but we'll give you money for our issue. It is their responsibility. I mean, I don't know, if my son wants pocket money for doing his homework, I'd be saying, too bad, that's your job, to do your homework. You're not getting pocket money for that. What do they want me to do? Give them money or lose money out of hospital agreement for them doing their job? That's their job. Their job is to provide an NDIS system and an aged care system that ensures people get dignity in care in their residence, and that we as a state are responsible for acute patients. I'm not asking the Commonwealth, heaven help me if I ever did, to run our emergency departments or our hospitals. That'd be literally the last thing the people of Australia would want.
Okay.
But I'm also though starting to have to invest tens of millions of dollars into their responsibility, which is aged care and NDIS, and I'm having to do that because that number continues to grow. But the 1,300, just to be clear to the committee, is not an accurate number of what it would be.
You've already said that, Minister. I mean, I guess the frustration for the community is you've got a state Labor government, a federal Labor government, nothing's moving forward. You know, you're contradicting each other in all of your public commentary. The announced strategy, and you talked about expanded aged care outreach, hospital in the home, etc. Is that new money that's going to that, or is that repackaging?
Yeah, we've
so
had
that's
to,
all new money, all new
that's
money.
announced as part of the budget. We've had to invest into this. I'll be honest, probably at frustration to the Treasurer and others, we'll probably have to do more than that. We've got a Productivity Commission report that's being worked on right now. We are looking at every model around this country and around the globe. I think apart from workforce, this is the biggest challenge facing our health system, and this is something that I am extremely concerned about. And when you're going through a winter like we're doing at the moment, and every morning you're waking up to 1,300 beds gone, the equivalent of 2 Western Sydney hospitals, you would forgive me for not being a little bit frustrated and animated.
Well,
about
people are
this issue.
frustrated waiting longer than ever in our hospitals too, Minister. So you also made a commitment a couple of years ago. It was a $480 million package for emergency department relief, and you said at the time that you estimate that would save 290,000 emergency department presentations each year once fully implemented. As I said, that commitment was made, I think, 2 budgets ago.
It's massive, I remember.
How many
ED
presentations
relief.
have been avoided to date? Have you been
I
able
reckon
to
I
track
can get
that?
you that. I think I can probably get you that as quick as I
Is it
can.
290,000 per year? Is your estimated?
I'm sure we've reached that. I'm sure we've reached that commitment. Not all of those would have been probably rolled out yet. It was obviously a 4-year, as all of those ones are. But
What can I ask you then? What was the methodology that you used to calculate the figure that it would save 290,000 emergency department presentations each year?
Well, Matthew Daly and the team who look after system performance and focus on ED diversions would have provided advice to government around that. That was arguably one of the biggest investments that we've ever made. We are now diverting significant numbers of Cat 4 and Cat 5 away, and just to get rid of terminology for people, I know this committee knows it, but for people like my mum and dad watching online...
I think my mum watches too, so that's 3 who are tuning in.
Miss Mitchell, your mum. Cat 4 and 5s are more of what we'd loosely call GP type of presentations or urgent care presentations, not necessarily what we would define as emergency care type presentations. We, for the first time over the last probably 18 months, seen a trend of those going down.
Right, but just to be clear, you don't have that information. I might ask Mr. Daly about that this afternoon.
Okay.
Thank you. When yourself and the Premier effectively told people to avoid emergency departments a couple of weeks ago, was there any clinical advice that came to you from the Ministry recommending people? I think the Premier went on 2GB and said people with cuts, abrasions and bruises and things don't attend hospital. Was there any clinical advice that you got from the Department or the Premier did before making that sort of commentary publicly?
Well, other than the advice that health professionals give me every day, and through this small thing called Health Direct, that 1800 022 222, which is a service governments over the last, many years across the political divide and across the country have invested into to provide alternative pathways for emergency department for people who need what we'd loosely call urgent care, but not emergency care. And what the Premier was saying is, something that I've said, the Secretary said, the Chief Executive of Ambulance have said, Minister Hazzard would have said it many times, rightly so as well, which is if it's not an emergency, then we as taxpayers have invested in alternative pathways to care. And I don't want people sitting at an emergency department with a cut and a bruise when they might be able to get access to a GP appointment, an urgent care appointment, a virtual care appointment. I don't know. That's...
So just on that, the messaging is that you want people, if they can go somewhere else to get treatment for a condition that might be overwhelming an emergency department, you're encouraging people to look at those pathways. That's a pretty simple way to put it, right?
No, I'll put it...
I'm not. This isn't a gotcha. I'm just genuinely asking.
I know it's not a gotcha. I'll just put it in my own words, just so that I don't mislead the committee.
Yeah.
If it's not an emergency, then taxpayers have funded other services that we would encourage people to utilise, and the best way through that is through Health Direct on that 1800 number that we've talked about, and that has resulted in many thousands of people having to avoid an emergency department. If people have a condition that they consider to be an emergency, and most people are familiar with what those types of things are, then those people should always be calling 000 or presenting themselves to an emergency department.
Okay, so just on the, I guess, less sort of severe conditions, are you aware that there's around 250 pharmacists who will graduate later this year from UTS and the University of Newcastle, full scope of qualifications, who could treat many of these conditions that are overwhelming our emergency departments? Are you aware of those 250 pharmacists with that skill set coming online?
Yeah, I'm aware, and we want to make sure that those people can utilise their skills. We're working through a process around recognising those qualifications and what they are, but I would again argue that we as a government have really lent into what I'd call expanded scope of practice, both for pharmacists and other clinicians, including GPs.
Okay, so but given that you've got 250 pharmacists who can come on as prescribing pharmacists by the end of the year, some of these common conditions, you know, rashes, urinary tract infections, ear infections, reflux, they're waiting, I've been told, for authorisation to be able to practice. When will they be signed off? When can that occur so they can be out in our community helping to ease some of the pressure on our emergency wards?
Yeah, so UTIs can be done now by pharmacists, so that's not one. What I will say is we are working with the Guild to make sure that we can get as many of those pharmacists out and about providing their scope of works to take pressure off the system. This is not a matter of not wanting them to do it, it's just a matter of they've got to finish their qualification. We've got to then just make sure that we're satisfied that that's been completed and that they're ready to go, and we are, as I think all governments of all political persuasions, certainly in this country but I think around the world, are looking at ways in which we can expand scope of practice.
Yeah, but this is, with respect, this is 250 who will be ready to go by the end. Big difference, particularly in rural and regional communities.
Massive.
Too, Minister. So it would be great to get them authorised and out offering these additional services as soon as possible. But I'll just hand over to my colleague for the couple of minutes we've got left.
Minister, the Aerotropolis Hospital, when we look at the current budget papers, it appears that planning completion has been postponed another year. Why is that?
Probably, yeah. Could I take that one on notice, Ms Carter? I don't like taking questions on notice. I'd like to try and give it to her, so if I can find it.
Happy for you to
if
do
I can
that,
try
Minister.
and find it between now and then, I will do it for the committee.
And perhaps you could also take on notice whether it's on track to be delivered in 2028 as well.
Yeah, that was around wasn't a hospital in 2028. It was a planning announcement around, I think, site identification. But yes, I'm happy to.
Thank you very much. And if I could ask you about St George Hospital Stage 4, with major works of the Stage 3 redevelopment of St George Hospital coming to an end, is there currently a proposed Stage 4 upgrade in the works?
Yeah, geez, that hospital has had significant upgrades. I was there with the Premier recently, speaking with their GM.
Well, they're his local, I expect.
That's his local, yeah. They know him very, very well. I also did an unannounced visit there recently. It was very productive. That hospital has had significant expansions. Where a Stage 4 would be up to, I don't think that has come for consideration yet for government. We obviously have a lot of priorities around New South Wales. I'm particularly focused on regional rural for a range of different reasons, but some of those hospitals haven't had upgrades for some time. Things like why we're doing things like Eurobadalla, because that hospital needed it.
Appreciate that. So there's no current plans for expansion of the cancer care centre as part of...
I'd want to take some advice and take that question on notice around the specifics that may be in the capital pipeline going forward. I just want to get clarity around that so I don't mislead the committee. Other than to say, St George is a very, very busy hospital.
Okay.
It's been invested in by successive governments, both the former government and ours. It'll be a hospital that we will need to continue, and governments of all persuasions will need to continue to invest in.
Understand all that and understand
funding. I'm just...
Yeah. But in principle, do you support the redevelopment of the St George Cancer Care Centre?
Well, I support in principle the redevelopment of all hospitals. I'm the health minister. It may be a bit unusual for me not to, but we've just got a treasury process that we've also got to manage, which is a range of other competing priorities across different portfolios, and health is a part of those discussions. We obviously take the lion's share of a budget. I think it's the first time, if I'm right in this, that we've tipped over $40 billion as a health budget in New South Wales, and that comes with it its own challenges and expectations. But you will always get myself and the Secretary to be really strong advocates for hospital redevelopment, but it can't just be redevelopment. It's also got to be about what we're doing to enhance staff, and that's why we're really investing heavily in our workforce.
Thank you, Minister.
Minister, you've just talked about the myriad of ways you're trying to provide alternatives to emergency departments, urgent care centres, telehealth, pharmacies. You're now getting involved in an aged care strategy. What consideration have you given to supporting people to access their own regular GP out of hours and get that continuity of care?
Well, I mean, it's a very good question. I think one of the biggest problems with the health system at the moment, and one of the reasons, and I can't say that I've got this data, this is necessarily evidence-based, so I just want to be clear, but there is a growing work of knowledge that says the increase in Cat 2s and 3s, so those very unwell patients, can be linked to a failure for them to have regular interface with primary care. Now, I'm not going to say this empirically, and
it's all right, Minister. I would agree with you.
Yeah, I just don't want people to say, "Well, what's your evidence?" Well, I just haven't sought an article on that yet. I'm looking at that but when I look at the country and the challenges we're having in our health system, and when you have people with chronic conditions who present to our emergency departments sicker than what they probably should be, time and time again, it is because they don't have continuity of care with a regular GP. So that's obviously something that we discuss with the Commonwealth. They have made some big moves in relation to urgent care services, and we've acknowledged that, and that is important. We've done some things in regional and rural New South Wales, particularly around single employer models and the rural generalist model, where we've invested in that program to keep GPs in the area. But my strong view, and it's not buck passing because I'm caveating it by saying I don't have a journal article to prove it, but I do have a view that there has been a substantial increase in Cat 2s and 3s, around a 24% increase. Those people are not just coming sicker just because of age, but age is a variable, but they're also coming, in my view, and in some informed opinions of view, including people from the health department, that they are coming because they are not getting continuity and regular access to what you know as a practitioner as primary care.
Thanks, Minister. If I can come back to the secondary employment policy, because we were cut off earlier. This is something that was, I understand, previously attempted in 2024 and abandoned after pushback from the workforce through their unions. Why has this been brought back?
Fatima, is that all right if I...
As I mentioned the other day, secondary employment was captured as part of the existing Code of Conduct for New South Wales Health. We're in the process of reviewing the Code of Conduct and seeking feedback on that, and as part of that update, we found that we needed to provide more guidance in terms of secondary employment, so we're proposing a separate policy on secondary employment.
So if I can come back to the Minister,
Yes.
The two reasons I've heard from the department are managing conflicts of interest and fatigue. Surely those things can be managed directly through codes of conduct or fatigue policies. Why do you need to know whether a nurse is a member of a sport club?
Well, I don't know if we need to know the member sport club.
But Minister, with respect, that's what the policy is proposing, that a nurse would need sign-off every 12 months.
Ms. Gon, I just want to emphasise, remember, it is in draft, and the unions are being consulted on that draft. So I just want to make sure the committee understands this is not implemented policy yet. What I've got to get the balance of, because you would know, and perhaps you've even written to me about this, but certainly people in the committee have, and rightly so, there is a concern around fatigue on health staff at the moment, right? Unions will tell you that our staff are tired.
They came off the back of a 3-year COVID period, and then they've seen big increases in presentations. Okay, so I've got to also get the balance between saying, yes, of course, doctors and clinicians and other staff work in and around other facilities, etc. But I've also got to make sure they're well enough and not fatigued to be able to do their job on behalf of public patients. So,
Minister, junior doctors are asking for their unrostered overtime to be recognised under the fatigue policy. They're not asking for you to police their community engagements. Why won't you fix this through the fatigue policy?
Well, I'm not saying we can't fix things through the fatigue policy. I'm just saying we're out in consultation and draft at the moment, and it's not implemented. Some of those issues that doctors have spoken to me about, I've passed on to Fatima and her team. They have also, unions have also had the opportunity, and we will continue to engage with them. We want to get the balance right. And I just say to the workforce, I'm going to do my best as your minister to try and get the balance right for you, to make sure that I can meet their needs to be able to do what they do, which is often work in different environments as health professionals. I know that. You know that better than anyone, but I certainly know that. But at the same time, making sure that we are managing that workload in a way that keeps them safe and everyone safe. But it is a draft. I'll just emphasise that it's a draft. We'll continue to consult on that issue.
Thanks, Minister. I hope it's the last we see of that draft. If I can come back to the Calvary Mater Hospital.
Yes.
You made a comment this morning that this would be a matter, the future of the PPP would be a future cabinet process. When I asked the Premier about this last week, he said that it was a matter for you.
Yeah.
You've previously said about the Northern Beaches Hospital, quote, "We've worked with an urgency and speed to provide certainty for the community patients and staff." Now, I understand the complexity of actually ending the PPP, but why haven't you made a commitment to do so in the same way that you made that commitment to the Northern Beaches community?
Well, Northern Beaches, no, you know this, Chair, but I just want to make sure the millions of listeners also know this, that contract dealt with the operation of the hospital. This PPP deals with what I'd loosely call facilities management, facilities maintenance, etc. So just slightly different. So I just want to make sure people understand that. Calvary is not the problem up there, respectfully. They're trying to do a good job under difficult circumstances that we contract them to do. I am working through that process, and the Premier is right. It is ultimately up to me to bring forward for government consideration a pathway for resolution around that. What I'm saying to you at the moment is I can't say whether that pathway is one way or another because I haven't received that advice. When I do receive that advice, I'm going to be pretty clear to everybody. I'm going to take my time to go through it in the same way that I and the Treasurer took a pretty substantial amount of time to go through Northern Beaches Hospital and the way that was going to be done. Otherwise, we were starting at a process in first negotiations with Northern Beaches that was many more times the cost that we were able to acquire that hospital for. So I suppose what I'm asking the committee to do is not just simply let the private provider off the hook, not believe that you can purchase a hospital for $2 back.
Minister, with
that
respect,
would have been tens,
that's
if not
not
hundreds of
what
millions of
I've
dollars
ever
of
suggested,
liability.
Minister. You've put some words in my mouth. This committee made a clear recommendation that the Calvary Mater Hospital should be directly owned and managed by New South Wales Health.
I know that.
And that's an extraordinary recommendation because even members of the Liberal and National parties support that recommendation. And we both know that they're the first people to privatise public assets. So this is a hospital where even the Liberals and Nationals think this should be directly owned and managed by New South Wales Health, and you're hesitating to make a commitment considering all the options. How can you come back with any other option than direct public ownership and management as a Labor government?
I know, and this is an area that the Honourable Emily Savale and I have had a number of discussions around. This is not something that I have said I don't just wipe away, we're not going down that path. It's not that at all. what I'm saying to the committee is that I'm actively looking at this contract and around what we may or may not be able to do. But I'm also not going to do it without really clear information and advice, because I have a responsibility in two fronts: to provide healthcare services that are safe, efficient for staff and for visitors and for patients, but also I'm a part of this contract and I've got taxpayers' money as a Cabinet Minister to also be responsible for in terms of my fiscal responsibility. So I'm not going to let the provider off the hook. I didn't say that it was you, Miss Con, who said we can buy it for $2. Dr. Con, I didn't say it was you who we could provide it for $2. I'm saying that comment was made. That is not an accurate comment. I can't do that. That would have exposed us to tens, if not hundreds of millions of dollars of liability. And the way in which we worked through the Northern Beaches contract was as quickly as I can, as I'm doing with this, but I've got to do it in a methodical way, in a way that does achieves those two aims, continues to deliver good quality health services, as the team at Calvary continue to try and do in a difficult environment, and I want to acknowledge them on behalf of New South Wales Health, as is the Hunter New England Local Health District team that are embedded in there. But I've also got a responsibility around taxpayers' money, and those are the two things I'm working through with my team.
I'm out of time. I'll go to Ms. Finn.
Thanks, Chair. Minister, in questions that I put to the EPA this year about trying to get some results in terms of soil lead testing in Broken Hill, yes. I got back some information which was quite alarming about tests that had been undertaken at preschools, daycare or family daycare centres. I got back, and this has been reported in the media now, so I got back 19 tests, and there were 10 sites which were over the 300 milligram per kilogram level of investigation or threshold. One was up to 2,933. So 10 times, and there were a number that were over 1,000, 1,200. However, only 4 of those sites have been remediated because the property owner of those sites allowed it. The EPA says that the remaining sites haven't been remediated because the property owner didn't opt in for remediation works. Now, New South Wales...
You mean the owner of the property?
Yes,
Sorry,
the childcare centre, the owner of the property. We're talking childcare centres.
Yeah.
So I just wanted to see what role New South Wales Health plays here, and whether that is incredibly concerning. The fact that there are, parents sending kids to childcare centres in Broken Hill, and we know, we've got the facts here, that there's very high levels of lead in the soil that hasn't been remediated, and nothing's being done about it because the owner says no.
Yeah, I understand. I just want to make sure that Dr. Chant also can correct me if I've got any of this wrong here. So just to be transparent to the committee, I understand that we've made it pretty clear to the EPA that this needs to be addressed as a part of the work they're doing there. You would know, Kate, that the government broadly has provided, based on advocacy from locals, including yourself and others, but around about $37 million to what I call strengthen and expand its lead contamination response in that area. But Dr. Chan, is that accurate, what I described in terms of
Thurman, we were unaware of the results in the childcare centre. I read about it in the paper, immediately asked our teams to follow up with the EPA at the highest level. Clearly, these are sensitive settings, they need to be remediated, and we've asked to explore it with EPA whatever our powers, and want this resolved as quickly as possible. Clearly, childcare centres need to be safe places, and we need to resolve this issue. So I've asked the team, and they have reached out to EPA, and we've escalated that issue.
Thank you, Dr. Chan. That's very good to hear. So the
Shouldn't
EPA,
have got to that, probably,
the EPA did the testing very high levels of lead in soil that kids are playing in probably, but there was no requirement for them to notify New South Wales Health?
The only way, I mean, look, we would ideally have wanted notification and better communication, and I think there's some real opportunities coming with the additional enhancements that's been announced by government to really look at that information management across agencies that are working in this area to, do the best we can to improve the outcomes for the children. So look, yes, of course we would have wanted to know about this. I would have been exercised and extremely concerned about this issue. The team are following them, have already reached out and followed up. We will continue to watch this and look at whatever means we can to get that environment safe for children.
And is there going to be a protocol now? Clearly there does need to be something in place if it didn't occur automatically in terms of notifying New South Wales Health of these elevated levels.
Yes, certainly we have expressed our desire to know about these things, but I think there's also an opportunity coming out of the additional investment that government's put into to tackle this problem, to look at how we work across all of the agencies, so there's no critical pieces of information which are falling between the cracks.
Can I check with the 37.2 or something million? I can see that that's going to a range of agencies being coordinated via the Premier's department. Is there additional funding to New South Wales Health for any work on the ground?
So look, I would want to say that we resolved the funding ahead of the whole of government approach, thank you. And we've committed ongoing recurrent funding to Far West, ongoing recurrent funding for Marama, so in the past.
So the same, when you're saying ongoing recurrent?
Yes, and also we had an additional 120,000 recurrent that makes a whole total commitment to $1,049,740, which is recurrent funding, and there was also some one-off investment in some equipment to support the assessments. And we are looking at additional, with the Lead Smart program, what that might look like for additional investment.
Thank you. And with the Murray Mar, I know in the past that the EPA has given them additional funds, which they have put in a number of pitches for. So it doesn't sound like any additional funds come from that bucket for Murray Mar, or is that being funded by the EPA
so
again, for example?
we've taken over funding because our position was that we thought it was appropriate, given Murray Mar is a health entity. We already have existing relationship and existing funding. So when this issue arose around continuity funding, we wanted to jump in and make sure that Murray Mar knew that there was support.
Additional?
No,
or just the same?
It's the same level of money, appropriately escalated, but
Okay.
it will form within our grant structure that we already have to Murray Mar, and I want to acknowledge Murray Mar's commitment in this area and the fact that they are a key person that we need to work more effectively with in managing this issue.
Member Kate, you asked me at the last estimates about them going on a funding cliff.
Yes.
I'm not putting words in your mouth, but that's roughly what was happening. We just felt we didn't want to argy-bargy with EPA around this each time. It's a health service. We've got a lot of faith in it, and anyway.
It does make sense.
I won't take your time.
I don't know the detail, but I'll check in with them for sure. But that does sound promising. The pill testing.
Yeah.
The evaluation, firstly, has that? So I understand that's finished. Is it going to be released publicly?
Yeah, probably will be. Yeah, I'd say that type of report would be released publicly.
I think we've been on the record saying
we wouldn't have an issue. I'd probably want it to be released publicly because it was a pretty big. Well, for some people it was a big change in drug reform. Other people it wasn't a big change, but we think it was a pretty important one. Government is in the process. Haven't made an announcement around that yet, but looking at what the future of that is going to be based on that evaluation. Other than to say Kate, there will be some on both sides of this debate, some who would say that we should be doing more, some who should be saying we should never do this. The evaluation was important to try and give government advice around the impact that it had and the presentations made, and then what subsequently happened as a result. It was a pretty... I went to the first one at yours and ours at Wollongong, and it was pretty interesting thing to see public policy reform like that firsthand happening on the ground. So I'm very keen to have a look at to work through the evaluation, and then to say to government...
You've had the evaluation for a bit though, haven't you?
To say to government one way or another, and that hasn't been determined yet. Sorry.
So the evaluation, thank you, the evaluation was the one that you were mentioning at the last budget estimates, Dr. Chant, from the University of Sydney independent consortium, if you like, reviewing that. How much has the trial as well as the evaluation, have we got a figure on that?
Just under $1 million, I think.
I would have to. Sorry, it's
I've
probably
taken
in my
notice.
notice.
I've got a recollection from me that it's just under $1 million, but I just double.
We'll just double check
for the 12 festivals as well.
Yeah.
Okay, I'll just have the note here.
Nine something.
Yeah, that's what I think it is as well from me.
I think it's 9 something, but I don't want to.
There's an exact figure though. Thank you.
I'm pretty sure there is an exact figure. That's all.
Thank you. Are there any questions from the government?
Yes, Chair. Thank you. Minister, could you please provide an update for the committee on how the Minns Labor government is planning for the new South West Sydney Integrated Health Hub?
Yeah, so this committee, and you would know, Mr. Vale, as well as everybody, but certainly people from that part of Sydney would acknowledge that it is a very, very fast-growing area of New South Wales. I've had an opportunity to meet, well, probably goes back to when I was Shadow Minister, to be honest, with, at that time it was with the Mayor and Chief Executive of the Council, who were raising concerns around Wilton and that area growing very, very quickly, and an identification of where a hospital, or where a health service would go. Subsequently, when we came into government, the local MP, Judy Hannon, has been a really strong advocate alongside the council and the community broadly around making sure that we don't miss out on opportunities in relation to land to put a marker down for a future health service there. Now that is what we have announced we will be doing. It'll be a comprehensive, what we call an integrated health hub, but in plain English speak, that includes primary care. It includes the ability for us to carry out preventative care so that people don't have to go to, well, as of last week, it was the busiest hospital in New South Wales, and that's Campbelltown. It is consistently in the top 2 to 3 busiest hospitals in New South Wales, and therefore some of the busiest in the country. So we are investing in that area. The South West Sydney Local Health District, Sonia Marshall, has also been an incredible advocate for this, as have others in that community, and it is designed to provide the first step towards delivering health services. It's not necessarily they need a new hospital yet. That growth hasn't eventuated to that point, but they certainly need to have access to healthcare, often primary care, preventative care, as well as that early intervention, mums and bubs, drug and alcohol, that type of issue without being specific. So we think we are in the process around site selection that will then lead us to future investments into that facility, with land acquisition obviously being the critical first step in relation to that. But I've got to be honest, health services in South West Sydney are under record pressure. The hospital at Campbelltown is performing well and has been performing well. It's been straining a little bit in the last few weeks as we go through a flu season that's pretty demanding. They've been able to use their safe staffing and investment that the government made in many more additional nurses to reform the way they do their ED and change the way they do their ED. The gentleman there who runs that hospital and the Camden service, a very fine individual and healthcare professional, said that that investment in safe staffing plus the investment around what is paediatric short stay has made a big difference into taking pressure off that hospital and that ED. Now, equally though, they have got, I think, second in line in terms of the leaderboard, in terms of the most number of extended or long stay patients, aged care, NDIS patients in the system stuck at Southwest. So Sonia and the team are working really hard to move that. We hope that this investment into Wilton starts to bear fruit when we work through the process of construction and rolling out the service, but it is a system that is working well, but it is a system under great strain.
Thanks, Chair. If there are no further questions for the government, then we'll break for morning tea and we'll be back at 11:15. Thanks, everyone.
Thank you, Chair.
and we'll resume with questions from the opposition.
Thanks,
Mrs
Chair.
Mitchell.
Thank you. Minister, I want to take you to the issue of illegal tobacco, which is obviously something that I've raised with you before.
Yep.
I've had many members of the community still raising concerns about stores that are operating in their main streets, their shopping centres.
Yes.
Some have been reported multiple times to health yet remain open. Is there an average time frame for assessment of reports when people do them through, say, the website? How long between someone reporting them and when action should be taken?
Yeah, good question. I'll probably take that specific part on notice. Other than to say you're right, I probably don't go, I'll say maybe a few days without someone reporting, both in my own community as the local member, but also out and about. We're probably getting through on average between 17 to 20 closures a week. We're up to about 417 or so closures in totality. We've just introduced these landlord provisions as well. I met with the Federal Minister, Julian Hill, yesterday and just had a discussion with him around to acknowledge the support of the Commonwealth that they've provided with additional staff. We've probably got in the order of about 70 odd staff working on this, including working with New South Wales Police. But Ms Mitchell, this is a massive challenge, and I just this is going to be a lot to work through. We've also got the added challenges, as you know, of we don't feel the excise arrangements that are in place at the moment are helping. No, I know that was. I just want to.
Yeah. So I mean, and I also will acknowledge that the work that health officials are doing on this and the teams on the ground, and there's bipartisan support for that.
A lot more to do, but
I have an example, and I might give it to you or some of your officials offline, of one that was reported 4 times in 2 weeks and it's still open. So those sort of frustrations in the community, and I won't publicly, but I'll share it with you.
That's frustrating.
Privately. Is there a backlog in the number that are reported and the time to be able to go and open? I do see Dr. Chant nodding, so I don't want to, just for Hansard's benefit, but there's more being reported than you can get to at this point.
There's so many of these, and the problem is, even when they're not in an identifiable, say, tobacconist or whatever, if it's in a service station like the ones recently that were raided, they're engaged in lawful activities. So to try and say there's X number of these would be difficult, because you're likely not to get the barber, the service station owner, the other outlet that is doing this on the side. So there's a lot of these across New South Wales. Our reforms that receive bipartisan support have made a difference, but we've got a long way to go, and we would argue, and are going to continue to argue, that excise plays a role in that because of the distortion of the market. That's all.
So with the challenges of tracking how many there are, and I guess that sort of backlog of the ones that just keep popping up, how are you measuring, or I guess what sort of performance measures or targets can you put in about whether or not some of the reforms in place have been successful? How are we tracking that this is working?
Dr. Chen, do you want to just that operation?
Perhaps just to express that we've probably got 2 operational platforms. We've targeted a lot of mixed-use tobacconists, because we feel that will only require a slight nudge to get for that group of people to exit the industry, because they've got a sustainability from selling others. So you've probably seen there's been a big focus on petrol stations and convenience stores. The landlord provisions have also very much assisted us, and thank Parliament for passing those. We also have to prioritise work across government agencies, and sometimes that work is not visible, and that's part of the national disruption, where we work with all of the different agencies at a national level, ABF, ATO, ASIC, and we share a lot of intelligence and work with police locally. So there will be some issues where we're going after some of the larger scale criminal networks, of which we've got the front end shop front pace, and our other partners have got some of the other areas. So I do acknowledge that the community will be making reports. Please continue to do so. our staff are working really, really hard on the ground. And we're pleased to see some additional investment from the Commonwealth, which will allow us to increase resources in this area. But there is just quite a head of steam of the diffuse nature of this, and we're going to have to tackle it. And it's going to require coordination across all levels of government.
So, and I'm happy if you need to take this on notice, Minister, but I'm wondering if you have any data on, because you would hear as I do, shops that are closed and then the next day they tend to reopen. So not always, but then they seem to be operating again. Do you have any data on how many of these premises have received a short-term closure order and then subsequently have been reopened and kind of pinged again, for lack of a better phrase, for reselling illegal tobacco? If you can provide that on notice, that would be
I
great
think
if
I'd be
you've
able
got that
to.
data.
I think I'd be able to get access to that data.
And maybe where they're located as best you can. Again, on notice, that would be.
It is an issue.
It is.
Because I don't want to identify an area, but we have had people, despite the closure orders come in place, despite their doors shutting, then they will also change their business model, and I'm making this up because I don't want to indicate what that is, but they'll go behind the shop and start selling out the back of a shop, not inside the shop, but they'll identify to their customers another area to which to pick. So, I mean, it's
complex.
It's trying to keep up with the criminal element, I suppose.
I want to move now to the issue of the core pulse defibrillators in the ambulances. Now, again, quite a bit of public commentary about this in recent weeks, and my recollection is that I think you made some comments that you were going to seek some more information from the TGA about what they had actually determined. There's obviously a lot of concerns coming to us from frontline paramedics about
100%.
the issues that they're having with these devices. Do you have any more information from the TGA that you can provide?
It's a very good and appropriate question, given what we're dealing with at the moment. I've had a meeting with a number of groups. I met with the TGA. I've met with Core Pulse itself. I've also met with paramedics, and obviously I've met with Mr. Michael Nicol from the Clinical Excellence Commission and the Acting Commissioner Claire Beach from Ambulance. The meeting with the TGA, they reiterated to me that this is not about recall or anything like that yet. This is essentially to provide time for Core Pulse to be able to make the rectifications that they need to make to the system. One of the things I'm concerned about in a discussion that I had recently with paramedics was that there is, for them, a number of issues. Some of them, Ms. Mitchell, are the leads and the lead length of the device, which is a bit problematic as they see. Some of them were talking to me about the location of that within the truck is a bit of a challenge, and then some talked to me about making sure that it did what it meant to do. So what we've got to try and balance, and I think these devices came in, others would tell me if I'm wrong on this, about 2022. We're just having a look at the contract in relation to enforceability, and I've had a discussion with HealthShare about that, and I think eHealth have a role to play in that. We've set up an incident management team where paramedics are able to report stuff through. We will make it, and we've made it clear to TGA that we expect them to keep us abreast of what's happening. The Secretary also met with the TGA in addition to a meeting that I had and a separate meeting my actual staff had. So we've had a number of engagements with them. There is a software rollout that is around about 58, I think, %. I'll just get that corrected. 58% completed at the moment, and we're working through some of those other concerns that paramedics had raised directly with me, and no doubt through that. But Commissioner Beach,
I might come back to a bit more detail with the Acting Commissioner in the afternoon. I just wanted to, just one more on this though, Minister. I've also heard comments about the leads, but more concerningly, I've had several frontline paramedics share instances of basically the device switching off in the middle of a resus. And I know the TGA reported, I think there were 117 adverse events linked to these devices, including 31 injuries, 5 deaths, and more than 20 instances of the devices refusing to shock patients. Do you know how many of those are, had reported to have occurred in New South Wales?
I spoke to Mr. Nicol about this and Miss Beach around this, and just want to get this accurate. We have had a total of around about, this number I'll get as close as I can, but 540 odd incidents. None of ours have led to what I'd call serious harm. That's around about from 540 incidents from about 2 million uses in total, but I don't want people to think that just because our investigations hasn't led it to think that a serious harm is not an issue. I don't want people to think that. I'm not saying that, but in answer to your question, of those incidents that we've looked at, the 540 from New South Wales, out of 2 million odd, the 2 million uses, that we haven't identified serious harm causation as a result of that.
Okay. I'm just conscious of time.
I'm just double checking that I hadn't misled. That's all.
I think there's a bit more with this, but I'll hand over to my colleague.
Yep.
Just back to pill testing, Minister. When will there be a decision from New South Wales Health as to whether that's going to be pursued permanently or not?
I would put that in the category of soon.
Soon before Christmas or soon before September?
I think soon. No. Soon before.
Soon before last sitting of Parliament in November.
Soon before the end of the year. Soon before Santa comes down. I'm not sure.
Soon before the Easter Bunny.
Well before the Easter Bunny, Miss Carter. Well before.
Will there be drug checking at music festivals in the summer music festival season?
Well, that will form, obviously, that decision from government will be informed one way or another to the community, other than to say that government knows it's in the final throes of making decisions around this. I just want to make sure everyone's across the evaluation report. I want to thank New South Wales Health. It's not an easy thing to do.
And you've committed that evaluation report will be public, I believe.
Yeah.
Excellent. Great. Minister, this is the last year of the world-class end-of-life funding. Will you be continuing this support for the dying?
Well, we will, as I think every government would, continue to invest heavily into palliative care. I know from your perspective, and I know also Mr. Donnelly has a very keen interest in this, as does other members of the committee.
I think everyone who cares for the dying has an interest in this issue, Minister.
I was going to say, just as have broadly members of this Parliament and certainly our health service staff and the community.
So do I read that as a commitment that you will be continuing the world-class end-of-life funding?
Yeah, we're going. I can't put a figure on it other than to say that we are investing around 400 it's close to 450. I think it might be about 447, but I'll stand corrected.
Can you give me those exact figures?
About 447 on palliative care in total.
Sorry. There's the two different buckets of funding for palliative care. The world-class end-of-life funding, will that continue after this year?
Yeah. I'm just trying to say, yes, it is. I just tried to say what we've allocated in totality around it. I think the former government in its final year was about, again,
actually, can I ask you for
389, and I think we're about 447.
But over what period?
Over the next 4 years. Over the period of...
And can I ask you what was allocated and spent on palliative care last financial year?
I think it was in the order of about somewhere between...
I'd really love an exact figure, so I'm happy for you to take that on notice.
I will.
Perhaps
I don't
Mr.
want you to
D'Amato
think
can give us that this afternoon, or unless you have it at your fingertips now.
Last financial year is still to be finalised through audit, but our estimate is around 447 million.
447 million over the last financial year.
That's
and
right.
What's been allocated to palliative care in this year's budget?
In this year's budget, I don't have the amount allocated this year, but is more than that, given there will be escalated for...
If you could get it for me this afternoon, I'd be very grateful. Thank you. Minister, we know that there were significant funding cuts to palliative care in your first year of government, and we're now hearing from stakeholders who are palliative care service providers that when they are submitting funding proposals, they are consistently being knocked back. Is this yet another funding cut for palliative care?
Well, do you have documentation of people who've been knocked back, or just
I
so that I can give context?
I have letters here from people and from Palliative Care New South Wales that are very concerned that as part of the changes made in your first year of government, they're all required to resubmit business cases, and they are consistently being knocked back for this financial year. Why?
Okay, I'm happy to look at the Coro, other than...
Okay.
So that's never a problem, Ms Carter, but other than to say that I think this government and the previous government have done and should make significant investments in palliative care. I don't think anyone is trying to say that the former government didn't do a substantial amount. I've never said that. I think they did. I know it was something very important to the former Premier, and it's important to this government as well.
Thank you.
We've obviously invested around about, I'll stand corrected on this figure, but about $93 million into capital around a range of expanding...
That was the figure that was provided for in the world-class end-of-life funding for capital, absolutely.
I know.
So thank you.
No.
Minister, you would know that the Commonwealth funding for the joint Commonwealth State Initiative Palliative Care and Aged Care stopped as at June 30. Will the state be continuing its funding for this program?
Kerry, do you...
It's Elizabeth.
Maybe Elizabeth...
I think I can answer that, Ms Carter. We're still having a lot of conversations with the Commonwealth about some of those services. The Commonwealth make decisions in terms of where their funding will be allocated each year.
Ms Wood, as I understand, it was joint Commonwealth state funding, and the Commonwealth have clearly said their funding's stopping, or the state be continuing the funding they were providing.
Yeah, we're still discussing that with them, Ms Carter, so we have a regular dialogue with the Commonwealth on this.
But if the Commonwealth has decided they've stopped, what is there to discuss other than what the state's position is on continuing funding?
Well, we continue to discuss it with them because it is an important service. So in the absence of that, what we are doing is looking at all of our services for older people. As Minister Park mentioned, we have a significant number in our hospitals at the moment, and we're looking at outreach services.
Sorry, Ms Wood, but older
care.
people and the dying are not subsets
No,
of each
they're
other
not.
necessarily.
No one is assessing that.
Commonwealth funding stopped on June 30. This is now, 27th of August. Is there state funding today for delivery of palliative care into aged care homes?
We do provide those services now.
Yeah, so it's continuing then?
We provide those services now.
And it's going to continue?
As much as we would like to, yes.
Great, perhaps we can come back this afternoon and
You also
look at
raised,
the
I
details.
think, Ms Carter, last estimates, I think, around the paediatric hospice issue, and we are obviously working with that foundation,
Great,
Ryan
thank
Carr and
you.
his team, around the development of that out at Westmead. Just as a very
Thank
quick anecdote to one of the questions I think you raised, I
Thank
think
you.
at the last estimates or maybe the one before.
Thank you very much. Minister, we've previously talked about the work done by Health in relation to a policy concerning conscientious objection, and as of July this year I understand that there is a new policy directive, and it indicates at 1.1 that the policy is in accordance with the Abortion Law Reform Act. Why then does it purport to limit the provisions of Section 9 of that Act?
This is in relation to abortion, sorry?
Yeah,
I just want to make sure.
Yeah.
I know this is an area that's very sensitive and very important to people, so I just appreciate if the committee engages in with this the way that we always have.
Yep,
so
absolutely.
Just to be important, and I do acknowledge that people have different views, both within my own government and
why does the policy
across them.
purport to limit the reach of Section 9 of the Act?
Yeah.
The Honourable Susan Carter has interrupted witnesses now several times. The Minister has just said that this is a very sensitive issue and he'd appreciate the courtesy of the committee and the member asking the question. So I just think the persistent interruptions, particularly around a question and answer such as this,
Yeah, look, to the point of order, I think I've lost count of the number of times I've made a similar ruling. I appreciate members do sometimes want to interrupt, particularly in the interest of time, but let's let the Minister get a couple of sentences out first.
I'll go through as quick as I can. I just wanted to give that context. We completed a review in July, and I know a number of people, including members of this committee, had a keen interest in that.
that implementation is now underway. It provides guidance on the roles and responsibilities of New South Wales Health and our staff. It clarifies, Ms Carter, provisions for conscientious objection for registered health practitioners in line with the Act, and my expectation...
Excuse me, Minister, but it actually limits the reach of Section 9 of the Act. How can an executive policy limit legislation?
Well, my expectation is implementation is in line with that, but we do have to make sure, and Parliament has made a decision that this healthcare is important, and we as a health system need to make sure that it is accessible to women right across New South Wales.
I have further questions, but I have no time.
Yes.
Thank you. Minister, firstly to the question of the core pulse defibrillators.
Core pulse, yes.
It's my understanding that that contract is supposed to continue for the next 6 years, after which time there'll be another tender. Why wouldn't you bring that tender process forward, particularly when there's the risk that there's currently no other replacement or substitute devices? It's my understanding that the old life packs are no longer around to provide a substitute. In the event that the TGA progresses to recall these devices, surely you want to be ahead of that process.
Yeah. So, a couple of things on that. The TGA is not giving any inclination that there's going to be a recall. Now, I'm not Nostradamus, I can't predict what may or may not happen in the future. But as we sit here and having direct engagements with me in the room, and the Secretary also having those direct engagements, and no doubt as ambulance at different levels, that's not where we're at. That doesn't mean, though, that I am not concerned about the issues raised by paramedics. It also doesn't mean that I'm not going to have a look at the contract and what options there are for us to exercise, because I feel as a responsible person for taxpayers' money that when a company goes into contract with us and we provide them with taxpayers' money, then they have to provide a service that meets that. I'm concerned that a number of paramedics have said to me that the device is not doing that. Now, just got to get clarification on all of this, just to be clear. There is no talk about removing these devices. They are continuing to going to be used. But I don't want that to be seen as, well, you're ignoring paramedics on the ground who are saying there's issues.
Yeah, Minister, to be clear, I'm not asking you to remove them, and there's obviously no replacement at the moment. No. I'm asking about actually getting ahead. I imagine that if you were to seek a new tender with a new company earlier than 6 years, that's a process that would take some time.
Yeah.
Why wouldn't you get ahead of that process to actually get an alternative available in the event that you are required to remove them?
Yes, Susan, did you want to...
Hi, Dr. Con. I'm happy to comment on that. We are absolutely doing contingency planning work to your exact point, as you would expect us to. Whilst, as the Minister said, there is the TGA have indicated, and they've published this, that the devices are able to continue to be used while they're reviewing the situation, and we are engaging fulsomely with them on this. We are in the background doing contingency planning work in the event that they make a decision that's unexpected at this point. So we are currently doing that.
Thank you. I'll come back to you in the afternoon to understand more detail about that. Minister, on a different topic relating to abortion access.
Oh, yeah.
Earlier this year, you said you were interested in making sure that accessibility is as good as it can be and is close to where women are located as we possibly can. Is accessibility as good as it can be when the newly updated Termination of Pregnancy Directive stops short of actually requiring public hospitals to provide abortion care?
I think it is, because the bulk of these procedures are done outside of a hospital. So I just want to say that from the get-go. I do believe that we have made this service. It's not necessarily 100% yet. So I don't want the committee to take that. But I think with the changes that the Parliament made and to take this out of the criminal code, then the work that we are doing around that policy and around the rollout of support for those women seeking termination, I think we are doing a strong effort to try and make that as accessible as possible. But I don't think in the state, the size and breadth of New South Wales, that you could ever, as a health minister, say that you are meeting the needs of every woman seeking to access this type of service necessarily as close to where they live. There is always going to be people who will have to travel some distances just because of the nature of the procedure and the length and breadth of this state. So I think we've made improvements. I would argue that we will need to, and future governments would need to continue to focus on this so that women do have access to safe and accessible termination services. I think that'll be something
Minister,
that
you've
is
said
an
that
evolving piece of work.
Yeah. You said the bulk of the procedures are done outside of hospital currently, and my understanding is that's because many abortions are provided through medical abortion, prescription of tablets rather than surgical. But that's also the case because most public hospitals in New South Wales are not providing abortion care. People are having to go to the private sector or travel because this isn't available at their local public hospital. This committee's previously been told that there are 40 New South Wales health sites that provide abortion services. This figure includes sites that only provide abortion in limited circumstances or where that service is inconsistent. Even so, that figure of 40 sites is a significant minority of public hospitals in New South Wales. Do you accept that there's a need to expand particularly surgical abortion provision in public hospitals?
Yeah, I mean, you're right around the difference between surgical and the medical, and the bulk of which are medical. You're also right in saying that, not saying, you didn't say this, but you're also right in a view that says governments are going to have to continue to look at where there are gaps, trying to close their gaps as best they can. We've been able to provide continuation with the Pregnancy Choices Helpline that you and others know a lot about, and Search. That's the project with Family Planning Australia to improve access to this health service. In addition to that, Women's Health New South Wales, I think is the organisation, they were awarded a grant of around $2 million to support women to access safe and low or no-cost abortion care as well. So I suppose I just say that to indicate to the committee that we are continuing to work on this. We're not saying job done, but equally it's an evolving piece of healthcare provision for us given the changes made by the Parliament.
Minister, the Family Planning and Women's Health New South Wales are both terrific organisations. Certainly in rural and regional areas, for some patients there may well be stigma in accessing a specialised service, despite the excellent work of those organisations. And for some people, their preference will be to attend a public hospital where that can be done more anonymously in a small community.
Yeah, I understand that. I'm just trying to make sure that that's a real issue for women, and women have talked to me about in small, rural and remote communities that is a challenge, so I don't want people to think I'm ignoring it. I've just got to get the balance right in terms of where we put our resources and how we do these and how we support those within the sector who are already providing what I think by and large, are very, very good services, including some of the ones that you mentioned. So we're not where you would like us to be at the moment on this. So I understand that. It's an evolving piece of healthcare provision for us as we move this piece of legislation, as the Parliament has moved this piece of legislation out of the criminal code and taken that out.
Minister, to be clear, it's not just where I think things should be. There was a representative survey commissioned by Australian Clinicians for Choice in 2023, the year that you became Health Minister, which found that 68% of New South Wales residents believe that every public hospital that delivers women's health services should also provide abortions. That included not just a majority of Labor voters, actually a majority of coalition voters. So, you're talking about getting the balance right. Do you accept that the current balance where the majority of public hospitals don't provide any abortion care is actually really out of keeping with community expectation?
And my probably answer would be that, as I've said, I think this is an evolving piece of work that we will, as a government, and no doubt the next government will have to continue to focus on to meet the needs of the community, but most importantly meet the needs of women. I think we're making some strong inroads into that and accessibility, but I don't think the job is done in relation to that. The role in which public hospitals play in this space, in terms of the mass provision of it through that, is not something that we have landed on yet, so I don't want to pretend to the committee that we have, but we are supporting those organisations like the one that you referenced to make sure that this is as accessible as possible. Like many things in healthcare, is there more work to do on it? Of course there is, yeah.
Last question from me, Minister, before I go to my colleague. Coming back to the questions asked this morning about the ability of health workers to advocate for their workplace and for patient safety, if this committee were to inquire into the ability of staff to raise issues about their workplace and the health system, would you support New South Wales health employees to be able to participate in that inquiry without repercussion?
Yeah, the Secretary was clear in her comments during the first year of our term of Parliament, when people wanting to give evidence to the Special Commission of Inquiry, that she would support them in every way, shape or form. I've never been one who would want to stop clinicians, just as long as they do that in a right and respectful way. They've got to also remember, sometimes, Dr. Con, this is clinicians attacking other clinicians, and I've just got to be mindful of that from a workforce perspective. But no, they would not be prohibited from speaking to you or committee members around suggestions around cultural improvement.
Thank you. I'm glad to hear that. Ms Boyd.
Thank you, Chair, and good morning.
Morning, Ms Boyd.
Thank you. Look, the media has been awash with stories of sexual violence in the last couple of weeks. We tend to get these kind of peaks and troughs of interest in this topic. When I asked you back in March whether the government would extend funding for the New South Wales Sexual Violence Helpline, you took it on notice. You then answered saying that the grant was being renegotiated for renewal. That was 5 months ago, and I understand that the government's previous election commitment to supplementary funding that keeps that line open 24 hours a day will lapse on the 30th of June 2027. Will you commit to include that uplifted funding to ensure that we have a safe 24-hour helpline?
Yeah, so I just want to be clear, Ms Boyd, this is the work that Full Stop do? Yeah. So Full Stop Australia, as certainly Ms Boyd knows, but committee members may know, they operate our sexual violence helpline, which offers around-the-clock trauma specialist counselling and practical support for anyone who's been impacted by that horrendous and terrible crime of sexual violence, sexual assault. The election commitment funding enhancement of approximately about $958,000 per year for 4 years, and another year of funding remains on that commitment. We've, not me, but my office recently met with the CEO, Karen Bevan, from memory, last month. Health is now working with DCJ on the details of a long-term contract with that, and we are in discussions with Minister Harrison about that, who also meets them regularly. So we are working with DCJ, or cross-government, however term you want to put, as well as through Full Stop around the continuation of that. Is that a...
Thank you.
Yeah, good,
I mean, I guess it's coming up quickly now, the end of the this financial year. When will the service likely have an answer as to what their future will look like?
I'd want to do that sooner rather than later. I don't want to put a direct date on it, just because I know discussions are with another government agency, other than to say that you have, and I want the committee to know that they have my full commitment to work through this issue. I know the work that Full Stop do was something I'll treasure, being able to provide them that election commitment, because I got to know their work and what they'd done pretty
incredible.
clearly, and they do great work for people who are having the absolute worst day of their life.
Yeah, exactly. Thank you, Minister. Turning to something different. Minister, are you aware of the enhanced obligations imposed on PCBUs as a result of changes to the Work Health and Safety Act that came into force on the 1st of July this year? Specifically, Section 26A, which imposes mandatory compliance with approved codes of practice.
I think I'm going to have to throw to Fatima. Sorry, Ms. Boyd, on that one.
That's all right. It's probably a bit of an ask to be to have in your head particular sections of an act, but I'm interested in which approved codes of practice apply for health workers.
Can I take that on notice and come back to you today? Yeah.
So from the 1st of July, my understanding is that all health facilities would be required to comply with the minimum standards imposed by those codes. And one of those codes is managing the risk of fatigue at work, and another is healthcare and social assistance industry code of practice. And the only way that you could then deviate from the code is if, in doing so, it would provide an equivalent or higher standard of work health and safety than the standard required by the code. That's correct. Yes. So the fatigue code identifies less than 12 hours between shifts as a hazard and says rosters should not provide less than 12 hours. But New South Wales health policy permits 10 hours for doctors in training and proposes 10 hours in the new medical award.
That's correct.
How do those two things equal?
Yeah, we are working through an analysis at the moment about the new obligations under the Act, and my team is doing that across the system. As you know, obligations within the award need to be met across the workforce, but we are doing some policy work to make sure that we're not in breach of the legislation, so we'll continue to work with the relevant unions on those award provisions.
So I understand that at the moment there's no minimum breaks or maximum hours for staff specialists at all. Is that correct?
That is correct. However, we are working through a range of provisions. We have a fatigue management committee that is looking at these provisions.
The fatigue code says a worker is at work whenever they're doing work for the PCBU, even outside paid hours, and says employers should monitor the actual time worked against the roster. Does New South Wales Health record the actual hours worked by staff specialists?
Broadly, yes, we do, yeah.
Okay, so you will then have the sort of actual hours data to look at in working out whether there is compliance then with the code?
Yes, I mean, look, generally there will be some issues around the adequacy of a break and what is deemed to be a break, and if someone is undertaking unrostered work, then we are trying to implement systems to be able to record that, particularly for junior medical officers, for example. We require them to report on unrostered hours, specifically for this issue, so that we can manage fatigue.
Okay, so you can assure the committee then that fatigue risk across the statewide medical workforce is controlled and monitored?
It is a work in progress. We are still doing some work on this area. I don't think I would sit here and say we've done everything that we need to do. It is an ongoing issue, but I can assure the committee that it is a significant focus, not just for the ministry, but for the chief executives who also have PCBU obligations.
Okay, thank you. I might come back this afternoon.
Minister, in 2024 you made a very welcome commitment to bring management of temporary health workers in-house. This was a recommendation of the Garling report back in 2008. It was reiterated by the Special Commission of Inquiry. Since then, the expenditure on locum agencies has only gone up. So in 22-23 it was 37 million, 23-24 43.8 million, 24-25 87.3 million. Why do you think it is that clinicians are reluctant to accept permanent roles and you continue to be so reliant on locum agencies?
I think we're always given the breadth of health services that we provide across New South Wales. Locum services will always be a part of the labour mix that we have. We've been able to commit in the latest budget, I think, around about $6.3 million to examine the feasibility of providing on an alternative sourcing model for locum doctors to reduce our reliance as a health agency on external medical locum agencies, and importantly for me, reduce spending on agency fees and therefore bring that money back into local health districts to provide frontline healthcare services. So we are well in train around doing that. As I said, we're looking at that alternative sourcing model. The statewide locum bank, as we're loosely calling it, will be launched in fin year 27-28 under the name, I didn't make up this name, but I think it's called Health Flex. Anyway, someone did, but not me. And that'll initially support the sourcing of non-specialist locums for the system, as it's designed to do and as has been the challenge. That'll extend its services to support sourcing specialist locums in the system the following year, 28-29. But this is a pretty big piece of work that we're doing, all designed to reduce the financial burden of it, still acknowledging that locums are playing an important role in our labour force mix, but trying to generate savings, and when I say savings, money that can be directed back into New South Wales Health Frontline Services.
There obviously will always be a need for locums in appropriate circumstances, like people taking appropriate leave, natural disasters, etc. I hope you'd agree that at the moment not all locums are in those what I would call appropriate circumstances. There are many positions across the state, I would imagine, in every local health district that are being filled by locums simply because you can't recruit permanent staff. Are these gaps something that this new agency will be looking at as a priority?
Yeah, 100%. We want to make sure that where possible we're using our staff, and because that is an expensive form of labour. That's the reality of it. Necessary, as you know, Dr. Con, professionally, but as you know from your advocacy as well on behalf of people and LHDs, particularly in rural and regional areas in this space. One of the reasons why we've invested heavily into workforce incentives is to try and increase our staff, particularly in regional and rural areas. We're making some inroads, not case closed, but we're making pretty significant inroads in attracting and retaining healthcare staff coming off a challenging base coming out of COVID.
We're in opposition time.
It's quite a good segue, because I also want to talk about locums. We didn't plan that, but funnily enough, it's the topic that is of interest to us as well. You actually just said, I think, Minister, that obviously you've acknowledged that locums are an expensive form of labour.
Yep.
I want to get an understanding of what the total spend was on locum doctors in rural and regional hospitals in the last financial year. Are you able to tell me that?
Geez, Alpha might be able to, but
the split to regional, we don't have it.
Okay, let me take it on notice.
Okay. And can I ask, one of my colleagues, the member for Northern Tablelands, actually put a question on notice to you, wanting a breakdown for his hospitals, what the spend was, and with respect, the answer back was a bit vague and didn't actually give that figure. But is it possible to get, and I'm happy if it's on notice, but for specific hospitals, a breakdown of the locum spend?
Yeah, I could have a look at what we're doing in relation to locums. Just I'm not 100% sure how it's broken down, so I just want to. I don't want to say I can do something.
I can have what I can get for rural and regional on notice, and then also specific spends for Armidale, Glen Innes, Inverell and Moree, if that's possible, Minister, that would be great.
Yeah.
Okay, thank you. The other concern that I've had raised with me with local GPs from a number of health districts in regional and rural New South Wales is a concern about them only being offered potential VMO shifts at the hospital after a locum has already been, or an agency's already been engaged. So effectively the offer goes to the locums first before the local GPs with VMO rights. Has that been raised with you as well?
Oh, it could have. I mean, the issue of locums.
Does that seem a bit backward to you, that you wouldn't be offering the local GPs that opportunity first?
I'd need to have a look at the specific circumstances as to why. So I don't want to comment. We obviously don't use locums as our first point of call. We would want to be trying to recruit to positions. Sometimes
for a range of different reasons, we can't do that, which is why we have incentives and other things in place. But Fatima, is there anything you wanted to add to that?
I'm not aware of that being raised as an issue, but
Okay.
as the Minister said, we would normally try and prioritise existing contracts.
It was literally 2 days ago I had someone raise with me that anyway, I don't want to go into their specifics, but
No, I don't.
sort of the roster for the month gets offered to the locums first before the local GPs, and that I think adds to some frustration. But if you could provide some advice into that would be good. I want to just take you to a couple of issues in rural and regional areas, Minister.
Sure.
Moree, we've spoken about it before. Some real concerns still about the issues of only having telehealth available. I appreciate telehealth has a role to play, but I think for most of us in the country, we'd like it to be a complement to real doctors, not a replacement. Do you have any data on how many times Moree Emergency in particular, the hospital ED, has only had a telehealth doctor available in the last 12 months?
No, I don't, but the local member has talked to me about this, and I just want to acknowledge he has raised this in correspondence with me there. I think it's important to note that we don't view, and I don't want the community to view telehealth or my emergency doctor as a substandard. They're dealing with getting access to very specialised clinicians through a camera and working with staff on the ground. Ideally, it's always great if you have your own staff in every facility to meet every vacancy, but there are times, and many times, in a big system like ours, where LHDs are out there advertising and doing everything they can to try and source doctors, in this case doctors, but sometimes it's nurses, healthcare professionals, and they don't have that. Now, we don't want to get into a situation where we shut down a service because of that. So in relation to Moree specific, I know that a qualified nurse prac is working full-time in Moree ED, and we have had additional nursing staff rostered in that, including the nursing unit, and the manager at the moment is working clinically to support that team up there, and we do have at Moree on-site surgical anaesthetic and obstetric coverage remains available for those more significant emergencies at that hospital. That doesn't mean that I don't think workforce at Moree is a challenge. I do think it's a challenge, but I don't want the committee to think that not we as a government, attack us as a government, but the local health district is not doing what it can to try and recruit to that.
And I appreciate that, Minister, but I guess with respect, and I could give you a number of stories that have been raised with me for local hospitals of people waiting hours for care, kids with broken bones sitting in emergency. In Moree particularly, there's one that's been raised with me where a mother took her teenage son. He had a hand and a finger injury. There was no doctor at Moree Hospital. They had a video call, but there was no referral. There was no transport available to Tamworth. So she drove her son to Toowoomba, got a referral through Toowoomba ED. Her son ended up needing to see a hand specialist, 25 stitches and nerve repair. So it was a pretty serious incident. I appreciate what you're saying about workforce challenges, but to that mother of a teenage boy who had to literally get in the car and drive him to Toowoomba into another state to get the level of care that she needed, that's not an ideal circumstance. So what would you say to those families? And I could give you 1,000 stories like that from all over the state. This is the day-to-day that people are experiencing in the regions, and we don't think it's good enough.
Yep. I could also give you day-to-day experiences of people who get a really great service from people in regional and rural healthcare and remote healthcare, so I've got those as well. That doesn't mean the fact that I'm ignoring that there aren't challenges in rural and regional and remote healthcare. One of the reasons why I wanted to keep that portfolio under me is because I'm very passionate about it. We've got a really good leader in Luke Sloan who works really closely with chief executives in those rural and regional areas. We are doing what we can to improve rural and regional health. I'm happy to look at any of those instances. You are right. That's not something that we would want to see happen. I don't think I can ever be accused of saying there's not challenges in rural and regional health. There are. We've been able to increase that workforce by about 5,000 or about 9.9% since 2023. So that's a substantial increase in rural and regional healthcare workers under our government. Doesn't mean there's not more work to do, there is, but that is a substantial increase that we hope has gone some way in addressing some of those challenges, but we are not pretending that there aren't from time to time issues like the one you said, and when people don't experience the healthcare system in a way that meets their needs, we always regret that. That's not something that we want. We strive to try and meet people's needs every day, but when you're seeing upwards of anywhere between 8 to 10,000 people through emergency departments across New South Wales every day, from time to time there are going to be people that we don't meet their needs. And whilst we're apologetic, it doesn't mean that we don't recognise it and doesn't mean we don't focus on it.
Another issue which I know you'd be familiar with, particularly because of the advocacy of the member for Mile Lakes, Tanya Thompson, but I wanted to ask you why there's been no visible progress or timeline announced for the Foster Tuncurry Health Facility component. I know that the member has met with you about it recently, but still concerns that there's no transparency or public update on the status of that particular hospital. What's going on?
She has met with me recently. I think she would probably have met with me actually in the last probably few weeks, and I have met with her in the past around this. I can say that we are in the final stages of discussions with a provider around the foster urgent care service, for want of a better term. And I won't make an announcement today, but Ms Thompson will, I can assure her, will know about it sooner rather than later. It is being finalised, so it is in the final.
So when you say being the planning for it, or what are you able to share?
No, in the provision of that service, and how it's going to roll out. We just haven't announced that contract and that yet. So I just can't be in a position today to say it, other than to say we're in the final stages. We know it's important to the community. I think that the member would also need to acknowledge that there was no funding provided by the last government. It was simply a commitment. We've had to find that for that service, and we will be very soon in a position to discuss it.
Okay, well, the community is waiting with bated breath, Minister, so hopefully that can happen soon. Can you tell me the status of the 2023 Lake Cargelligo MPS Health Service Plan now?
The Lake Cargelligo MPS, I think from memory you've got a call for papers about this.
There was a clinical services plan completed in July 2023, and the community hasn't had any updates or feedback on what's happened with that since, and they've asked me to ask you.
I think I do have something. I might just throw, Luke, is it yours? I might just throw to you, other than I'm just not 100% sure I've got the latest info on that.
So thanks, Mr Mitchell. So yes, you're right, the clinical services plan was finalised in 2023. It had identified the need to expand the residential beds, which we've seen in a couple of our MPSs across the state, just noting that expansion of residential beds is pales in comparison to the overall residential aged care bed platform in New South Wales. It's also co-led by the Commonwealth. It remains a priority for the district at the moment under their asset management plan, with the planning and documentation reviewed and submitted annually through to New South Wales Health, and then we're prioritising it. So with regards to the ongoing engagement with the community, with regards to feedback, I know there's an advocacy group in the community which we're just working with the district at the moment to make sure that they do get that feedback about where it's up to. And we're recognising the fact that there is a need, but we do have several sites across New South Wales where we've got similar or otherwise need that we have to work through from a prioritisation point of view, with not only health infrastructure, with our Commonwealth colleagues.
Thank you. Minister, in Scone, the only local GP obstetrician is due to retire at the end of this year. What plans are in place to help women and families in that community to be able to continue to give birth in Scone District Hospital?
This has been an issue that I know, Ms Mitchell, you've raised on behalf of the community, as have other members in relation to Scone. And I mean, I think regional maternity services broadly are something that we're trying to focus on to do more, but it'll be something that we continue to focus on going forward. In relation to Scone specifically, there's a recruitment for an obstetrician in Scone is ongoing, and advertising for that position will continue essentially until we get a position filled. The district has in place plans to ensure ongoing access to safe quality maternity services. I think from memory the name was of the clinician who left was Isabel Lang.
Due to finish, yeah.
Yep, due to finish. And I think she's retiring at the end of January.
Yeah.
From memory.
Well, that's what I've been told by the community.
Yeah.
End of the year.
End of the year. Yep. So we are in the process of advertising. We'll continue to do that until it's filled. I know I don't want to lose service continuity there, so I'm keeping a careful eye on it. But we know it's important, and we're out in the market advertising. Luke, is that a?
I might come back to
Yep,
Mr.
sure.
Sloane's side, because I guess also I've raised with you before, Minister, the issues at Muswellbrook with their maternity service. So you've got women who are in the Upper Hunter particularly, and I appreciate you trying to recruit for the Scone position, but concern again about women, where do they go to Singleton, do they go to Tamworth, they may from Scone, it becomes very complex. You made some comments in March last year to the ABC Upper Hunter, and it was in relation to, I guess, maternity services in the regions more broadly, and they said that you were working on an action plan for maternity that would be in place by the end of the year. What was that plan, and was anything delivered?
I need to probably just take that on notice, just to have a look at the comments and then try and reflect back to what particular issue.
If it helps, it was on the 16th of March last year that
I'll have a look
ABC
at
Upper Hunter ran that story.
What I was sort of referring to.
Yeah. I mean, obviously there's the broader maternity blueprint action plan, but I'm not aware of anything new or different since then.
Yep.
I want to take you to Dubbo now. Any further stages of the Dubbo Hospital redevelopment, stages 5 and 6? Any plans for that?
I had an opportunity, as has the Secretary, I had an opportunity to meet with the representative of the Clinical Staff Council, and very recent, so that was probably a couple of months back, fairly recently, the Secretary has also made her way out there and met with them directly, because I think on a couple of occasions, because this is an important issue. We are having a look at that capital as well as other capital requests as part of our capital bids and a capital management plan. As you know, from a big capital intensive agency, Minister, these come in and we obviously assess them in terms of priorities. I just want to emphasise to the staff that we're aware of it, the Secretary's aware of it, the CEO of Health Infrastructure and Emma Skoolander, I think, has also been out there, or certainly has engaged with that staff. So other than I can't give a commitment now because we haven't worked through all of the priority requests, but well aware of it, good engagement at a very senior level from the agency. I appreciated the opportunity to speak with them, where they raised with me a number of issues, including the one that you just talked about, and we'll continue to work through that.
While you were there, did anyone raise issues with you about the number of patients who have to come from Mudgee to Dubbo for their dialysis treatment? Are you aware of that concern in the Mudgee community?
Yeah, I did the meeting via Teams.
Oh, right, sorry.
But but I just because I didn't want to mislead the community.
No, that's fine. I made an assumption. But
No, that's all right. They raised issues around dialysis, from what I'm understanding. They also raised issues about weekend access through to Orange Health Service, something that Secretary Pearce has had subsequent conversations with Western New South Wales LHD CEO and clinicians in relation to Orange. But Secretary, did they raise dialysis?
And specifically for Mudgee patients?
Yes,
not specifically, although I would say, Ms Mitchell, that we recognise that the Dubbo Health Service is under very significant demand pressure. The clinicians there have had a really good conversation with us about what that looks like for them and for the patients that are coming from across the district into Dubbo for care and treatment. They're very busy there.
They're an excellent hospital.
They are an excellent hospital, doing really good work for not just the Dubbo community, but far, far into the surrounds of Western New South Wales. So we absolutely recognise that. Ms Schoolander or Luke may wish to comment further, but the district has updated its clinical service plan associated with what a future redevelopment or further redevelopment of the hospital would look like. That's gone in as these plans do into the list that we prepare for government. But we've had very good engagement with the doctors. We've also urged the district to make sure that the networking of services across the district are really focused upon, and very happy to pick up that issue around the renal dialysis specific to Mudgee.
That would be good, yeah.
No issue there.
Because obviously I think the community's keen to see if there can be a local dialysis service in Mudgee.
Luke can comment on that.
So, Ms Mitchell, so I've talked to the district about this on several occasions, and it's a clinical indication unless there is other specific cases where it's not, that I'm more than happy to take up. But when a person's coming on and off dialysis, their initial dialysis phase, especially if it's hemodialysis, they will need to attend a tertiary centre like Dubbo or Orange, depending on where the actual availability is, to be overseen by a renal physician. And then as they get safer treatment, they can then transition back to where there's chairs available in the peripheral sites. And we know it's not only Mudgee that happens, but several of the satellite sites within Western New South Wales, and I suspect many of our other districts, just while they're in that clinically indicated phase of going. So wouldn't matter what sort of capacity they had at Mudgee, if they're in that phase, the clinical indication is that they will travel to another service to actually have it not optimal from a travelling point of view, but clinically indicated.
Thank you. Just in the little small amount of time I have left, Minister, Parkinson's and Parkinson's Australia have obviously, Parkinson's New South Wales, have put a request to government for $3.8 million over 3 years to help with that growing cohort of Parkinson's patients. Are you going to look to support their funding request?
We're going to look at it, yet I've got a recollection of some correspondence, and I think from memory my office have engaged with them. I'll just stand corrected, just double check on that. It is an important issue. Demands on the healthcare system are wide, long and deep, but we are happy to have a look at that and continue to engage with that organisation.
Thank you. I'm sure they'll appreciate to hear that. And I do have 30 seconds left, so I'll fit one more in.
Yeah.
Are you aware of complaints against the management at Bathurst Health Service and some of the issues with staffing there?
Mr. Toole, the member for Bathurst, and I've had a number of conversations. I probably don't want to, because I haven't got permission from him to outline some of the things that he's raised, other than to say that he's raised a number of issues with me. We have looked at that. We have also, I've had a in-depth meeting with the Health Services Union, and I've had an in-depth meeting with the providers in that PPP or that setup, because a number of issues, not necessarily ones that Mr. Toole raised, but a number of issues that staff raised around Bathurst had to do with that.
And it came through our inquiry too.
Had to do with that contract provider. So I met with them. We've made some inroads there. In relation to those other issues, I'd probably lean on the service and Susan and others if they want to outline anything that I haven't said.
Yeah, look, like with anywhere where there's a concern raised, we get in there and have a look at that. The same goes for Bathurst. So both Mr. Sloan, Ms. Abbas have been there, personally met with staff, talked to the local management. We've got a series of actions underway to address those concerns. Obviously we'll keep talking to the unions as well, and we've discussed this matter with the Chief Executive, of course.
Thank you. Thanks.
Minister, this morning when you were responding to a question about Blacktown Hospital, you said, and I quote, "To my dismay, they built a hospital shy of what needed to be built in one of the fastest growing areas in the country, so we've had to expand that." Minister, to my dismay, you're delivering a coalition promise at Albury Hospital. that falls well short of what needs to be built in one of the fastest growing areas of the country to serve a regional community of 300,000 people. This redevelopment's been broadly criticised by clinicians, by the community. There's an alliance of 13 regional councils asking for a different approach. If the business case that supports this particular approach to the redevelopment supports what you're doing, why wouldn't you voluntarily release that to reassure the community?
Yeah, just a couple of things. I understand the release of the business case is something that is important to you, and perhaps it's important to people on the ground there in Albury. This was a decision obviously made by the former government and through a cabinet process. So whilst I understand that you want that information, I am going to have a look at how we might be able to provide that information that doesn't put me at breach of cabinet in confidence, nor does it set up a precedent in relation to business cases, because some of those things have commercial sensitivities around that they can just go out into the public ether. Plus, I'm also engaging with the Victorian government on this issue. So I don't have a direct answer for you right here, right now, other than to say I'm trying to have a look at the way in which we might be able to provide that information to you in a way that doesn't breach that. However, probably from my perspective, it's important to note that this is $500 million investment. I've heard that some people don't think it should be at that particular site. I think I asked the community just to take stock of the fact that that investment is also leveraging other investments that we've made into that site, including the Rural Cancer Centre, the School of Clinical Medicine, I think the University of New South does, the Hilltop Accommodation, the ED, the Brain and Mind Institute. There's one more, I think from memory, there's also some key worker accommodation in there, so that's fairly new. So what we've tried to do is balance that, and no doubt what the previous government tried to do is balance that. We're trying to leverage those assets, but I understand that you're after for some more information. I'm prepared to have a look at what we might be able to do in a way that doesn't breach my obligations through cabinet in confidence processes.
Thank you. I'm pleased to hear that you're engaging with Victoria, at least on this question, and we're not being entirely chucked in the too hard basket. You talked about the other facilities that are already on the site. At the moment, Minister, there is no stage 2 planned at Albury. There was a previously designed stage 2 that appeared in documents that I ordered to be released through the Parliament that you ruled out because that stage 2 required the demolition of the brand new $30 million ED. At a previous hearing, I asked Ms Kuhlander about the next step for a stage 2, and the answer was that it would be back to the drawing board for a new CSP. How on earth can you be confident that we'll ever get the services that we need on the current site when there isn't actually a plan for a stage 2?
I'm happy for Ms Kuhlander to elaborate on this, other than to say that we are confident through some of the engagement with architects going forward that future stages like that are possible on that site. But given your interest in it, I'm happy for HI to provide a bit more detailed briefing to you about that. I know it's a service that you've been advocating for, and the member for Albury has been advocating for. No doubt he did when his party was in government. But I haven't been given the impression, unless Ms Kuhlander says differently, that that type of stage is not possible on a future on that site. Ms Kuhlander, I don't.
That's all right. I might come back to Ms Kuhlander in the afternoon. Thank you. Thanks for understanding.
As long as I haven't given any information that's not accurate, I would rather that corrected. That's all.
No, that's correct.
Okay.
Understood.
Thank you.
In May, the Auditor General announced a performance audit of Health Capital Works and infrastructure delivery, including specifically the Albury-Wodonga Regional Hospital project to be examined. Would you wait to award the tender until the Auditor General has released that report?
Yeah, so the Tender Evaluation Committee, for want of a better term, is finalising their recommendations for the preferred contractor in relation to this. The strategy, as is often the case, is to award in stages so that main work construction is actually awarded later in the year after the AG report will be handed down. So we won't be doing the main work contractor before that AG's report is handed down. Just the initial work, I think main work construction was sort of projected to be early 2027, give or take. I don't have an actual day after the northeast building was completed, but the initial work awarded will enable the design to be finalised. So we won't be doing main construction before the AG's report's handed down into that.
Thank you. That's a very sensible approach. Minister, as you know, nurses and midwives campaigned for years for safe staffing ratios, and safe staffing levels was your promise in response to this. You're nearly at the end of your first term as Health Minister. Safe staffing levels, I understand, have taken effect in 80 emergency departments and 7 maternity wards, not in any other departments of hospitals or any other hospitals.
Yeah.
Do you accept that the vast majority of nurses and midwives in New South Wales have still not experienced any difference on the ground as a result of that initiative?
The ones where we've rolled them out have experienced massive difference because I've spoken to them, and it's been arguably the biggest change to their emergency departments in a very, very long time. Some of these emergency departments have seen upwards of between 20 to 30 additional staff come on board, the larger ones. That is a massive change in the way in which they operate. So we've recruited about 970 so far. We've probably got a bit over 1,200 or thereabouts to go. We've moved through we've moved through level 5 and 6 hospital EDs, just to clarify for the committee. We've moved through level 3 4s. We are now moving into NHPPD wards, that's nursing hour per patient day wards. That is the 1 to 4 ask, just in vernacular terms, that the association were asked us, so 1 to 4 on the floor in those surgical medical wards, and we're also doing postnatal wards as a part of that rollout, and we are in the process now working with, there was a committee set up with the Nurses and Midwives Association and New South Wales Health where they work through these things on the ground, and we are now working on the rollout of that last remaining portion. Fatima, is that?
That's correct. We are in the planning now for the NHPPD wards, and we expect to very shortly be able to allocate those across the state.
So when will the nurses working on those wards receive the support of the extra staff?
So we will allocate numbers to the wards, and the expectation is that districts will commence recruitment where there is a gap immediately to those. So we're not far off that allocation to the NHPPD wards.
Minister, I don't want to diminish the importance of having extra staff in some EDs. I agree that the nurses in those departments would be grateful for any additional staff. Blacktown Hospital is one of the hospitals that you've announced that safe staffing levels have been achieved. Nurses at that particular hospital have responded to say that safe staffing hasn't been completed. They said we're funded for 4 resus beds, but we're constantly overfilled to 5 with only 3 staff working in that area. They've talked about having to care for patients in informal treatment spaces, for example in the ambulance bay, and that was not counted appropriately in the safe staffing level rollout. So how many other hospitals, noting that Blacktown nurses were brave enough to speak out about this, how many hospitals are in that position where safe staffing levels is actually only on paper?
Well, let's be clear. Let's say, and I'm just making up the number for the purpose of the discussion, Blacktown was allocated an additional 20 odd, which from memory I'm right on that, but I'll stand corrected. Someone will tell me if that's a mile off. Then from time to time people are going to leave and be sick, and that so we're funded there. That's what we recruit to. We recruit to that number. We are going to continue to recruit to that number. If that number drops, we continue to recruit to that number. But you've seen at Blacktown also big increases in presentations as well. So one of the reasons why we're doing 30 extra beds at Blacktown by the end of this year is because there's big pressure on the fact that we don't have a Rouse Hill Hospital up out of the ground that should have been up out of the ground given it was promised at 3 elections by the former government. Now, we've had to increase that investment to $900 million. We've had to include an emergency department and a maternity service, both of which weren't budgeted for. That is single-handedly one of the massive reasons why there's pressure on Blacktown Hospital today, is because we don't have another hospital in the northwest that was promised 3 times by the former coalition government.
Appreciating the pressures on Blacktown Hospital and many other emergency departments in the state, you haven't actually answered my question, which is around the theoretical number of beds that the department thinks that New South Wales Health think a local department has, versus what often happens in reality with people being treated in informal treatment spaces.
Yep.
So when you've got 1 to 3 on paper, what the nurses are saying is that they haven't got 1 to 3 in practice, that they're still caring for people in informal treatment spaces and that safe staffing hasn't been achieved. When you say that safe staffing's now been achieved in 80 emergency departments, is that in reality or is that on paper?
Well, just so everyone knows the process, Nurses and Midwives Association and Ministry of Health do essentially a walk around, for want of a better term, and determine and land on that number. Let's say that number in Blacktown is around about 25 or so. And what they then do is start to recruit to that. That doesn't mean from time to time that there's not gaps, that Ryan or Susan or Emma don't decide to leave the service and then there's not gaps and we have to recruit again. That's always the case. What we've lifted is their profile up to an additional 25 staff, and that's what they recruit to, that's what they're budgeted for. But no service around the world would ever say that from time to time you don't have natural gaps when people resign or leave. But you've also got challenges at Blacktown where 50 patients a day are coming into that service from the Rouse Hill area that should have by now had a hospital built, given it was committed by 3 times at 3 different elections by the former government. That is a challenge.
The nursing union delegates at Blacktown have taken to social media quite bravely, despite the threat of the draconian social media policy, given that they have spoken out to criticise the numbers at Blacktown ED. Will you commit to revisiting them to make sure they actually reflect the bed spaces being used at Blacktown?
I'm always happy to engage with staff. It's part of the job I like the best. If people want to know, that's what I like. That's when I learn a lot. They give me feedback about what's working well and what's not working well. The general feedback that I've got from ED staff who have experienced significant uplift is that it has made a difference. That I'm not pretending that the rollout of ratios is a silver bullet for every problem. But I am saying that this government and through the Health Secretary has invested significant amounts into a reform that was not supported by the previous coalition government, and we also on top of that had to secure the employment of 1,112 nurses, all of which would have had to resign soon after where we took office. So these have been pretty substantial
Minister,
increases
not
in
disagreeing with any of those points, but you didn't actually answer my question, which is, will you revisit the numbers for safe staffing at Blacktown ED?
Well, I'll engage with the staff about their concerns. I can't give a commitment that we will go back on a number that has essentially been agreed to, but I will give you a commitment that I'm happy to engage through the union movement, through their union, with those staff.
Thank you. In terms of pay and conditions for staff, the nurses' work value case in the Industrial Relations Commission ran for 22 days. There was a 24,702-page hearing book and 69 witnesses. When the Commission then awarded a pay increase for nurses, the government called the outcome fair and then met its legal obligation by funding it in the budget. The doctors' award arbitration then ran for 30 hearing days. There's more than 30,000 pages and 76 witnesses. Why do you continue to fight your health workforce in court at that scale before funding the outcomes that you then describe as fair in the first place? Why not come in the first place with an offer above the fair pay baseline?
Well, to be fair, if you have a look at the nursing workforce and just take those for a moment. In 2022, 2023, a first year base salary for a nurse sat at around about $67,000. That base salary is now $81,000. I mean, in anyone's books, that's a substantial uplift in the space of 3.5 years that the government I'm part of has leaned into because of the removal of the wages cap that essentially suppressed healthcare workforce wages for over a decade. So that's what I would say broadly to that. We also set up an independent umpire, the Industrial Relations Commission. We brought that back because working men and women through the union movement, including nurses and midwives, the Health Services Union and ASMOF, the three big unions that I deal with, advocated for an independent umpire when disputes couldn't be resolved. And that's what we did, that's what we've set up, and it has worked accordingly. There will always be compromise and bargaining and negotiation, except when the coalition government are in place, where they capped workers' wages and they provided 0% increase during COVID for healthcare workers. So this has been a substantial change in policy reform in the space of 3.5 years, and that has led to frontline healthcare staff paid more than ever, more of them, and therefore our plan around delivering more beds, more services and more staff is fundamentally backed by those metrics.
Minister, I certainly would never defend the former government's disgraceful wages cap or 0% pay rise during COVID, but do you accept that the pay rises received since you became Health Minister have actually been below inflation and still a pay cut in real terms?
Well, I'd accept, and I think most people would accept, that those figures that I've said in comparison to a first-year nurse and a nurse now first year under us is substantially different. They're paid more under us than they ever were before. I will always expect, as a Labor Member of Parliament and someone with Labor values, for working men and women to fight for better pay and conditions. I'd be very, very disappointed if working men and women didn't do that through the trade union movement. That would not be something that I would want to be a part of. I will always expect working men and women to do that. But as a Cabinet Minister, I've also got to balance the ability for the state to pay. I think we've landed on an amount that is a substantial uplift. Is it everything that the nurses wanted? No. But I think the nurses would also acknowledge that we're the first government to roll out a ratios reform, a policy that they had been advocating for close to, probably not equivalent, but close to 2 decades for a long period of time. And that has led to substantial increases in staff. So if you have a look at both of those reforms in totality, I think that's a pretty big investment and change in the space of 3.5 years, for argument's sake.
Other states that we continue to compete with for a scarce health workforce, Victoria and Queensland, are paying nurses, midwives and doctors more. At the rate that you've offered pay increases, when do you expect that we'll achieve pay parity with our neighbouring states?
Well, one of the big challenges is, and it's simple compounding mathematics that we probably learn in Year 7 at school, is that when you suppress wages for a decade, the power of compounding does not work, and therefore you don't get growth on growth. So when you've had that cap in place for 10 years, does it lead to healthcare workers being behind at times their counterparts in other states who didn't have a cap? Obviously it does. Is that something that we have tried to make up in as quick as possible time as we can? Yes, we have. Can you do it in the space of a year? No. But if you have a look at our workforce, paramedics, nurses, and the increases in pay that they have received, not only both numerically but also increases in staff overall, that is a substantial reform that I think my colleagues can be proud of in terms of what they have advocated for on behalf of their community, and I think the Health Service should be proud of in terms of the delivery of those reforms that I think will make a real difference, including the rollout of close to, not yet complete, but close to 500 additional paramedics for the bush.
In my last short remaining time, I wanted to come to the question of security and occupational violence, and of course this is related to short staffing. Back in 2023, you announced a short, sharp evaluation of progress on the Anderson reviews, 107 hospital security recommendations. Is that review finished?
Yeah, I have to take notice on that. Just in relation to security, I think it's one of the biggest underlying challenges in our health system right now, and Ms Fairman raised issues earlier around the nature of people presenting. Having spent a lot of time working with the Health Services Union, and they're the union responsible largely for security guards, but it is not just security guards, it is also, as they recognise, clinical staff. This is a massive issue. We've increased the workforce, security workforce, by around about 13%, give or take, and that's the equivalent of around about 180 or so FTE. We've also established a task force that is working through with the Secretary specific issues where we might be able to make quick change in relation to training, in relation to the environment in which they work. That's something that the Health Services Union have advocated. It's something that I've met with the Nurses and Midwives Association. No doubt ASMOF are also talking about this, and we've obviously got the body-worn camera trial across 15 specific hospitals around the state that's also been extended. So we're trying to look at, through that task force, a range of different measures that we think we can lean into to make our hospital safer. It is never going to be something where a minister, well, certainly not I would say that we can't do more in this area. We can and we must, to keep our workforce safe. But this is something that at the highest levels of the health service, through the Secretary, we are actively engaging the workforce through representatives of their union to try and deal with challenges that we face, not solely in EDs, but I'll be honest with you, it's predominantly in EDs and those types of spaces.
Yeah, so you mentioned the body-worn camera trial. It's my understanding that this is quite contentious among the workforce, that there are paramedics who think this is terrific and paramedics who don't.
Probably
there's also concerns in the community around the risk of being filmed in what is an extremely vulnerable moment for many people, potential misuse of that footage. I understand some paramedics are also concerned that it makes them less safe because they might be mistaken for police officers in some circumstances. Why are you legislating to provide the power for permanent body-worn cameras when, as you said, this is still something that's in trial form and needs to be considered quite carefully?
It does need to be considered quite carefully. I've equally spoken to many paramedics who have said that it has had the ability to, what I would call, their terms back to me, is de-escalate issues. Every time you have some form of surveillance, whether it's CCTV or body-worn in a hospital setting, it's always a fine line. It's always a fine line, right? And we've got to get the balance right. Hospitals, you're right, are some of the most vulnerable but complex settings. People go there not on their best day most of the time. Sometimes it is, but most of the time it's on their worst day or their worst day for their family. But I've also got to try and make sure that we protect the staff who go to work every day and try and provide the very best possible care. That's not just nurses and doctors, but it's also cleaners, security staff, allied health professionals, administration staff. It's all of those stuff, and I've got to make sure I get the balance right. I think we are working on doing that, but the task force is designed to provide specific advice direct to me and the Secretary about what we might be able to do more, and that includes, but not limited to, things like training, which is something that the Health Services Union has said that we need to lean into more, as well as specific licensing for healthcare security, something that I've written to the Police Minister about, to have a look at the security licensing arrangements to see if there is an appetite or an opportunity to have a security licence that is very much focused around healthcare, because a security licence for a nightclub or a hotel is probably different, well, not probably, is different behavioural skills that we would want to see in someone that is providing security within our hospital or health services.
I'm out of time. We do have a couple of minutes of opposition time.
Yeah, just quickly. Thank you, Chair. Minister, the Northern Beaches high volume surgical hub, I continue to have many clinicians raise issues with me about their concerns about this particular setup. They effectively are calling it a production line, a surgery factory, concerns about what happens in terms of both pre and post-operative assessment and support for patients. Are you hearing these concerns as well? Have you spoken to doctors and clinicians who are working out of Northern Beaches about their issues, and what will you do to address them?
Yeah, good question. It's an issue that has come up as we move to a different model. This surgical hub is in its very early days, so there's been pretty big changes at Northern Beaches Hospital as we've moved away from privatisation and into a public health model, something that was very important to myself, the Premier and the Treasurer and Labor colleagues that we did that, but that doesn't mean they're not without challenges there. There's two issues. We want to try and make sure that we utilise the additional capacity that we now have at Northern Beaches Hospital to, one, focus on the people of Northern Beaches first and foremost, because that is their local hospital, but two, use that additional capacity to provide surgery for people in nearby local health districts, for example, predominantly within the Northern Sydney, but also in areas like Central Coast. Now, the hub has conducted surgery in relation to a number of specialties, including ENT, urology, gynecology, and we are working towards adding other specialties to that. We've conducted, I don't want to give them out because I don't know, but I don't have an accurate, and I don't want to sort of give it, but we are working through that. But we've got to this situation, obviously, because we've moved the hospital in public hands away from a privatised model under the former coalition government. Those changes will take time to embed in. I'm not pretending that every clinician over there has just said, yep, we're just going to business as usual. It's not. It hasn't been the case. We've had to change it because we've increased the capacity of that hospital.
Specifically, the concerns about patient safety and particularly that post-operative care piece, if people are travelling to the Northern Beaches for surgery and then have to go home back to wherever that may be, whether it's the Central Coast or other parts of Sydney, concern about travelling, post-operative bleeds, what happens if they're on public transport, which we know is difficult in the Northern Beaches. These are real, tangible concerns that clinicians are having for their patients. Who then takes clinical responsibility for that? Is it them? Is it the doctor who referred them? They're not small issues, with respect, Minister. So how are you going to work through those challenges that are being presented, surely to you? If they're coming to me, they'd be coming to you as well.
Yeah. Firstly, I just want to make it clear that, and you would know this better than anyone as a regional and rural member, I know people, so I'll just speak from my own community, people travel from the Illawarra and Wollongong every day to receive care in Sydney, just because of the provision of services is sometimes concentrated in our metropolitan hospitals. That's first and foremost. Secondly, the provision of this surgery will always be done in a way that is safe. There is no negotiation around safety. That is top priority of any health system, but particularly here in New South Wales. We will obviously work with those clinicians as we roll this out, but we are in the very, very early stages. Mr. Daly, did you want to add anything else?
Oh no, we're working both with colleges and the affected surgeons. The Chief Executive reported to the Minister just last Monday that we're getting increasing numbers of applications of surgeons to join Northern Beaches in order to facilitate this workload. But at the end of the day, it's a choice of the patient. If they don't wish to travel, then we'll facilitate access in one of the other, either within their district or with one of the other 8 or 9 high volume centres that we're setting up on the back of the growth of the Northern Beaches Centre. So it's giving patients a lot more options, but perhaps more importantly, it's building public sector capacity and moving away from the thousands of contracted patients where we're paying up to a 20% margin. That's money lost to the New South Wales public health system, and we'll be winding that reliance back on private sector involvement as a result of high volume centres like Northern Beaches and others that are scattered around the state for the convenience of patients.
Are there any questions from the government?
Thanks, Chair.
Yeah, just one final question from me, Minister. Could you update the committee on what impact the new Rouse Hill Hospital will have on the surrounding, on demanding the existing Western Sydney hospitals?
Yeah, it's a great question. Rouse Hill Hospital is arguably one of the most important investments we are making because of the growth in northwestern Sydney. I can report to this committee today that there are more than 17,000 patients from Rouse Hill and the surrounding areas that present to Westmead and or Blacktown each year. That is the equivalent, for the committee's benefit, of around about 50 patients per day. This represents about an added 13% of pressure going into the capacity of those two very, very busy hospitals. And that's because over 3 terms in this place, there was a failure to build Rouse Hill and invest in that facility. We've had to triple the size of that investment from 300 odd million down up to 900 odd million. That will, as you know, Ms. Savale, include importantly investment from the federal government around birthing services and importantly an emergency department and big increases in the clinical spaces there. This area is literally coming out of the ground every few months. If you speak to my colleague, the member for Riverstone, as well as the Minister for Western Sydney and the Deputy Premier, they are frequently talking to me about the massive growth that is happening in that northwest corridor. And this hospital can't come out of the ground soon enough. The work is now underway. That construction, preparation construction has started. I had a look at some video work of that recently. That is certainly underway. Big construction, or what we loosely call main construction, will commence next year. And I know that for the people of northwestern Sydney, this is a hospital that they need probably today. They probably needed it 10 years ago. I'm disappointed that the former government didn't prioritise this. I think the people of northwestern Sydney are disappointed that this wasn't prioritised. But in the space of our first term, we've got this hospital underway. And I think that is something that, as Labor members and the Health Service, led by the Secretary and Emma Schoolander as the Chief Executive Health Infrastructure, who have driven this project really, really well, that is something that they and we should be really proud of, because for the people of Northwest, this is going to make a tangible difference. And anyone who visits Blacktown hospitals frequently, as I did, and has had conversations with management there, staff, as well as the local member Stephen Barley, they will tell you the pressures on that hospital. We can't wait for Rouse Hill, which is why we've moved to the investment of 30 beds at Blacktown, and then we'll also be doing 30 beds at Mount Druitt Hospital to try in the interim to take pressure. But Rouse Hill is strategically, along with probably Bankstown and Eurobodalla, some of our most important investments that we'll make as a health service, just given the growing demand.
Thank you.
Thanks, Chair. Are there no more questions from the government?
No further questions.
Okay.
At this stage.
That brings us to the end of our time with the Minister for today. Thank
for
you very
having me.
much for your
Thanks,
engagement
Minister.
with this process, particularly as this might be my last hearing as Chair, depending on what happens next year. Thank you, Minister.
That could be true for everybody. You know that.
And we'll be
My
back.
last Minister.
It's in the hands of the people, Amanda.
Thanks everyone for having me. Yeah.
Thank you, and we'll be back for everyone else at 2 o'clock. Thank you.
Thank you.
Take that as a solid indication for no supplementaries.
Welcome back, everyone. We'll resume the questioning this afternoon with the opposition. Mrs Mitchell.
Thank you, Chair. Welcome back, everybody. Ms Gilland, I'm just going to start with a couple of quick ones to you. Just in relation to the number of beds that have been delivered, particularly in Western Sydney, in this term of government, how many beds have been delivered at Westmead?
At the Children's Hospital, Westmead?
Yeah, or across the campus?
72.
Yeah, 72, and in the sort of general hospital?
In the Westmead Hospital?
Yes.
In this term of government, I don't believe there are any new beds. Let me just confirm that.
Okay.
The 82 number that the Minister quoted was 72 from Children's Hospital, Westmead, and 10 from Nepean.
Okay, and the 72 at the Children's Hospital, when were they first funded?
First funded, I will have to check the announcement for that funding, but it would have been prior to this term of government.
Thank you. If you can maybe find that, or someone can, and if you can come back to me with that at some point,
No
that
problem.
would be good. And then same for the 10 at Nepean, were they funded also prior to this term of government?
Yes.
Okay, thank you.
But delivered within this term.
Yeah, I'm just keen to know sort of when they were funded and initiated. So, but if you could clarify the date for the 72 at the Children's Hospital, that would be great. Thank you. I want to turn now back to the Martyr, and probably again, Ms Pearce, happy if it's through you, but
Sure.
it may be better directed to Ms McCosker, but I'll ask, and whoever's best placed to answer is fine.
Yeah.
I just wanted to go to the statement yesterday, and on this one Professor Nicol might also have some evidence or advice. The statement yesterday talks about clinical advice coming from, I think, the Health District, but also the Clinical Excellence Commission about having the ICU remain operational, and I just wanted to better understand that clinical advice. Someone can give me an update.
Okay, who would like to start?
I can speak to that.
Tracy, thanks.
Yes. Thank
So we did have people from the CEC and some of the public health people from Hunter New England and the clinicians from Calvary Mater. The levels of the 3 rooms, probably one was a little bit more elevated than the others, but all were considered relatively slightly elevated. So they talked about the fact that, as I explained to you before, that someone was being discharged, so they used that room, and they felt that working them through and cleaning and then moving them in and cleaning and then moving them in was the best way to operate than rather try and close 3 beds out of 6 beds of the ICU. Those levels were not unsafe at all for staff, but because these our patients were potentially immunocompromised, they didn't want to take any risks. There was one patient out of the ED, and because I'm not a clinician, I won't know this, but sort of they weren't actually accessing any outside air. They were getting the breathing from oxygen machine or something like that. So they were actually at no risk, and they were in the ICU. So they talked about it. I was at the meeting when they discussed it, and they looked at the air levels again, and they decided that it was okay to do so.
Okay, so just with the advice from the Clinical Excellence Commission, I note the Minister said that I think the testing results came back Monday evening. He was informed Tuesday. So when was that advice sought from the Clinical Excellence Commission about it being fine to keep the ICU operational? I'm just trying to understand.
It came back
timelines.
Monday. That meeting was held on the Monday night.
Okay.
Yes.
Okay, thank you. And then I appreciate what you've said about sort of patients moving through and cleaning, but do you have a total number of patients that were in those affected areas?
So there was 6 people at the time, but of course, because the testing was done on the 12th of August, obviously there had been other people come through the ICU, so they contacted all those people as well, just to let them know.
Do you have a number that you can give of people?
I'm sorry,
who
I
take it
don't,
on
but I can get
notice?
back to you.
Yeah, that would be great, thank you. And then I understand that the testing had started from sort of April last year.
Every quarter.
Yes, and this, I'm assuming, is the first time that there's been an elevated test that has required further action, is that correct?
Yes, that's right.
Okay, thank you. And this might be Ms Gilland, I might put it through you, Ms Pearce, but just the broader issue of the HVAC remediation. Obviously, we've spoken about it at our committee hearing and inquiry as well, and thank you, Ms Gilland, because you came a few times, as did you, Ms McCosker. You were happy to provide evidence, but I'm wondering about the timeline for completion of that remediation of the HVAC. And then also, I think last time we had you here, Ms Yolanda, we asked about the $400 million that had been set aside in this budget. Is there any update on any of that money being allocated to MARTA? How long until the HVAC work will be finished as well?
Yeah, I think the Minister's referenced the task force that's been established to look at the remediation works. So that task force is established. They're on site and meeting daily at the moment with Honeywell, who are on site as well, to understand the activities that will be undertaken now for remediation. The priority remediation activities is a package of work. We think that there are some immediate things that can be undertaken and some will take longer, so I don't have an exact time frame, but certainly the HVAC works, and including the HVAC in the ICU, are in the priority package that they're currently preparing.
Okay, and is any of that going to come from that $400 million program allocation?
So part of working with Honeywell on site is that some of it we consider to be maintenance work that we want to ensure is undertaken immediately, and certainly we wouldn't want to spend that money on those activities that we can get Honeywell to do under the contract, and we'll oversee them doing those activities. I anticipate that we will use some of the money from the Health Asset and Equipment Range Replacement Program to carry out some steps in relation to the HVAC remediation. The Minister has committed to that, and through our governance for that program, we're currently assessing submissions, and we'll have that list of priority projects finalised, but I do anticipate we will need some money there to put towards this HVAC upgrade.
Okay, thank you. Did you want me to keep going, or do you want to jump in for a bit?
I'm happy for you to keep
Okay.
or I'll jump in, whatever suits.
I might just keep going for now.
Yeah,
then.
sure.
Sorry, we're just tag teaming a bit this afternoon. The wanting to move to, and I'll direct this through you, I think is best, Ms Pearce, the Special Commission of Inquiry into Healthcare Funding, which I obviously asked the Minister about this morning as well. The preventative health and obviously there's significant findings on the need for prevention and paths forward. I know that the Minister's announced a preventative health summit. I guess obviously that's a matter for government to hold summits, but I'm curious to sort of understand why we need to do a summit when there has already been some recommendations made through that inquiry around sort of preventative health, and what more we expect to get, or you as health officials expect to get out of the summit.
Yeah, I'll get Dr. Chant to comment, other than to say, I think from my perspective, and obviously it's not for me to contradict the Minister's or the government's position on the need for a summit. I support the summit, and the reason for that is I think that the inquiry, was very robust in this space, and we support the robustness of that. But I think it's important, there's been issues raised here this morning, for example, around access to primary care and various other parts of the health system, and I think that it is important for us to take many factors into account. The inquiry heard a lot, but I think there is room for us to think about what more can be done in that space. But Kerry, did you want to?
So, Ms Mitchell, at the moment we are doing extensive stakeholder consultation to understand what are the key priorities. So the Special Commission made a lot of excellent recommendations, but did so at a fairly high level. And so we also need to determine what are those areas that we're going to prioritise for system change and action. We have been undertaking stakeholder consultation with non-government organisations, with the medical, allied health, pharmacist, other allied health groups, we've got community consultation, Aboriginal health communication, just to identify what would be the priorities. And the proposal is that we do a deep dive in relation to those issues. So some of the emerging themes that might be relevant are reducing cardiometabolic risk across the life course, and so we're seeing obesity as both a disease and a risk factor, and that taking on a prominence in terms of contributing to burden of disease, how that impacts on multiple systems, and what would be the best have we got it right? You know, where are there gaps? Where do we need more investment? What are some of those new possibilities? We know that there's new therapies as well coming on board, as well as very much a focus on primary prevention. So it's really thinking about what topics we take. Healthy ageing, we've done a burden of disease report, which we're also consulting with stakeholders on, and that will be released at the summit. And that really does show the massive ageing of the population, the profile of chronic disease. And so there's lots of opportunities to both reflect from a health perspective ourselves, but also recognise that many of the prevention activities work in a whole of government phase. So the proposal is that there's 2 days of the summit, one which is more health centred and the second is more whole of government centred, and so that could look at things like active physical activity, schools as a setting for promoting health and well-being. Really, those things are, I'm just throwing those out there.
No,
please
I appreciate
don't.
that.
But that gives you an idea of the issue. So it will actually become much more granular in terms of the specific recommendations, with some cost effectiveness, reach and equity lens applied to the recommendations coming out of the summit.
Yeah, sure. And then I guess just I know you mentioned chronic disease, and obviously there's linkages between that and hospital demand, and there's probably a range of areas that you could focus on in that. Do you have a breakdown of what proportion of the health budget is currently allocated to preventative health measures?
There is I'll go to the Chief Financial Officer, but there is a formula that's calculated and reported, but one of the things I'd just like to make a point before going to the Chief Financial Officer is prevention is a very broad church. We all the way from primordial prevention, which lies across the government agencies, all the way through to secondary intervention. So we have seen massive declines in cardiovascular mortality, and that's been consequence of better management of cholesterol, high blood pressure, and again, it's how we capture and cancer screening's probably been another success in vaccination. So there's always a question of what do you count and how you count it, but I'll allow over to Alpha to Mr. D'Amato to describe it.
Getting the data.
Sorry,
who's getting the data?
Oh, that's okay. That's all right.
We can come back to
it.
Yeah,
we can come back if you can provide it on notice if that's easier. If it's hard, sometimes searching isn't as easy as you hope it will be on laptops in these sessions, which I understand. I wanted to, probably to you next, Dr. Chant, the scope of practice for pharmacists, which I spoke to the Minister about this morning. My understanding is there's an expert advisory panel that has been set up to look at that, and I just wanted to get some more detail about I guess the purpose and scope of that panel, how it was established, application process for members and the like. So what can you tell me about that panel?
Would it be possible if I just corrected or expanded on a particular issue that I think is really important this morning? So currently in New South Wales, all pharmacists have the ability to undertake some relevant training modules, and they can then follow protocols that have been endorsed by the Expert Advisory Committee on urinary tract infections, continuation of hormonal contraception, and minor skin conditions, including atopic dermatitis, herpes zoster, impetigo, and psoriasis. So I just want to make sure that there's no consideration that there's actually the ability for that training, which is online training, that would allow protocol-driven use of that for any pharmacist who's practicing. And that's been a consequence of the trials that we conducted in those areas where we assessed on the basis of improving access and looked for any safety signals in that was a safe way to proceed. In terms of the expert panel, that was set up to I could have to go back in terms of the approach, but generally it's a multi-disciplinary group. It has got pharmacists on the expert panel, and the nature of the expert panel has changed over time. So for instance, when we were considering the protocols for minor skin conditions, we brought in dermatologists. When there's particular interest around the age cutoff of protocols, we've brought in and sought advice from paediatricians or paediatric specialists. So I can provide the list of the
the nature of the approach to it, but it's generally been, there's been a core membership which is representing pharmacists, general practice. We also got representatives from Canberra, ACT, because a lot of the trials we've done collectively with ACT, and we've supplemented them with experts that would be relevant when we did the oral contraceptive.
So was there like an application process to go on the panel? Who appointed the members of that panel?
They're based on recommendations to me from sourcing where we think people have got expert advice on particular domains. In the usual way, we would seek and construct an expert panel. Sometimes we seek expert panels by nomination of the colleges, but in this case, I would have to go back, but we've generally sought where we know a person's got a particular expertise and is known to us, say, for instance, in oral contraceptive pill complications or issues such as dermatology.
Okay. I might put a few more detailed questions on notice about that, but is any of the sort of recommendations that the panel has made to date, or is there any sort of publicly available advice documented in terms of some of the decisions that they've been made, or what's the accountability or structural measures around it?
So just to be clear, the major issue is that the expert panel reviews, provides advice on the adequacy of the modules or the training that would be required to do this. And I just want to really emphasise that this is not about prescribing. It's more about is the training sufficient to allow the health professional to diagnose and then treat and manage the said condition. Some of it will require prescribing, but some of it may require other modalities. Generally, we've used them for where there's been agreement that, for instance, with the UTIs, there was an agreement that we would do a trial for UTIs, for prescribing the oral contraceptive pill, and for the UTIs. That was done separately by University of Newcastle, who set up their own expert panels and did that. And then subsequent to that, we have kept those protocols current. So those protocols were there, but when we've transitioned that to business as usual, an example being that the antimicrobial guidance for first-line therapies for UTIs recently changed, and so therefore we needed to update the guidance for practitioners on that. There are also aspects where there might be gaps identified in terms of antimicrobial stewardship or concerns around resistance patterns changing, that might need to be augmented. So that expert panel is really a clinical expert panel that provides advice on, are the protocols reflective of the care, best practice care, and then they also have provided advice on the sort of level of skills and training that would need to diagnose someone with presenting symptoms. So what sort of clinical training would you need to make sure you're not missing other things, or outlining some of the risks that would need to be considered in that basis.
Okay, thank you. I do have some, but I might just put them on notice because I don't expect you to have all the detail here. The number of ambulance call-outs and arrivals that we're seeing, I think we give these ones to you. Is it correct that they're at some of their highest levels since reporting began in 2010? I've been shared that, and I'm curious as to whether that's true.
Yeah, happy to take that. So thank you. We have experienced, as the entire system has, a significant uptick in demand for our services over the course of this winter. And even in the last fortnight, we have seen 000 volume on a daily basis, at times reach 4,000 000 calls per day, which is an increase in demand. We have had periods of higher demand than that which we've experienced recently, particularly during COVID. But it is fair to say that our demand trajectory probably never really normalised after COVID. We have a range of strategies in place to ensure that we continue to meet our performance targets, particularly around our sickest patients, so our Category 1 cases, and we continue to meet that target across the state, which is very pleasing for us and for our patients. We've also implemented a number of strategies to contribute more broadly to the management of demand across the system, and one key strategy there is the implementation of our virtual clinical care centre, which is increasingly diverting patients who access the health system through 000 away from emergency departments where it's safe to do so, and refers them to more appropriate care pathways for them.
Okay, thank you. I've got a few more, but I'll come back in my next session.
No worries. I've got several questions relating to ambulance, but the first one is for Ms Pearce, which was relating to the contingency planning being done for the defibrillators.
So look, the work we've been doing to work through that issue is extensive. As the Minister mentioned this morning, there is an incident management team stood up. Mr Daly, Professor Nicol are part of that along with others. Obviously, it's incumbent upon us to, I suppose, be prepared for a worst case scenario with respect to a TGA ordered withdrawal of those devices, so we can't continue on as though that's not a possibility, although they have not signalled at this point in time that it is, that they are considering a range of factors. At my request, there was a meeting with the TGA last week, also with health chief executives from across the country, because these devices are used in other states and territories as well, and we'll work closely with them to make sure that we've got our reporting mechanisms very clear. There is a lot of clarity in them already, but we think we can strengthen those, so we make sure the TGA's got everything that it needs in making these decisions. We are examining other products that are available on the market and what that supply would look like to anticipate, that if that should eventuate. I did, say to the colleagues here the other day, I felt like I was back buying ventilators again during the pandemic. It did have shades of that, but certainly we are looking at all things. And in addition to that, the Minister quoted a number this morning. I think it was around 58% of the devices that we hold are going through software updates. That's happening. And I will also say that at a point in time, post the procurement of these devices, there was an issue identified some time ago, and the device owner went around and checked all of the motherboards across all of the devices in New South Wales Health. I think from memory, there were only 18 motherboards that were updated out of the thousands of devices that we have, but we are hearing and making sure that we're understanding from our clinical teams, what is at play here, and making sure that we can do everything we can. The issue of the leads, I think Ms Mitchell or yourself, Dr Conn, had raised that this morning around the length of the leads. We are also aware that there is concern about those. The team are actively engaging with the supplier to see what is possible in that space, taking on board that feedback. But yeah, absolutely looking at a contingency should that be required.
Thank you. I'm pleased to hear that there is contingency planning for a worst case scenario, even if you think that's unlikely. Should you be required to replace them in the event of a recall, what is that lead time going to look like to be able to get new devices?
I'd have to ask Mr Daly if he knows the lead time.
Since the tender that secured these units across ambulance and a number of districts, not all, about a third of the districts use them, other devices have come onto the market, and I've had confirmed that they are actually on contract should we need to move quickly onto another device. So we won't have a procurement lag. It'll just be a safety assessment that the CEC and ourselves will be actively involved in, and then a decision made either at a chief executive or a system level if we need to move. But if it's if it's foreclosed really by any direction from the TGA, we'll need to respond very quickly. But it's on contract. There are other items that frankly weren't there when we procured this one, so there are alternatives available to us.
Thank you. That's helpful information. It didn't quite answer my question in terms of what the lead time would be to activate those contracts and get replacement devices.
We have the capacity, and it has been confirmed that there are suppliers within the US. We've seen in past efforts, such as during the IV fluid shortage, that we can directly procure and directly freight it into the country ourselves. So we could move very quickly, but device numbers are available in the US from where they're sourced.
Could I just add to that? The TGA have made it clear, though, that there would be no abrupt withdrawal. They recognise that even if they're in the eventuality that there was a recall, and again, they are not signalling that is the likely outcome to this, but I won't preempt what happens at the TGA. An abrupt withdrawal would be very dangerous because obviously any health system would require time, given the scale of the New South Wales health system, to properly roll out any new device, and so it would be an orderly transition to any new device in any event. Professor Lawler has, both to myself, to the Minister and to others, made it clear that the risk of removal far outweighs the risk of leaving those devices in situ at present. In a sort of precipitous or a rapid way. So it would be an orderly transition should that come to pass.
Absolutely. If it were my loved one, I'd rather them have a core pulse defibrillator than no defibrillator if they needed one.
That's
but I'm pleased
right.
to hear there are plans in place to replace them quickly if we needed to. Sticking with ambulance, have you now received the complete review of the Northern New South Wales helicopter service?
No, we haven't. As this committee would be aware, an independent review was commissioned. From the outset, New South Wales Ambulance has been very clear in our expectation and our requirement around receiving the full and unredacted report in relation to the workplace concerns that were raised within that organisation. To date, we have not yet received that full and unredacted report. I can share with the committee that in the last 48 hours we have received correspondence from Northern New South Wales Helicopter Rescue Service with a proposed approach to accessing the full and unredacted report, and we are considering that.
I appreciate there's less and less time now before their current contract expires. What does it mean for your consideration of any extension that you still don't have the information?
Again, Dr. Con, as we've said, in order for us to undertake the due diligence that we have committed to undertaking and we believe is imperative, without access to the full and unredacted report, we're unable to undertake that due diligence, and hence our ongoing and frequent dialogue with Northern New South Wales regarding the importance of the provision of that information. They have provided to us, in addition to both a summary and a de-identified report, we have also received a communications strategy and an implementation plan that addresses the recommendations which Northern have fully accepted and intend to implement. What we still need is the full and unredacted report, and we're considering the most recent proposal to us, which, as I say, has come in the last 48 hours.
What kind of lead time would you need should the information, once it's provided in full, not be to your satisfaction to allay the concerns around workplace safety to allow a tender process for an alternate provider?
The reality is we are now under significant time pressure. The contract expires in May 2027 with a 6-month notice period. So we are now under significant pressure, and I can assure the committee that myself and colleagues are in very regular dialogue to provide as much time as possible to consider the information once we receive it.
Thank you. I think if I can try to paraphrase the concerns of people I'm speaking to, there's a worry that this contract will be extended by default because you're going to run out of time.
Well, I think from my perspective, workplace culture and the concerns that have been raised have led to a commitment from our previous chief executive and myself and colleagues that in the absence of being able to assure ourselves that the culture is of a satisfactory level and that our employees across New South Wales Health, both paramedics, doctors, have the opportunity to work in a safe place, our capacity to consider an extension is limited.
And appreciating the importance of receiving the complete and unredacted review, have you sought any other sources of information? So, for example, CASA or Safe Work or any other organisation?
So, earlier on in this process, and I can come back with the exact dates, when we first became aware of this, there was an audit done, an industry audit into the aviation safety of the operation being run at Northern New South Wales Helicopter Rescue Service, which returned a satisfactory result. So from an aviation perspective, we don't hold safety concerns, but of course, culture is an important part of any operation, and we continue to work with Northern New South Wales to provide us with that information.
There were a couple of recommendations for ambulance that arose from the inquest into the Bondi Junction attack. One of them was for tranexamic acid to be carried as standard in New South Wales ambulance vehicles. Has that been implemented?
It has. The advice I've received as late as this morning is that 85% of all eligible clinicians, so our paramedics, have engaged in the training, and TXA, as we refer to it, is now stocked in all ambulances.
Great. And the next recommendation, 16, was about reviewing emergency planning documents, including consideration of adequacy of training for commanders to ensure they obtain and maintain competence in relation to major incident management.
Thank you. So we have undertaken a comprehensive body of work to contemporise our emergency management arrangements doctrine. We've taken an approach to consider our doctrine in, I guess, a benchmarking activity across other like jurisdictions. We are in the final stages of consultation internally on those on that doctrine, which would be a modernised emergency medical services plan, which would rescind our current AM plan, which we've had in place for some time. Once consultation is finalised, a key part of implementation of that new framework and doctrine would be the training of all of our, not only our paramedics, but of course our supervisors in those arrangements. So that would be part of an implementation. And I'm expecting that we will be commencing that implementation either in the later stages of this calendar year or early next year.
Thank you. I understand that intensive care specialist paramedics are not able to work at Category C and D stations, and that's been in place for a couple of years now. Has that had any impact on response times to incidents actually requiring the skills of an ICP?
Not that I am aware of. I think probably important to call out that our intensive care paramedic program does deliver specialist scope. Any specialist scope, and this is consistent, I think, across health systems and health professions, as respectfully you would be aware, specialisation requires a range of conditions, including exposure to the nature of the work that allows for currency to occur. We moved some years ago to a role delineation arrangement with a capability assessment, and effectively what that assessed is the volume of demand for different specialist resources in our organisation. And where we identify locations where there is insufficient demand to maintain the currency of intensive care practice, we have categorised those stations as C and D locations. It really is all about clinical governance and patient safety rather than a reduction in capability. I should add, Dr. Conn, as well, the paramedic, the core workforce within our organisation, that paramedic workforce is a highly capable, highly qualified, with a contemporary scope that has been uplifted in recent years. And our paramedics are able to address reversible causes of cardiac arrest, deal with critical patients, both from a medical and a trauma perspective. And so we're very confident that our paramedic workforce is providing an excellent layer of coverage, and where necessary, intensive care paramedics, or for that matter critical care paramedics through our aeromedical service, are available to respond across the state.
I appreciate the importance of currency, which you raised as the critical issue. What alternatives were or might be considered to be able to maintain currency for a specialist paramedic at a C or a D station?
So we have, as you would expect, a credentialing framework in place, and that credentialing framework does require our clinicians of any level to engage in recency activities, including for high acuity, low occurrence skills and scope items. For intensive care paramedics who had, prior to our categorisation arrangements, who had previously been working in more remote and lower volume areas, we are maintaining that credentialing and supporting those intensive care paramedics to remain there. And I think our credentialing framework is the safety mechanism that gives us assurance that our clinicians are able to maintain those more critical scope items.
That credentialing framework, or that safety framework that exists, why couldn't that then be applied to a specialist paramedic who might relocate from a metropolitan area to a remote area to maintain their skills in the same way?
I guess the challenge with any area of clinical practice really is down to exposure, and so high fidelity simulation, reflection, repetition in an educational environment does deliver a level of assurance. What we would say would be that exposure in the clinical practice environment is very important, particularly when we're talking about skills that have a high risk associated with them. And so our commitment is to maintain those individuals who have previously worked in those locations, but with a view to ensure that particularly our new intensive care paramedics, as they're training, and those with more experience, are practicing in a supported environment with sufficient exposure.
I still haven't quite wrapped my head around the difference between those two groups. So if you've got sufficient support and training for someone to maintain their skills who was already in a remote area, you haven't quite answered the bit of my question of why do you need to be treated differently if you've trained in the city and then relocated to a remote area?
So just to clarify, we train most of our intensive care paramedics in the city, with the exception of a couple of large regional locations. And paramedics who are trained to an intensive care level do still have the opportunity to move to regional locations, so a Category B location. Those locations support up to 6 intensive care paramedics. They have a community of practice. They can work with other intensive care paramedics, and we would see that as the most effective way to support their practice. For those paramedics who have previously worked in those lower volume locations, we are grandparenting those arrangements and moving towards what we would say is a more contemporary and safe arrangement.
I understand that you've recently been put under some spending constraints. What measures have you put in place to ensure that those spending constraints don't impact on the well-being of frontline staff?
Thank you, Dr. Conn. So I can advise the committee that New South Wales Ambulance last year failed to operate within the budget that it was provided with, and early indications around our forecast for this year would also exceed the budget that we have been allocated. I have put in a range of measures to ensure that our organisation, which I would say has been the beneficiary of substantial investment over the last 4 years, quite significant, and I can provide some specifics on that on notice if required. But I've put in a range of arrangements to ensure that the responsibility that we have as public servants is to work within the budgets that we're provided, and I'm confident that we will be able to do that and continue to deliver the level of service for which is purchased from us, and also with a priority on the wellbeing of our staff. There are no wellbeing programs or measures which would be impacted by the current financial management arrangements that have been put in place.
That's helpful background information. I think it would be helpful to get a bit more detail about some of the things that you're talking about. So I said you've made an assurance that that's not impacting staff.
Mm-hmm.
What areas is the spending being cut back from, and how are you ensuring that that's not impacting them?
So we've got a range of opportunities to improve the efficiency of our organisation across our whole business. So whether that's in improving the experience of our staff and reduction of burden on our staff around overtime, for example, that could be avoidable, to better manage fatigue, improve access to breaks. So that's more in the operational environment, but equally there's some efficiencies within the way that we deliver our services, I'd say back of house, particularly around the way we manage and roster our resources, the way in which we consider performance in a contracts and procurement space, as well as deliver efficiency for the broader system. So we're taking a holistic approach to improving not just the financial performance of our organisation, but the value and contribution our organisation makes to the broader health system. I can, on notice, provide some additional information about some of those measures. Largely they sit in the realms of financial controls, which would be prudent and expected by this committee.
Thank you. I'm out of time. We'll go to the opposition. Mrs. Carter.
Thank you. Mr. D'Amato, do you have those figures about the palliative care budget?
I will be able to provide on notice. I can provide just an update on last financial year. The correct figure is 449 million. I just want to stress two things, if you don't mind.
Sorry. That's what, financial year 26?
Yes, that's correct.
And what was the figure again?
449.
449.
Yeah, this morning I quoted 447. It should have been 449.
Right. And so you don't have the financial year 27 figure?
No, because of two reasons. But before I go to this financial year being 27, I just want to make sure that I want to stress two things. One is remains unaudited. Last financial year, we haven't completed the audit process.
Would you expect it to change?
Look, at this stage, I'd rather be conservative, simply say once the audit office provides all of that.
Yes.
And the second part is that in terms of the accuracy of these values, we rely heavily on the information provided by the districts through a process where we cost every single encounter.
Yes.
The process normally is completed around February the following financial year, and the information there informs also national efficient price and the like. So that's the reason I want to be very clear that these are estimates. I'll be able to provide an update once we finish the audit process.
Okay.
But ultimately...
So when you say you'll provide an update when you finish the audit process, if that hasn't finished by the time questions on notice are due, what's the mechanism by which you'll update the figures for me?
Look, ideally, I'll feel very comfortable if I can provide the update in February when we get all the data from the districts for last financial year.
Perhaps you can give me running updates, is that possible?
I'm happy to do that.
Great.
As I said, we really rely heavily on the detailed data provided by the
Because you'll understand why February might be a bit late for our purposes.
I appreciate that. But as you also appreciate, there will be an update through the annual report, which unfortunately won't cover 25-26 because and that is one of the reasons why the agreement with the published data in the annual report relies on
thank you. Later. Who should I ask? Is it you, Mr. D'Amato, about allocation of funds to LHDs?
You can start with me and see what
because
I can do.
I've been told that at least 4 local health districts have indicated that no local health districts received the final year of enhanced funding as per the comprehensive funding plan submitted for the final year of the world-class end-of-life funding. What can you tell me about that?
Well, look, I can describe the process that we
No,
have
I'd rather you tell me, has the funding been allocated according to the submitted business plans, yes or no?
I can't answer that question
Who
because
can answer that question for me?
I think, Ms Carter, the piece of work that we've done is actually to annualise the funding. So in previous commitments, as you'd be aware, it could be for 4 years, and at the end of that 4 years,
So, Ms Wood, as I understand what happened
well,
when
I
the
can't
initial
answer the
cuts
question
were
for you if
made.
you won't let me answer it.
Well, I'm just trying to make sure you understand exactly what my
Sure.
question is, because I don't really want 20 minutes of what the process is.
Sure.
What I would like to know is, when the changes were made to the world-class end-of-life funding component of palliative care funding, providers and local health districts were asked to resubmit business plans, and they had a 4-year business plan. The first 3 years have been funded. Now, with this last year, the funding bids have been put in, and I am told at least 4 local health districts have been told there's no money. So what's happened to the 4th year of the business plans for the world-class end-of-life palliative care funding?
So, Ms Carter, I'm sorry, I wasn't in this role 4 years ago.
Okay.
All I can tell you is that the funding has been annualised. So every LHD has that funding in their base allocation. So they get growth on that every year.
So is the problem that the LHDs have been given it, but they don't see it as world-class end-of-life palliative care funding? And so
I
therefore
can't
they're
answer
using...
that question, Ms Carter,
who
'cause
can
I'm
answer that for me?
Well, you would have to ask the LHDs directly.
Okay, I believe... who's here from the LHDs?
I'm here, but
Okay.
I don't know that detail for that
Who,
line.
who would know that detail in your LHD?
My CFO would know that.
Well, on notice,
Yeah, sure.
can you provide me with details? Who else do we have here from LH? Could you come forward, perhaps? What can you tell me about palliative care funding in your LHD?
Yeah, I'll have to take that on notice myself. So, yep.
Okay.
From Murrumbidgee Local Health District.
Murrumbidgee, thank you.
Yep.
And Ms Wilcox, what are you able to tell us?
Thank you, Ms Carter. I cannot give you the absolute figure. I'd have to double check that, so I'll give accurate information to the committee, but we did receive an enhancement, and we did receive an enhancement for additional FTE, as in staffing, to support the process.
Right.
But I can...
So do you understand why palliative care services are hearing from local health districts that there isn't money in the world-class end-of-life funding?
I couldn't comment on that. We have a clinical director in cancer and palliative care that I work very, very closely with. Dr Agarwal from Concord Hospital heads up the palliative care stream there, and we work very closely on this. We're obviously great supporters of this funding enhancement, and we have a very strong culture in our palliative care services. And we did receive an enhancement in the budget, and we have been recruiting to additional FTE. But the absolute number, I'll take on notice.
Because I think we're all in furious agreement that palliative care should be well supported, and if money's been allocated in the budget but it's not getting to its intended recipients, then we need to understand that a bit more, I think.
I'm very confident that our enhancements are getting down to the teams and to the patients who require the care. And I'll come back to the committee shortly on the figure.
Really different information, and it would be good to understand exactly what's happening, because people we want not to be affected by it are the dying.
We understand that, Ms Carter. It's very important to us also.
Thank you.
Yeah, thank
and
you.
I believe there's somebody from Central Coast LHD, is that right? Did I miss here?
Not the Chief Executive, Mrs Carter. We've got a public health physician from the Central Coast.
Right. Okay, thank you very much. With respect, I think Ms Wood, we were talking this morning about the federal funding going from the palliative care and aged care. So the state funding, is that continuing?
So we are still continuing to provide those services, Ms Carter, yes.
Great, okay, thank you very much. And you said you're in conversation with the federal government.
Yes, we are.
Do you believe that they will be recommitting funding?
Look, we would hope so, Ms Carter. And look, it's fair to say, even in last week, the federal government has increased a commitment to services they previously said they would not. So it is absolutely important that we continue to lobby the federal government on behalf of our communities, and we'll continue to do that.
Okay, and have there been any positions for palliative care and aged care that have been cut because of the change in funding?
None that I'm aware of, no.
Right. On notice, would you be able to check if...
Certainly.
Yeah, that would be very good. Thank you very much. And what's happening to make sure that palliative care funding in the budget maintains pace with demand? So
sure, I can certainly answer that, Ms Carter. And look, that was the reason that we actually put it into annualised funding, because that is how we do increase our activity and subsequent budget for all services that we provide right across the system.
Okay. So what's the mechanism to make sure that it keeps pace with demand?
So each year the funding growth allocated is based on population demand predominantly, as well as activity growth that we see coming through.
So population demand isn't just population growth, it's people requesting a palliative care
That's
service.
correct, or in some areas where we do have higher older residents, obviously that's not related to every resident of an aged needing palliative care, I take your point, but that is obviously the reality of an ageing population as well.
Okay, and can you tell me how many palliative care referrals and admitted patients there have been each year for the last 3 years across the New South Wales health system?
I would have to take that on notice.
Okay, no, thank you very much. Great. Thank you. Thank you very much. Who would be the best person to discuss the new conscientious objection provisions in the new policy?
If you're referring specifically to the termination of pregnancy policy,
is there another conscientious objection policy that's been produced by health?
Not that I'm aware of. Sorry, it's just the only one I am aware of.
Okay. Okay. Why does it limit the provisions of Section 9 of the Abortion Law Reform Act?
My advice, Ms Carter, is that our legal team participated in the review of the document.
Yes.
The policy provides additional clarity on who the conscientious objection provisions apply to and who they do not, and that is in line with the Act.
But it limits, the Act provides conscientious objection for health professionals, but the policy seeks to limit when that starts and when that finishes. So it specifically says in this new policy that acts preparatory to are not part of conscientious objection, whereas most people with a conscientious objection would see acts preparatory to, and Section 9 of the Act simply says health professionals, it doesn't limit it in that way. So why does the executive policy seek to limit the legislative provision?
Ms Carter, I can only reiterate what I've been provided by our legal team, and
perhaps you could go back, because I really don't understand how a policy can be narrower than a legislative provision.
Sure, we can take that on notice.
And do you have any advice about the change in language in relation to trying to find the exact words. So the previous policy was said to cover public health organisations and approved health facilities, which is a term well understood because it's defined in the Health Services Act. But the new policy, the language has changed, and it just talks about all facilities. What was the intent of changing that language?
I would have to take that on notice, Ms Carter. It's not something I'm aware of specifically. That was a conscious decision by anyone particular, so I'd have to take it on notice.
Okay, because it significantly changes the meaning and seeks to extend significantly the reach of the policy. What consultation was undertaken with faith-based hospitals before this policy was produced?
They were consulted, I know that much, Ms Carter, but I'd have to take the details on notice.
If you could, and can you specifically ask if they were consulted about the change in that language, because that seeks to reach past the Health Services Act definition into a range of other facilities. With respect to that, I notice that it specifically talks about who is and who isn't able to conscientiously object, and the policy says that those engaged in administrative or managerial tasks in relation to the provision of abortions cannot conscientiously object. But who has looked at this policy in respect of the obligations of every PCBU to manage hazards and risks in the workplace, including psychosocial hazards?
Ms Carter, again, I would have to take that on notice. As I said, the advice I've provided you is what my legal team have advised me, so anything further would have to be on notice.
Well, if you could take that on notice, because if a ward clerk who believed that an abortion at 22 weeks was taking an otherwise viable life, if they were required to find an operating theatre and schedule that procedure, isn't this likely to create a stress response which could lead to psychological or physical harm?
Ms Carter, again, I would have to take that on notice.
Because, yeah, I just wonder what has been done in terms of the OH&S and safe work.
I absolutely appreciate the question. We'll take it on notice.
Okay, thank you very much. Who can I ask about eating disorders?
You can ask me about eating disorders.
Sorry, it's a two-way conversation, one-way conversation. So the Agency for Clinical Innovation reviewed the New South Wales Service Plan for Eating Disorders. Have those recommendations been accepted?
I am advised, Ms Carter, that we have actually decided to do some further consultation. We want to extend it to make sure that we have got further consultation with people with lived experience, as well as specifically some of our Aboriginal population and community members. So until such time that's completed, which we do anticipate to be at the start of 2027, the existing plan and recommendations stand.
Okay, so that work is happening now?
Correct, yes.
Great. And will that work be published?
Yes, I understand it's intended to be.
Okay, and who's conducting that work?
The Agency for Clinical Innovation.
Okay, and why, if you see this as a lacuna in the research, why wasn't this addressed when the agency was first asked to do the evaluation?
Look, I would have to ask that of the team, Ms Carter, but all I know is that we are very, very committed to the experience of people who have got eating disorders and hearing from them, and I can only assume if it has been extended that there has been a further intent to do that more broadly, and that's why.
Yeah, if you could on notice, tell me why that wasn't. What funding was allocated in the budget to for eating disorders currently? So you're not implementing recommendations yet, so what's the current funding?
Thank you. I can actually give you that. In 26-27, we have $20 million in recurrent funding that's provided for the eating disorders program.
How does that compare to, for example, other $20 million across New South Wales Health, given that we know the figures that as many people die of eating disorders as die on the roads, doesn't sound like very significant funding, does it?
No, I can appreciate why you would say that. So this is specifically targeted for eating disorders programs and some of those specific inpatient services, such as the one at Newcastle as well as the one at Sydney Local Health District. It's important to note that when a person who comes into a hospital, they come to an emergency department or a general ward or an intensive care, that's part of the general funding that's provided to the hospital. So people who have eating disorders would still be within that funding environment. This particular $20 million is specifically programmatic for eating disorders services.
And from memory, about 12 million of that supports the facility at Newcastle, is that right?
No, it's 12 million is identification and treatment, and just over 8 million is specifically for the Newcastle
Flip
facility.
the figures, right. Okay, thank you very much.
No problem.
So the review did find that the service plan reporting had provided an important accountability mechanism. Is there a desire to implement a new service plan to keep that accountability mechanism going?
I think it's the service plan is really in response to the changing needs and what eating disorders looks like now for people, as we said, with changing lived experience expectations. The accountability piece is an important piece for our system. It's certainly something we're very committed to, so it would continue. The monitoring and evaluation functions are part of all of our service plans and provisions, which are an important part of it.
Okay. There have been major workforce issues identified. What work is being done to develop workforce in these areas?
Do you mean with eating disorders specifically, Ms. Carter?
Yes, sorry. Because there's major issues even with diagnosis, isn't there?
Look, I think it is a complex. It is a complex condition. So there is a lot of education and training and thinking that's gone into this, Ms. Carter. As I said, there's obviously the specific services for eating disorders, but as I mentioned, there will be people with eating disorders who find themselves in general services, and it's important that that training and education is more broad than just within the specific services.
Oh no, I agree. Who can I ask about something we raised last time about the New Street and Safeways programs?
That's also me.
I'm really not trying to do this till
That's okay. That's
We
okay.
have a break after our
Last time we spoke about these
Yes.
programs for children with problematic sexual behaviours. What's happened? So, in answers to questions on notice that I received about this, the answer was most LHDs receive funding to implement these services. Why not all LHDs?
Thank you, Ms Carter. So at the moment what I can tell you is that there are 14 LHDs and that also includes Albury-Wodonga Health as well that have been provided with that funding. What we do though is...
Could you tell me which 14 there are?
I haven't got it here in front of me, but I can certainly provide
Thank
it
you.
on notice. What we do is that the Sydney Children's Hospital Network are actually funded to provide specialist clinical and cultural advice statewide. So as you mentioned before, in terms of sometimes with recruitment it can be challenging. That's why we have got that statewide support that is available to districts and networks who may not have the advice that they need on hand.
So in 2024-25, 128 referrals to the New Street services, that's the 10 to 17-year-old service, were not accepted. That was exactly half of all referrals. What happened to these young people?
I don't have that number or advice. I'm sorry, Ms Carter, I'd have to take that on notice.
Okay, so what are we doing to increase capacity in these services so we're not turning away half of those people who are referred?
Well, I don't have that information that we've turned away half. I don't have that information at all.
What data do you have about how many people were turned away?
We actually
from
don't collect it at a state level, so we can certainly provide on notice where we're at the moment. I do not have that in my notice.
I guess my question is, if nobody's collecting that data at a state level, how do you feed into the budget what the needs are?
Because it's provided locally. So the local health districts would actually raise it if they had a concern through an annual budget process.
So how many LHDs are there across New South Wales?
There are 19 districts and networks.
So should I assume that only 14 get funding, that there's 5 that just say we have no issue with problematic sexual behaviours here, we don't need money for it?
No. So the work we do statewide is to work out where there are challenges and certainly the actual LHDs that have identified that they've got challenges we work with very closely. The service provision across the state is networked and where we see that there are areas that need the additional
So you're
support,
aware,
that's
are
provided.
you, of figures from health department officials that over half of all child abuse is child on child, and these services deal with exactly those sort of problematic sexual behaviours. Are you telling me that there are areas across the state where that just isn't a problem and we don't need to be addressing these issues?
No, I did not say that at all. What I said is that we have the Sydney Children's Hospital who provide that statewide oversight. It's a highly complex area, as you can understand, Ms Carter, so we have to make sure that we have the right people providing this service in the right place.
But we have to make sure it's provided too.
Well, you're out of time, Mrs Carter. I'll go to Ms Fairman.
Thank you, Chair. Good afternoon. Now, Dr. Chant, I just wanted to ask where we were talking a little bit about Drug Summit before with the Minister. Where is the alcohol and other drug strategy up to?
So there was a recommendation on the Drug Summit that there was a whole of government. That's in the final processes of consultation. Yes, so that's been consulted, and
so a strategy has been developed internally.
Strategy has been developed, and we are in the process of putting that through government processes.
It's not something else that's just stuck in what they call cabinet, is it?
I couldn't comment, but I think it's in the final stages of.
It's blocked in the pipeline.
No, just it should be available shortly.
Was that, in terms of consultation, did that kind of go out to stakeholders, or is this a kind of internal policy document that's gone to government?
It reflects the stakeholders' views that were heard through the summit, but it has been consulted. I just have to take on notice the exact process and where we're up to with that. If I can just refer to my notes. that would be great. I'm happy to take some other questions and come back to you.
Okay. I did want to ask about alcohol presentations to EDs, to emergency departments. This is looking at the Health Stats website as well. And I've kind of done it really because I've also got the portfolios of music, nighttime economy, and have been quite across the government's vibrancy reforms. It does seem that, though, that since COVID, even before COVID, that rates of alcohol-related presentations have increased. So I've got the stats from pre-COVID, so 2018. It was a peak in 2018 of 7.4 per 1,000. However, in 2025, so just last year, the annual rate of unplanned emergency presentations for alcohol problems increased to 8 per 1,000. Is this a trend that we're seeing, and something that New South Wales Health is addressing and communicating with other arms of government about?
So clearly alcohol is a major preventable risk factor, and a significant proportion of the population drink outside the guidelines. So we are concerned about alcohol, and we're actively looking at strategies to both minimise the acute harms, but also alcohol contributes significantly to other risks such as domestic violence and other aspects, as also being a key contributor to overweight and other dietary impacts. So yes, we are concerned about alcohol and other drugs, and we have reviewed the evidence for the sorts of interventions that we as a system can put in place, as well as continuing to work across government at how we could keep alcohol use and remove the harms associated with alcohol use.
Yeah, thank you. And for this question is really just alcohol. I do ask a lot of questions about all the other drugs, but this is alcohol.
And I think it's a really important factor because, as you're aware, alcohol causes the major of all, when we talk about alcohol and other drugs, we are very concerned that there is an appropriate focus on alcohol in the health of the burden of the health of New South Wales. We do call out alcohol, its impact, particularly on the younger age groups. But as I said, it also is a risk factor more broadly.
Are you aware of, with this latest data, where where presentations were the highest?
Look, I'm just trying to get onto health stats as we speak.
I'll jump in because I got there.
And could I just go back and say that my original response was correct, that the consultation draft is with government in terms of the for the whole of government strategy, and so I'm sure that will be appropriately available. In due course.
Thank you. Well, I wouldn't be so sure, to be honest, but given how other things seem to have stalled in that area. I just mean the very general cabinet area when I say that, by the way, not necessarily health. It says that presentations were highest among males, people aged 25 to 64 years, and in metropolitan local health districts. In some ways, I don't want to say that that's surprising, but it is surprising to me that that was the highest in terms of alcohol. Maybe I was expecting it to be regional, but maybe it's always been like that. What formal role does New South Wales Health have within the overall vibrancy reform? So when the government is considering relaxing opening hours, allowing pubs to trade later. How has New South Wales Health consulted, for example, the last couple of vibrancy reforms?
So Representative New South Wales Health sit on those, are a participant in those interagency forums.
Is there, when you're saying those interagency forums, is there anything more specific in relation to the vibrancy reforms that provides a formal role for you?
There has been a vibrancy committee, and I'm aware of one of our senior clinicians is actually on that committee representing us, and I think ambulance is also represented. Our role in those is both to present the data, to ensure...
So you do present data like this?
Yes, we present data like that, and ambulance call-outs are also a component of the data that is presented. We also work closely with academics and others to understand the evidence base for drivers for harms associated with alcohol, and do present that evidence base in those discussions.
I think what's interesting with this is we're consistently hearing about the changing appetite, the changing nature of young people in terms of what their relationship with alcohol and how much, if at all, they're drinking. So it's surprising to see higher rates of emergency department presentations than pre-COVID, because a lot of the stories and the research is saying that people are drinking less. Pubs, clubs, restaurants are doing it tough, possibly in some ways because of that. So is it, do we know whether it's because when people are drinking and choosing to go out, they're drinking more? Is there any explanation for these increases? And also, Ms. Beach as well, if the ambulance has it, paramedics have any?
I think it's always important that there is a global trend for young people in relation to alcohol, but it can mask the fact that there still is harms in some populations. We've got to also make sure we're distinguished between binge drinking, which is associated with different harms than chronic alcohol misuse. So what we're learning is we have to actually provide and subset the population harms and really do those deep dives, and we work with academics to sort of understand what are the drivers.
It's kind of just the increases that I'm curious about, and again, I think it's important because of the regulatory changes, which the Greens supported, by the way, but that it's important to know if alcohol dangers, it's not alcohol intake, it's the presentations, if they're increasing, is this linked in any way to later hours?
Well, we know
it sounds like the work hasn't been done.
I mean, look, we know the evidence is greater access, availability, duration. There are some... we know the evidence is where the evidence sits with relation to some of those, and so obviously that's the role of government in trading off some of those decisions around potential health harms. And so just to assure you, we're closely monitoring the information, and probably I can answer a question that you answered this morning, which I think was really insightful, that you'd indicated that you were concerned about the methamphetamine use. And the team really, we don't exactly know what's driving it, and but there was a convenience sample of surveys that NDARC did that reports over the last years that there's a move to more potent forms and more frequent use, but the population surveys are showing it's not going up. So again, it's the fact that you could have still the same number of people using, but if they're using more potent forms and more frequently, then we're more likely to see the harms. But it seems to be an area we need to research. So just to let you know, we're very interested in doing those deep dives and understanding that. Apologies.
One quick question. Abigail said yes. This would indicate that of the need for community-based drug checking services, not just music festival drug checking services, wouldn't it?
So just to the role of drug checking services are the fundamental role of a pill testing service is actually to do the brief intervention about reducing the harms associated with that. Now, we can deliver that message in different ways, and the mix of services. If we're looking for contaminants or other changes in the profile, we also have work with police where we actually do other broad-based testing.
It's okay,
So again,
Dr. Chan. Yes, thank you. Thank you. I'll go to Abigail. I wish you were the minister and I could have asked you that in a political question, but thanks for trying.
Good afternoon. Okay, so I wanted to go back to fatigue risk. So before Section 26A commenced, how many additional medical FTE did health calculate each LHD and specialty would need to maintain services while providing code-compliant recovery after rostered work, recall, overtime, leave and vacancies?
Sorry, just to clarify, you're asking how many additional staff we thought?
Yeah, so when you knew the code was coming in under Section 26A in relation to fatigue management, how many additional staff did you calculate were required across each?
We haven't calculated additional staff needed because, as you know, the code is about applying the risk management approach to the environment that we operate in. So the assessment is about what is reasonably practicable within the environment that we operate and within the industrial instruments that we have. So,
but does that mean you're not compliant then with the
no, absolutely.
code?
So the compliance is about the application of the code to the health areas, and we're working with our districts around it needs to be considered as part of an overall approach to fatigue management. So it's not just about the staffing numbers, it's about the rostering, the additional supports, the training that people have. So we're being guided by the Work Health and Safety, the Safe Work, New South Wales work around the application of these standards to work.
But if you knew that 12 hours between shifts was required under the fatigue code, and that health policy permits 10 hours currently, then you would have known that there would have been a need for that difference in rostering. So did that then result in needing more staff?
No, so just to clarify, the 10 hours is in our industrial instruments. It's actually in our awards and provisions. So we don't change those because the new guidelines state that this would be, an appropriate rest break. We're also obligated to take into account our operating environment and our employees' feedback in terms of how they like to work. So our awards provide for the breaks between shifts, and we're still required to apply those awards unless we negotiate a different award with our unions.
But when we spoke before, so at the moment there are 10 hours between shifts for some.
Yes.
But the code says 12 hours.
But our awards provide that. So the industrial instruments govern the rostering that we have.
Okay.
What we're required to do under the legislation is to assess the standards holistically in terms of both the operating environment, but what additional measures we put in place to manage fatigue. So it's not just a straightforward application of those requirements across into the workplace, and every organisation is required to think about the application of the standards into the operating environment and to consider what additional controls or measures you can put in place to manage fatigue.
Sure, but Section 26A of the WHS Act imposes mandatory compliance with those codes of practice. Am I being thick, or is there I don't understand. So from the 1st of July, required to comply with the code. The code says at least 12 hours between shifts. At the moment we've got 10. So are we in breach of the code?
No, so there's a distinction in the code between mandatory as in must and recommend as in should.
Right.
And there's always an interplay between codes of practice and industrial instruments. So ultimately the award needs to be the key document that we roster to, because that's been negotiated with our unions, with our staff, and that is a legal instrument.
And that's the legal requirement. Like, have you been advised that that's
So
what Section 26A does?
We have worked through those requirements.
Okay.
I did want to stress what I said earlier, which is that of course we want to do more work in terms of managing fatigue. It's an issue that we're always going to be working to, but it's not a direct translation across from the code.
Okay. Can you tell me how many workers' compensation claims have been made in the last 3 years in health, citing fatigue, excessive hours, or inadequate recovery time?
I don't have it in front of me. I'll need to take it on notice.
Okay. Has New South Wales Health notified Safe Work of any incident where worker fatigue arising from the conduct of the business was a factor, including motor vehicle accidents on the commute home?
Again, I'd need to take that on notice. And just to clarify, each local health district is a PCBU, and so they report sometimes directly to Safe Work on some of these issues, but we do undertake an oversight role in the ministry, and so I will do my best to see if we can gather that information.
Okay. The Safe Work advice in relation to the code, I'm sorry, just coming back to that question before. So should is used to identify the standard required by code. PCBUs can only manage the identified hazard or risk in a different way if doing so provides an equivalent or higher standard of work health and safety than the standard required by code. But you're saying that the lesser standard in the award overrides.
No, what I'm saying is we have to apply the award. What we then need to do in assessing the risk and the compliance with the standards is look at what additional control mechanisms we can put in place to supplement and make sure that people working within the award requirements are able to have effective measures for fatigue.
Okay, but you're breaching the code.
I don't agree with that, because the code provides guidance in terms of the implementation in an operational perspective. The test is what is reasonably practicable, and if you take an organisation with the complexity of the health service, clearly we do have requirements around rostering, and we are working through at the moment what additional controls or factors we can put in place to provide additional measures for fatigue management. But at the end of the day, our award requirements need to continue to apply.
So you mentioned before that the LHDs are PCBUs, but presumably New South Wales Health is still a PCBU as well?
Yes, we are.
So how do the ministry satisfy itself that districts are meeting the duty then?
Yeah. So we undertake a policy development and oversight role for the districts. We set policies and procedures and we update those, of course. So with the recent changes to the legislation, we worked across the system to ensure that we are compliant in terms of policies and procedures. We also undertake audits on an ongoing basis in relation to specific issues, but also in terms of the application of policies and procedures at the hospital level.
You're currently negotiating the award, you were saying before, the one with the 10 hours in it.
Yes.
Yeah. So presumably you're not going to negotiate around the number of hours. Like that will just be brought up to what's in the code?
Not necessarily, no. So there's a lot of discussions around work and around the expectations around fatigue. So the 10 hours needs to be taken in the context of all of the other arrangements that people have for their work.
Are you using the 10 hours as some sort of bargaining in the award negotiation?
Are we, as in New South Wales?
As in, yeah.
No.
No, so you're not insisting on the 10 hours?
No, so the 10 hours is the status quo, unless one of the parties brings forward a claim to change that, then that continues.
But wouldn't they just look at the code and go, well, the code says 12, so now that should just be automatically included in the award?
I think the key point is the code applies generally across industry. Our award is fit for purpose for the purposes of health in terms of rostering.
But fatigue,
so it doesn't necessarily need to be increased.
But fatigue is like a serious risk to patients. Are you saying that when it comes to these, specialists, that they're just somehow less in need of meeting the 12 hours that's been agreed to be the safe standard for everybody?
No, I think what I'm saying is you can't just look at the hours in isolation of all of the other arrangements that are in place in the workplace. It needs to be looked at holistically, and the codes require you to assess the control framework that you have which in our particular case include a series of policies, procedures, supports for employees, guidance for managers about how to manage fatigue. So it needs to be reviewed as part of the whole workplace environment.
Thank you.
I have a question about back pay for the nurses as the government meets its legal obligations arising from the Industrial Relations Commission decision. I understand that nurses and midwives directly employed by New South Wales Health started getting back paid in May. There was then a delay for nurses and midwives employed by affiliated health organisations. Why haven't former staff yet received the back pay that they're owed?
I think the answer is that there is a significant number of former staff, and we're working our way through. Initially, we prioritised the back pay for current employees, but we have now started working our way through back pay for former employees.
I'm sure you can appreciate the urgency of this in a cost of living crisis. You know, I've spoken with a nurse who's owed $2,000 of back pay and hasn't been told when to even expect that. What's the expected time frame to be able to work through the former employees?
If you'll just bear with me for a moment. HealthShare, who is our payroll provider within New South Wales Health, is working on a system update for the back pay of former staff members, and we anticipate that to be finalised by mid-October.
Sorry, so they require a software update
There
to
is
be
a
able to
system
pay
update.
people?
Yeah, so
I don't
we
understand
could,
this.
So because each person who's left has specific dates or specific time frames, there is a complexity in calculating the back pay. If we were to do it manually, it would take a long period of time. What HealthShare are doing is updating the system to allow for an automatic payment for those employees, and that will be done by mid-October.
When was that issue identified?
In terms of the need to back pay or the need for the system fix?
The need for a system fix to be able to do it.
We started working with HealthShare as soon as the IRC awarded the outcome, and our focus initially was to get the increase in pay for everybody, just to be able to pass on the increase, and very concurrently with that we were working on the back pay issue.
Mrs Mitchell.
Thanks, Chair. I think Professor Nicol, this one might be best directed to you. I wanted to ask about the remanufactured single-use medical devices. I understand other states are using them, but New South Wales isn't, and that was based on advice from the Clinical Excellence Commission. Is there anything you can tell me about that?
Thank you. Look, this is a very complex situation where for the first time there is consideration of reuse of goods that were meant for single use. And under the current regulations, those single-use devices should be disposed of appropriately. Look, we're in the middle of dealing with a number of medical device reforms under the TGA direction that relate to both pre-market, in-market and post-market issues. A number of these are directly relevant to this particular issue. One of them relates to unique device identification and tracking, and with respect to recall. Currently, under the TGA provisions, medical devices that are repurposed or remanufactured are considered new devices. So in terms of tracking, there will be no way for us to track those devices into the future. That issue is among many issues that we're seeking further advice from the TGA about. One of the important things that we've learned from overseas is that when you are repurposing or remanufacturing single-use devices, you need to be able to track how many times they've been repurposed, remanufactured, so that they're still fit for purpose under their original ARTG registration. So there are issues that we haven't yet fully addressed that relate to the TGA regulations that would allow us to feel comfortable that we can move into that space straight away. We are not the only jurisdiction that has concerns. You've mentioned that that many jurisdictions have moved towards using remanufactured devices. Every jurisdiction in Australia still has concerns, and there is an interjurisdictional group that is meeting with the TGA to try and work through these regulatory issues. It is a very complex thing. Obviously, we need to consider what's driven us to single-use devices and our reliance on single-use devices. I think we've got to get to a position where we're using multi-use devices rather than single-use devices. So addressing some of the drivers is also an avenue that we're exploring. So it's not a simple issue. The economics make sense. If we can reuse something, absolutely, from an economic perspective. But from a safety perspective, there are things, particularly with respect to us being able to track and trace, to recall, but also to have reassurance around the number of times that they've been through a remanufacturing process. Until they're addressed, I think we need to take a fairly cautious approach.
Thank you. Thank you for that. Thanks, Chair.
Thank you. That brings us to afternoon tea, and we'll be back at 3:45. Thanks, everyone.
Thank you.
Yours, Emma-Ville?
I was going to say,
Yeah.
I'm sure it'd be weird. Mine.
You know, I get it.
Welcome back, everyone. Order.
It's normally us that have to.
Yes, exactly. That's the first time I've had to call the department officials to order. We'll resume the hearing for our last block this afternoon with questions from the opposition. Go ahead, Mrs. Mitchell.
Thank you, Chair. I just want to come back, if I can, to you, Ms. Beach, some more questions in relation to sort of call-outs. One of the things that gets raised with it, well, there's two issues. One is the transfer of care delays, and I mean, it's probably a technical way of maybe saying ramping, I'm not sure. But do you keep data for how many paramedic hours get sort of lost to delays in that transfer of care sort of methodology, I suppose?
We don't.
Okay.
What we record and report on is the transfer of care time, which is obviously reported at a system level and managed at a system level.
Yeah.
So that is what we report on. And we have a range of escalation processes in place, both for our clinicians as well as within the LHDs, to resolve transfer of care issues as they arise. And there is an escalation process that my colleagues would be.
Is there any? I'm just trying to understand, maybe over say June and July or whatever you've got for this winter, any data in terms of those sort of delays of transfer of care that you can provide either now or on notice?
I'm happy to speak.
Please, yeah.
And particularly to an earlier question that you put to Claire, just put some metrics around it. I mean, we work on the publicly released information, which is through the Bureau of Health Information. And over the last 3 years, to your question earlier of Claire around ambulance presentations, has seen an increase of 39% to emergency departments. So they are patients being delivered by ambulances. In that same period, the transfer of care that Claire was talking about improved by 3%. Now that was across the system, and you know, as we all see, we're not delusional. The system performs different ways in different areas because they all have different geographic and other pressures, and so you know we're all very sensitive to that, which largely distributes the kind of input, support and effort that occurs from the ministry to work with those districts that are experiencing difficulties. But as a system, it's kind of grown constantly, and the big safety indicators are transfer of care because it's putting resources back in the community. And the other is the time to treatment, particularly for T1, 2 and 3, that are the sickest presentations, and they've increased in those 3 years by 11%. But the time for them to be seen is actually improved by 2.5%. So on the safety indicators, there's no doubt the system is performing well and more safely than it was 3 years ago. Are we meeting everyone's socio-demographic needs in terms of time to wait, etc.? I think that's self-evident that on occasions we let people down in terms of how quickly we can see them, but that really then calls on the ministry to engage with individual hospitals and emergency departments, and that's where my teams work very closely with those hospitals and those EDs.
Thank you for that. If I can just come back to you, Ms. Beach, and I appreciate you weren't in the role when this time, March, when I put this forward. But I asked a question in March that was taken on notice by your predecessor just about the 500 regional paramedics. There was a $438 million allocation, which was effectively an election commitment of the government. But I asked for a breakdown of the commitment that would be for sort of operational expenditure, including like salaries, but also what was going to fleet and equipment. And that was taken on notice, but I didn't actually get an answer back that reflected that. I was told that 250 FTEs have been allocated, which was great of that 500, but I was keen to understand how much was going to salaries and how much was going to capital works, vehicles, fleet, etc. Do you have a breakdown of that, or could I ask for it again on notice and maybe hopefully get it this time?
I'll commit to giving that to you. The update on the staffing is that the Regional 500 commitment, which we've now entered our final year, we have now delivered 375 paramedics into regional New South Wales, with a final 125 to be delivered in this financial year, and that's on track. With respect to your question around fleet and infrastructure, I will pick that up and we'll be able to provide that promptly.
Thank you. That's great. I appreciate that. And then also just sticking with you if I can, and I know that the Chair asked a few questions about the intensive care paramedics. Do you have data, and again I'm happy if you need to take it on notice, I want to understand how many ICPs are currently stationed in each of the rural and regional ambulance stations, and what that looks like even by zone or however you sort of capture your data.
So we do have that. I could take quite an amount of time to list all of that here, but I can provide it to you.
Yeah.
But we do have that information. We understand exactly where our intensive care positions are established and the extent to which they are substantively filled.
Yep.
At a high level, there's 896 trained intensive care paramedics across metropolitan and regional New South Wales. And with respect to your question, 437 of those are in regional New South Wales.
Okay.
So approximately half
Yep.
Of our intensive care paramedics are in fact in regional New South Wales.
And if perhaps on notice, if you could provide me the list of where they're stationed, and I appreciate it's a long list, so maybe if you want to do that on notice, that saves you and I time both now as well. And then in terms of any vacancy data in those positions, do you have any of that to hand?
I would be able to provide that basically with that same data set.
Yep.
We in 2022 we delivered a $34 million program to convert 246 paramedic positions to intensive care paramedic positions in regional New South Wales, and since then we have been working to both train and appoint intensive care paramedics into regional New South Wales. So as I say, happy to provide the breakdown at a station level and also the occupancy.
Yeah, that would be good. And then also, again, this is sort of anecdotally, but I've had it raised with me in a few different areas of the state. If a person in that ICP role retires, is that role then automatically recruited for a replacement at that ICP level, or what happens?
No, it's not at a category C and D location.
Yeah, which I think is part of what Dr. Khan asked
that
about.
response, yes. So if
Can I ask why not? So just in really simple terms, in a community when you're used to having access to an ICP, people retire or move or whatever, and that's part of life, but community also then asks questions of us in terms of, well, why don't we get a replacement or a replacement recruited? What's the rationale?
Yeah, of course, and I completely understand that, and I suppose what I'd like to assure the committee and also communities across the state is that our paramedic workforce are highly capable. Our intensive care paramedic clinicians are safest in our view, where they are working in areas where they are supported by other specialist clinicians. So we are delivering that level of care, and we deliver that level of care when there is sufficient workload or exposure to the types of patients who require that level of care. So this is purely around delivering best practice safety with respect to how our clinicians practice. So it's described quite clearly in our role delineation guide, much like how health services are delivered. We wouldn't tend to see, specialist scope of practice in many of those regional and remote locations for a range of reasons, but predominantly because it is safest to practice where that volume is.
Yeah, I mean, and I know, as I said, I know the Chair's raised this as well already, but I suppose my challenge with that is that in some of these, the more remote you go, the further you are to then access some of that specialist care, say in a hospital setting, right? So it feels like a bit of a catch-22, whereas if you've got the paramedics who can have that sort of in particularly the ICP roles that might be able to offer sort of clinical supports that isn't available at the local hospital, you've got to transfer further. I guess that's kind of the community push and pull on the issue, right? Which I'm sure you understand. But how do we overcome that? Because I would think the more remote you are, the more likely you are to need people who can upskill and offer those sort of services. So it's...
And I completely understand your question, and we spend quite a lot of time in community, working with communities on exactly these concerns. And I think respectfully to communities, it's about assuring community that the emergency ambulance response that is available in their community is of a high capability in and of itself. So as I mentioned previously to the Chair, our paramedics have in recent years had a fairly significant enhancement to their scope of practice. They are able to deal with all life-threatening emergencies through the full age demographic of our communities, from childbirth to death and dying and everything in between. And intensive care paramedics practice in locations where there is exposure to that work that is at a level that we can assure ourselves of their recency and currency under our credentialing framework. But I do accept that conversation is a very important one to have with communities, so that communities don't feel like they are disadvantaged by what is effectively a role delineation of services.
Yeah.
Just if I could ask a couple of questions in relation to the health-led response to mental health emergencies, which is going to be running in conjunction with or supervised by your virtual care centre. Is that how it's going to work?
Yeah, so we welcome this response. I think everyone around this table is incredibly supportive of a health-led model to addressing mental health in the community. So over a 10-year period, there'll be $270 million invested in this model. It will deliver a mental health hub, which will be hosted within our virtual clinical care centre.
So what changes will there be to the virtual clinical care centre?
So currently today, our virtual clinical care centre provides statewide secondary triage and referral.
So I ring 000 and
I'll
say,
talk you through it.
I have a mental health issue. They go,
Today they do not.
Okay, all right.
What this investment will deliver
Okay.
is a clinical workforce who is capable of doing that.
Right,
At the moment, in our virtual clinical care centre, we have a multidisciplinary team of doctors, nurses and paramedics. Their focus is less on mental health and much more on identifying 000 callers whose healthcare needs are not necessarily a medical emergency or a critical emergency, but where we can take a moment, provide a virtual assessment and make sure that the health system responds effectively. This model will allow us to provide that to mental health consumers.
But this model will run for 12 hours a day or 24 hours a day?
Currently it will run for 12 hours a day.
Which 12?
7 days a week. So that will be consulted. Obviously we have a...
sorry, we don't know yet which 12 hours it's going to run?
We don't yet. We will be consulted.
What's the thinking?
So the thinking would be that we would implement a model that best meets demand. Now...
So how will that be ascertained?
We understand where the demand is, and so what we'll be consulting with clinicians and consumers.
So how much time will that consultation take before it's up and running?
We are in consultation. We've made commitments to have the model of care in the early stages of delivery in January 2027, and that's both in the mental health hub, so virtual care.
Sorry, when you say in the early stages of care, what does that mean?
What I mean by that is in early 2027, we will commence delivery of these services.
So complete delivery, 12 hours a day, the 12 hours to be decided with the 8 teams in place?
I guess that's what I'm getting at. We will commence that and it will need to be scaled up over the course of
So how many
next year.
teams will it start with?
That has not yet been determined.
Who's determining that?
Well, we will be in consultation.
So who's the we?
So New South Wales Ambulance, in consultation with the mental health branch, and importantly, in consultation with local health districts, whose workforce, as well as their referral pathways, will be a key success factor to this model.
And when will the last of the 8 teams be in place?
That is not yet determined.
There's not a target for that?
Look, I mean, to be frank, as soon as possible in all reality.
Sure.
But we do have a lot of consultation yet to do. As you are aware, this is only just recently announced.
Yep.
So at this stage, what we're doing is setting up a program team. We're commencing consultation with industrial bodies, with local health districts and consumers.
What's the consultation with the industrial bodies?
Around working arrangements for the paramedics and the nurses who will be out as co-responders, as well as those in the virtual centre.
Okay.
We obviously consult with our industrial bodies.
So there's
on
no
all programs.
danger that as part of this consultation there will be obstacles that will delay the implementation?
We, in Western Sydney, we have been partnering with Western Sydney LHD for nearly 14 years on a very similar model. In fact, this entire investment is modelled on a tried and tested model in Western Sydney. So I'm optimistic that what we'll be consulting on is ways of working. The model itself is well established and has been demonstrated to deliver value and is safe. And virtual mental health care as well. We will not be the first to deliver virtual mental health.
And what are the locations for the 8 teams when you're up to full strength?
So we are currently completing some modelling. We've made a commitment to Minister Jackson's office that in October we would be providing advice to Minister Jackson and of course to Minister Park as well about where we would propose those locations be.
Regional, metro?
Largely metropolitan, and the virtual hub is designed to provide statewide access to virtual secondary triage.
And where will the where will the virtual teams, where will the response teams sit while they're waiting to be dispatched?
So they will start and finish out of ambulance stations. So the idea, and that's how it's been working for many years now. So the idea will be that we will pair a mental health nurse with a paramedic. They respond in the field like a normal ambulance, except they are tasked specifically to mental health cases.
So the entire workforce that you're adding are mental health nurses?
As well as paramedics.
And
so both.
Do we have any workforce issues with recruiting that number of mental health nurses and that number of paramedics?
And that's exactly the consultation which is going on, because we will be needing to partner with local health districts to ensure that that this model can be delivered within the constraints of the workforce that exists.
Sorry, when you say partner with local health districts to have it delivered within the constraints of workforce, does that mean that you're taking mental health nurses who might currently be in a hospital and an LHD, and they will then be working on these on these response teams?
Yeah, I mean that's how it's worked in Western Sydney.
So we're taking nurses out of hospital so that we can run this mental health.
I think what I'm acknowledging is that what we need to do is make sure that there is not any perverse outcomes associated with the workforce that is required to do this work. Paramedics are excellent generalists, but this model relies on having...
needs specialists, absolutely. I'm just wondering where, and what about paramedics? Are we reassigning paramedics who would otherwise...
There are additional roles, and we are accounting for that in our workforce pipeline.
So when you say additional roles, does this mean overtime for those paramedics, or does that mean different roles for the paramedics?
This means that we will be establishing additional positions that paramedics can express an interest in fulfilling, and we are taking account of what we expect that to be in our workforce pipeline so as not to impact the remainder of our operations.
Are some of these people likely to be perhaps skilled migrants from overseas if we don't have enough people locally trained?
I could not speak to that. I think our current approach, Ms Carter, will be to leverage the highly capable workforce that we have across New South Wales.
Because I think they're talking about recruiting 100 extra roles, is I think the figure, is that right?
133 additional roles across both the virtual and the co-responder.
And we have 133 roles, paramedics and mental health nurses ready by January 2027?
As I say, I wouldn't be committing to saying the 133 roles will be filled by January, not at all. I think we will be commencing the sort of uplift of those roles as we get through the investment. I probably should qualify though to say at the moment the intention is to access a mental health nursing workforce, but that's not to say that as we move through and we learn some lessons, there may be other workforces who are also suitable and effective to work with us in delivering this health-led response.
Thank you.
Thanks, Chair. Just probably, I suspect Mr Sloan might be best placed for this one, but the IPTAS budget announcement, I think it was $71.7 million. Is that an allocation for just for a 12-month period?
No, that's across the forwards.
Right, okay. And is there any work being done, or direction, I guess, from government to look at particularly the reimbursement rate per kilometre, given fuel costs have increased quite significantly? I mean, I know they're back a bit, but there's that threat and people have raised that issue. Is there any direction to look at that?
Yeah, we've not received any direction directly, but this is something that we continue to monitor and look at every single year as we review not only that, but in line with other states and jurisdictions and their reimbursement rates. So of course, our overnight rate is much better than, if not all the other states. The fuel crisis earlier this year and ongoing caused us to have a look at what some of those modelling figures would look like, and we'll continue to do it with regards to what services that are actually applied to IPTAS, so that people can access the appropriate clinical services as part of the reimbursement model as well.
Perfectly timed. I won't even get another one in. Chair.
I've got some questions to start with about the single digital patient record, and then after that I'll come to Dr. Taylor if you want to start the hot sheet shuffle. I think to Ms. Pearce, I hope you'd agree that the rollout of the single digital patient record so far has not been smooth. This is obviously a really critical project and there are lots of people invested in its success. What's being done differently for the next tranche of rollout to learn the lessons of the first attempt?
Yeah, thank you for raising it. Look, it is certainly fair to say that the rollout, which to be honest wasn't unpredictable, has needed to be refined as we've gone along. So we took a decision earlier this year that we would delay the rollout to the Hunter New England, for example, and started off with Justice Health so we could take that opportunity to learn some lessons from that process. I will also say that I'd really like to acknowledge the staff who've been working through this. It is very complex. The Hunter New England, and the Chief Executive's here so she can speak for herself, is a very, very large district. It was coming from behind where other districts are in respect of its ICT capability, Wi-Fi capability and so on, so that also created some challenges for us. We are absolutely taking on board and learning the lessons though, Dr. Con. I think it's important for you to know that and for our staff obviously to know that. It's really important. We're working closely with the unions in respect of that and taking some decisions as we go as to how the tranches will evolve over time, which we've done again recently, to reflect the fact that there's a lot of importance on getting, for example, the Northern Beaches Hospital on board toward the end of this year because, as you'll appreciate, following the various inquiries conducted there, one of the things that was singled out there was the ICT capability of that facility, and so it's of critical importance that we get that on board. But we have also taken on board the feedback from the staff with respect to the need to phase other parts of the system differently. It is really important from a staff perspective and from a patient safety perspective that we get this right. It's a huge transformation for our system and it will deliver amazing results in the fullness of time, but we are not running at it like a bull at a gate in order to get this thing implemented more quickly if it's going to create challenges and risk for our staff and for patients most particularly. But Elizabeth can comment further about where we're up to at the moment with the latest plans in terms of, you know, lessons learnt and where we're headed, and I think ongoingly in the Hunter. So the benefit of the Hunter often is that it is a very large district. It's got a very large metropolitan site, but it's also got a lot of rural, large rural, small rural. So it gives us a really good opportunity to sort of see how that works. And finally, and before I hand over, I think it's also important to acknowledge that we are hearing some very positive feedback as well from staff as to the application of this, in addition to where there are areas of challenge that we need to correct.
Go ahead.
Thank you, Dr. Conn. And look, I think to reiterate Susan's comments, this has been a huge effort by our staff right across the system. There's obviously Justice Health, New South Wales Health Pathology and Hunter New England that were all involved in the first tranche. I think, again, it is important to state that just Hunter New England alone is actually the largest EMR rollout Australia's ever done. So even just that one district alone was a very big undertaking. What we have identified is we've come out of what's called hypercare. It's a 2-month intense 24/7 period of support for the district once they've gone live. We got to the end of that and we still had some outstanding issues, which, you know, the scale and breadth and complexity of this is to be expected, quite frankly. What we didn't want to do was not pause and look at all of that element in terms of any technical build requirements, because obviously to do that consistently and carefully, if we didn't get that right now, it would then have a flow-on effect to the subsequent tranches. So in order to do that in a really fulsome way with the clinicians and the clinical teams, we have made the decision to really focus and support Hunter and New South Wales Health Pathology to really bed all of that down. And it's not really just about getting it right, it's actually about that optimisation that we will see that will really improve our patients and clinicians' experience in what that record can achieve. So it is really important that we invest that time and effort now. As Ms Pearce has mentioned, we do have a complexity with the return of Northern Beaches Hospital into public hands. That wasn't anticipated at the time of rollout, so we do have contractual obligations we have to meet. Now, in doing that one facility, it does give us a very, very good opportunity to look at what it looks like to do one facility in a really, really targeted way that then supports Northern Sydney and Central Coast in terms of their rollout, and then we'll consider from there what that looks like for the remaining tranches. But from our perspective, I mean, the rollout from here, it's really important, and certainly we're going through the process with the Audit Office at the moment. They have been very explicit about how we take on the learnings from each of the tranches, and so I think for us, taking on these learnings is an absolute critical part of our successful rollout going forward. And I think the last thing I would say is that there's two components to the work we're doing. One part is the technical build, the other part is the change in the processes and workflows that will be quite different for each of our districts and networks, because they're all coming from a different system into a single different system. So it will look a bit different, and so I think working through that at the moment with each of the tranches that are coming is really important. So we're putting a lot of time and energy in that as well.
Yeah, and that implementation, noting it's become more complex because it sounds like you are learning the lessons from the first tranche. Is that fully resourced through the SDPRIA, or is there a contribution required from local health districts as well?
It is a mix, Dr. Conn, and that's one of the things we're looking at now, because the operating model that we had in place at the start of this obviously will need to look quite different, because we're sort of designing and building the system and configuring it. Now, once that build and configuration is actually done, there'll obviously be elements that we always have to check and refine, but that bulk of that type of effort, if you like, is really sustained to the front end. What we do see, though, as we move into this next iteration, it's why we do have to look at our operating model, is we've then got some entities who have gone live, some who are still finalising their go live, some that are planning to go live, and as we roll forward we'll have some that are then obviously in hypercare as well. So we are going to have to work very, very carefully with our governance structure and our operating model for the whole system to make sure that we're really leveraging services in their BAU approach, because I think that's one of the learnings certainly internationally, is try to make sure that you're embedding this as soon as possible into BAU processes that will be the ultimate sort of owner, if you like, of the system going forward. So it is going to be something that we have to remain a degree of agility with to respond to the iterations as we move forward.
One of the complaints, which I'm sure you would have heard as well, was about the level of overwork for the people involved in implementation. Have you put on more staff to support that workforce with the process?
So I think, look, and Mr Bast might take notice specifically around the review that was done in response to the concerns that were raised. And I think one of the learnings we certainly did take was we had Justice Health, and as I said, there is a 24/7 hypercare period that follows the implementation. We did work with the unions around that. There were staff who indicated they actually did want to do shift work. I think once the reality of that comes on. Sometimes it might not be what people then think they do want to do in an ongoing way, and that's completely understandable. You know, they haven't done it before, necessarily in this sort of environment. But I think what was the learning from the tranche A split was we went straight out of one hypercare into a second hypercare because of how we split it. And so I think moving forward, considering the timing of how that all plays out will be absolutely critically important. But a big part of the decision around how we roll forward was very much listening to the concerns that were coming through very strongly from staff, but that's why we did have that review done. But Ms. Maston,
thank you. We undertook a psychological risk assessment, a psychosocial risk assessment in response to feedback from the employees within the authority, and they did raise concerns about the rollout itself and the timing, but also about the workload issues, and in response, in addition to the phasing that Ms Wood has spoken about, which I think has gone a long way to alleviating the concerns from the employees based on the feedback that we've received. We're also reviewing rostering, workload, work allocation, and we have a small team working within the authority just to work with the teams to address any of these issues as they arise. We're also in regular contact with the HSU, who have done a great job of collating and passing on some of the feedback from their members. So it's very much a collaborative process with the workforce to work with them both in terms of the design of the work itself, but also to address their concerns about the workload.
Thank you. And coming back to Ms Wood, I mean, there were a litany of issues reported at John Hunter with from clinical staff, and I don't want to dwell on any one in particular, but for example, I was told the fluid balance was totally unreliable. There were errors in drug formularies. Some of these now have been addressed. I know some of them are in progress, but is there a centralised list of those issues so that people can see what issues you know about, which ones have been rectified, what the plan is for the ones that haven't?
Yeah, so I'd have to get Ms McCosker to speak about the local processes, but certainly from the work that we've been doing, as soon as we identified that we had some issues that were outstanding, we've got a complete issues log from a state level perspective. We meet every week to go through exactly where that's up to, and we've actually risk rated them, obviously, in terms of the fixes that need to be completed. But I do know locally it was challenging at the start, and as you know, Ms Pearce said, there are some people who are now recognising that there are actually tremendous benefits, but it hasn't been without some of those challenges that have been identified. But Ms McCosker, did you want to talk about local levels?
Yes, we've sort of got two levels of governance around this. So in the local level, we've set up a governance structure that has each one of my executives responsible for different sections, whether it's issues that are raised by medical staff, issues raised by nursing staff, medications. And so we are aware of those, we prioritise those and escalate the things that we need assistance with, particularly from Implementation Authority or EPIC experts. But we're sort of working very closely with them anyway. It's just if some of them are local issues and like workflow issues, but some of them are structural that need to be sort of reconfigured or things, and that's the ones that we escalate. But we're working really well together. I'd have to say I'm incredibly proud of the staff. They've worked hard, they've leaned in, and while they are they're keen to escalate things, they've also very calm about things and have sort of really tackled them in a really mature, considered way. And I have walked the floors of the hospitals to talk to people about how they feel about the system. And on the whole, it's positive. In the inpatient wards, particularly in the ED wards, they feel quite au fait with it, feel like it's intuitive, feel like it's helping, and tell me, oh, this is something we've never had before, so this is great, and point that out to me. In other areas, it's just getting used to it, a new system. When you go from paper to a digital system, you know, you're typing all your notes into a workstation on wheels. All those practical issues are a little bit different to what people were doing in the past. So I feel like they know that they can safely escalate the issues that they have, and that we are listening and that we respond to them. And we've had good feedback from the response that we've got, and that we've got people on the ground that have come in, walked into their section and said, I believe that this is an issue, how do we fix it? Let's work together. So we're getting there, but we've got a tight sort of list and governance over it so that we don't miss anything, and we meet weekly as well.
So I suppose the list of known issues, fixed issues, to be resolved issues, how is that communicated back to clinical staff? I mean, both at Hunter New England, but also the services that are coming next.
We've got a whole comms process. We've got a whole comms process that talks about what we did this week, what we've addressed this week, what information that you can access to find out what we've done. If you need to know particular details about things, this is where you would access that. So we've got pretty much a full-time comms person on it.
Yeah, and I would just add to that as well, Dr. Con, we've just also had to manage that comms process carefully, because as you can imagine, there could be a lot of email traffic or notifications that sometimes can be unhelpful in terms of then people missing things they do need to see. So we have been very considered in how we've approached that.
I'll come to Dr. Taylor. My questions are all arising from the coal ash inquiry that was conducted in the previous term of the Parliament. And my first question is about cancer rates in your local health district. The Cancer Atlas, for example, shows Budgewoi 79% above the Australian average for head and neck cancers, Gosford's above average for liver cancer by 47%, mesotheliomas 56% above the Australian average. What's your best explanation for that?
Thanks for the question, Dr. Con. Certainly a disease such as cancer is not a single disease or a single entity, but multiple different diseases affecting multiple systems. So it's also by nature multifactorial. And when looking at rates of cancer at a population level, there are certainly things that need to be taken into account in terms of known risk factors such as socioeconomic status, as well as established risk factors like smoking, alcohol intake and obesity. And certainly we know that some of those factors are not evenly distributed within Central Coast, and also that the Central Coast Local Health District region has a preponderance of some of these pre-existing risk factors as well for certain cancers. In September 2025, the Public Health Unit did do a regional health overview, particularly in trying to address some of the concerns of community groups asking about the potential impacts of coal ash in our region. And it was good to see out of that data that there was no significant difference in the suburbs surrounding the power stations and the coal ash dams to the regional average.
To adequately be able to unpick the multifactorial contribution to cancer or the impact of the coal ash dams, the coal ash inquiry had recommended an epidemiological study. Based on my own understanding, something like a case control or even a cohort study would be the most reliable way to unpack that. It was the previous government that had, or it was under the previous government that the decision was made to just do a human health risk assessment. Do you think that's adequate in terms of being able to unpack whether or not those cancer rates are indeed caused by the coal ash dams?
Thank you. Look, an epidemiological study was certainly considered at the time, but it's not the recommended methodology to address whether power station emissions might be associated with human health risk. And so for this reason, a human health risk assessment was chosen as the most appropriate method for assessing potential health risks from environmental exposures such as coal ash. So they're two different approaches. I wouldn't characterise it as just a human health risk assessment. That's certainly an established and internationally and nationally recognised methodology to answer precisely this question from the community.
That draft human health risk assessment makes a number of assumptions in the absence of data. Some of that data is either available to the EPA or are things the EPA have the power to compel from coal-fired power station operators. Do you think it's sufficiently reliable in the absence of that real-world data when it's being made on assumptions?
The human health risk assessment was based on a substantial amount of environmental monitoring data and data from other sources as well, and also informed by community consultation. However, every scientific method does have its limitations. I would say that the health risk assessment methodology draws on extensive toxicological and exposure science, and there are established ways for handling where there may be some gaps in the data. primarily around taking a precautionary approach and using the most conservative or worst case assumptions in terms of exposure. So to give an example, assuming that people are exposed at conditions, ambient air conditions of, incredibly dusty, where there's construction happening 24/7, using those kinds of assumptions that are quite conservative, and finding out of that there is still minimal evidence of health risk from the chemicals in coal ash dams.
What efforts did you or your colleagues make to fill the data gaps that were identified in the draft report?
So through the local health district, we work closely with our colleagues at the Ministry of Health, who have liaised with our colleagues at the EPA to require some of this information. And certainly the best efforts have been made to obtain this information through the EPA. I understand there are some challenges with obtaining that information in terms of commercial sensitivities. Having said that, there are adjustments made to the human health risk assessment methodology to account for those, taking a very precautionary and conservative approach to ensure that human health is maintained.
And when did you get the copy of the draft report from the consultant?
I'd have to take that question on notice. It was probably about 2 months before the draft was released to the Community Advisory Committee.
Thank you.
Mrs. Mitchell. Yes, thanks, Chair. I might get Miss Field up at the table. I've just got some more Lake Cargelligo questions. But also just quickly to finish back with you, Mr. Sloan, would you be able to provide on notice the IPTAS funding that I guess was paid out or spent over the last 5 years, or do you have any data on that for the last couple of years for me? Happy if on notice is easy.
Probably I can absolutely, probably to save you time, I can provide that on notice.
Yeah, that would be great. I'm just keen to know year on year. Yeah, that would be great. Thank you. And happy for either yourself or Ms. Field to answer these ones. Yeah. Just about Lake Cargelligo, I thought it might be better to have you at the table. So obviously, and I'm sure you're aware of and you spoke about it earlier this morning, Mr. Sloan, about the sort of community groups, and there's obviously a lot of support in the community to see the MPS upgraded, redeveloped, particularly the need for aged care beds. Is there any indication you can give me in terms of, I guess, the current status of this project? Is it high on the priority list? What's the likelihood of something being delivered for that community soon?
Well, as we discussed this morning, Ms. Mitchell, the HSP was submitted in 2023. Mm-hmm. I will say since then, though, there's been some other funding opportunities that have been we've the refurbishments. We've undertaken some works around culturally safe spaces, security and fire safety improvements, and a dementia-friendly infrastructure. And that's been through some funding that we received and that we through a grant. Through the residential aged care program, which we then were able to match that co-contribution from the district. So it still remains a priority for us, and it's the Lake Cargelligo build.
Yeah, and I guess particularly the aged care bed components, and I know you would understand this as well, but obviously having quite a high Aboriginal population in that community, there's a lot of concern that certainly came through to me when I was out there not long ago, particularly about people having to move off country to access residential aged care. I think the All Care community group, they think there's at least 27 people currently waiting for an aged care placement. So this is not a small issue in the community. In terms of updated information, I think there's a bit of frustration, to be frank, was what was presented to me by the community about just not hearing much about what's going to be happening if they're going to get priority. Is there ways that you can have a better channel of communication or something in that space?
Yeah, sure. And Ms. Mitchell, I did have a quick. I had a look at what we have been liaising with All Care. Yeah. But we will commit to that further collaboration with All Care. They are, as you said, a really important piece in the community, particularly in the aged care. And you're right, there is that culturally appropriate care that we've been really, I suppose, focused on, and the access to aged care beds is the priority for us out there with that with the HSP. Mm-hmm. So we are aware that is an increasing need and demand for Lake Cargelligo. And yeah, so I think from my perspective, we'll definitely take that on around the further collaboration with All Care. We have been meeting with them just as recently as in March 26 this year, where we did have a further conversation with them around service planning. So
yeah, and look, I appreciate that, but I guess we're nearly in September, so I think that's part of the frustration. The other thing too that, and you may need to provide this back on notice, but the services plan did have data around the predicted need of aged care beds, but obviously it's been 3 years since that was put together. So has the need or the demand sort of forecast increased since that time? I guess, is the plan out of date, I suppose, is a simple way to ask the question.
So what I can say that service plan was projecting those 14 additional aged care beds to 2036.
Yeah, okay, thank you. I might put some more questions on notice in relation to that, but I appreciate, and I'm sure you're hearing the message that the community would like to be talking to you more about what's happening. Did you want to add something to that?
Yeah, I might just add in relation to the capital planning processes, because I think it's an important thing across some of the questions that you've asked today in relation to funding for next stages of projects or funding that the local health districts request. So there is quite a structured facility planning process in New South Wales Health, and each year we request from the districts proposals for capital funding, and they are received. So we recently received this round of proposals from the district, and the one that you're discussing here is one that's been submitted as a priority by their local health district. We then assess those proposals, review, for example, the capital cost estimates, the clinical service need, and ensure that they're supported by the ministry. And then ultimately that feeds into a budget process. So we submit to government a list of priorities from the New South Wales Health's perspective for consideration for funding through the budget. So that process occurs over the next few months with a view to being submitted for the next round.
So, and I'm not trying to put words in your mouth, but is it fair to say then that project, say from when 2023 plan was done, if it's now moved into being considered in the funding, that's a step forward?
Correct.
Yes.
Correct,
okay. Okay, thank you.
I should also, sorry, Ms. Mitchell, I should also just add, we often do projects, especially around aged care beds, in conjunction with Commonwealth funding.
Sure.
And just, not to throw them under the bus as such, but we know that the Commonwealth's had a bit of a different tact with regards to the last couple of rounds of funding, and not necessarily putting it out there for public services to apply for the funding, including doing the last round of aged care infrastructure by invitation only, which was targeted towards private aged care providers in the piece, because we had quite a few of our MPS sites that are on the priority for expansion that we were going to put forward as part of that to operationalise the beds that they have granted us.
Yeah, and I appreciate that sort of unique delivery model, I guess, of an MPS as opposed to other sort of capital or aged care. No, thank you. That's great. And a totally different topic. I might put this to you, Ms. Pearce, but you may need to take it on notice, which is fine. Respite Care in Queanbeyan. There's an organisation who've been building Yvonne Kushkiri House. I think I've pronounced that correctly, and I apologise to her family if I've not, but I think it's Kushkiri. There was some state government and federal government funding that went into building this facility, just sort of capital money, which I don't believe was through health. But they're now looking at ongoing funding. Effectively what it's designed to do is to offer respite care for people aged under 60. My understanding is that the local member, Steve Warren, has said that he's seeking advice from health about whether there are pathways to funding, and I'm just wondering whether this is on anyone's radar or if you're aware of any funding opportunities that might be available.
It is on our radar, and we absolutely acknowledge and appreciate the advocacy for it. I'll hand to Mr. Sloan if that's okay.
Sure.
He might have a bit more detail.
Yeah, we've been working with Southern New South Wales with regards to the process around this for an elongated period of time now. Of course, this particular respite facility was built outside the auspices of the clinical services plan for the district, and thus it's a bit tricky about how we engage and then work with them on securing a way forward. I know Marg and now Joe McDonald, the Chief Executive, the interim Chief Executive for Southern New South Wales, has been meeting with the local team or the local advocacy group and organisation in order to support them to find a way forward. The most important part of that being an operator that will take the build forward now that it's actually established. And I know the district have supported them with regards to and met with their legal representation with regards to providing them information and support to find a way forward for an operator to step in and do it. And we still haven't got to a place. They didn't have anyone come forward, to my knowledge, that would be interested in providing that operation on
I think what they've said to me is that because there's no ongoing government funding, that's what's making it challenging for them to get an outside operator. That may not be what you've been told, but that was what was relayed to me.
Yeah, I guess it depends on the type class of the beds, and I know they're respite beds, but the type class of the patients that will actually go into there as to where the funding comes from a state or a Commonwealth point of view. But, you know, a suitable operator will have the expertise to know how that would move forward and whether it's sustainable, of course, as well, from a business model point of view. We'll continue to support them and the group through Southern New South Wales to try and establish that. We're keeping our minister briefed around this as well. And the local health district has been liaising with the local MP with regards to the way forward as well.
Thank you.
Yeah.
Ms Pearce, perhaps I could address the question to you. The your agency suicide prevention plan, I'm just wondering the status of that and the expected completion date.
Yeah, I'll get Ms Wood to respond.
Oh, it's you again, sorry.
That's all right. You two are just drawn
That's right,
to
exactly.
all your questions. You can just go and have a coffee and sort it all out.
Sorry, Ms Carter, I'm just going to get my mental health estimates book up again.
Well, this is really, it's not really mental health, it's the agency suicide prevention plan.
No, I absolutely understand. It's just that our mental health branch do run it, so I'm just going to see if I can find the date for you. Is there anything, is it just the status that
I just wondered what work's being done, what resources have been allocated, whether you've been liaising with the suicide prevention councils and have found their assistance useful, whether you needed to employ outside consultants, when it would be operational.
Sure. Perhaps what I might do is just wait to see if I can get a detail to come through to make give you
Oh,
some
look, I'm happy to
further.
put them on notice. I just wondered really what stage of development it was at.
Sure.
This being a novel thing, what the issues were you were encountering.
Look, we've been working very closely, and the Mental Health Commission obviously looks after this from the state perspective, but it's...
But as I understand it, each agency is to do their own plan.
Yes, they do.
Yeah.
But we work very closely with them. So I think the main thing probably to say is that we are progressing the plan. It's been a very important piece of work, not just for us as an agency, but also in our Closing the Gap work as well, because we do know Aboriginal people are very much overrepresented in those groups.
So to that, given there are two suicide prevention councils, is there a desire to have two plans within the agency?
No, there wouldn't. There would be what would be, from my perspective, I think what is very helpful is when we have an overarching plan, but we do address the very specific needs of our Aboriginal population within that plan.
Okay.
So I'll just wait to see if I can get any more answers on your others, otherwise take it on notice.
Okay. While you're doing that, I'm not sure, Ms Pearce, perhaps you could direct this questions about Shoalhaven Hospital and when patients will be accommodated?
Do you mean in terms of the development?
Well, I understand the hospital's now been complete, is that right?
Emma, can you comment about
I'm just going to double check the dates.
Yeah.
Because my understanding is there's been an announcement that the building's completed, but it was expected to open July this year, but that's been pushed back, I believe.
So we are working through, so the building is completed, and the operational commissioning phase is underway with a view to opening later this year. I don't think we've confirmed the exact date because we're just working through some final aspects with the final defects closing out at the end of the construction.
And the 20-bed subacute mental health unit that was closed down, will those 20 beds be reopening in the new Shoalhaven Hospital?
I will need to just check that piece of information.
If you could take that on notice, and also how many acute mental health beds will be opening in that hospital, as well as subacute?
Yes, I'll see if I can get that for you now.
Okay. And if you can also tell me whether the same level of mental health services will be provided with the same bed numbers in the new hospital as in the old hospital.
same, sorry, do you mind just repeating that question, Ms. Carter?
Whether the same number of mental health beds in the same categories
Okay.
will be available at the new hospital as in the old hospital.
All right, I will confirm that. Thank you.
Okay, thank you very much. And a question about the Bega or the former Bega District Hospital would go to...
What was the...
Oh, the question is, what's happening to the vacant site of the former hospital?
That's also one for Ms. Gould.
Okay,
we might just
perhaps
need
I'll
her
put
to,
that on notice as well. Yeah.
Yeah, I might have that information here. I just want to get the latest status for you, Mr. Carter.
We can do it on notice if that's more convenient.
I've got a couple of infrastructure ones, so I might just stay with you, Ms. Yolanda. Sorry,
it's my turn.
It is. It's your turn. Bathurst Health Service redevelopment. Any updates on that and the completion date for that redevelopment?
So we have staged completion for Bathurst. I think safe to say it's one of our more complex projects in terms of the staging of the work. So it's tracking very well. We're working with the contractor on site and working through construction there. And the project though itself is delivered in multiple stages, so there'll be staged opening of it. The construction is due for completion in 2028, but the commencement of stages of opening will be 2027, and that will occur over time.
Okay. The car park, which I think I've spoken to you maybe about before, have there been any further options for car parking on site as part of this redevelopment?
No. In terms of car parking to be delivered as part of the project, no. We've confirmed the scope that we can deliver within the project that we are working on, and the car parking that will be delivered as part of that. We haven't got any updates in relation to, I think you're referring to the multi-storey car park that has been discussed. No, I don't have an update in relation to that.
And are there any upgrades to Daffodil Cottage as part of the redevelopment?
That's a test.
If you need to take it on notice, that's fine.
Yeah, I think I do.
Yeah, that's okay. And then one more infrastructure one. Is there any, or I guess, where is the priority for funding for a new fit-for-purpose MPS at Grenfell? Is that on the list of potential projects? Mr. Sloan might also. It's up to you.
Yeah, it's one of those priority sites that we talked about. Definitely for Western New South Wales, much in a similar bucket to Lake Jellicoe at the moment for us. Knowing that the district themselves have done clinical service planning and recognise that it's the only aged care facility in town as well. We've had multiple representations from the community as well, which I've been not only the district in contact with the community, but Peter Moffat out there at Grenfell very much has got my phone number, and we talk often. And it's a case as well of us aligning with the Commonwealth funding with regards to operationalising the beds that particular facility has been granted.
Yeah, I think just to note, as part of that process that I described before, in terms of prioritisation from each of the local health districts, certainly has been put forward as an asset priority, as have a number of other MPSs around the state. So yeah, it will just be a case of reviewing that in our list of priorities.
Okay, thank you. And this one is probably best directed to you, Ms. McCosker. Wee Waa Hospital.
Yes.
I'm wondering if there's any updates in terms of the delivery of services there. I have been told by the local community that it's looking to be open a little bit later on some of the days, but obviously still not at a 24/7, which is what they're calling for. I'm wondering if there's any update you can give me on Wee Waa.
So we have recruited, we made it very clear with the local health advisory committee that we would have stages that we would need to recruit to and a number that we would recruit to so that we could extend the hours. We've recruited that number of people, so we've now announced...
Is that nursing staff? Sorry,
nursing staff, yes. And it also includes nurse practitioner. And the nursing staff that we've recruited, we rotate between Narrabri and Wee Waa so that they get more experience, because we're still not seeing a lot of presentations at Wee Waa, but we are now extending the hours to, I'm thinking 9 o'clock or 10 o'clock at night. 10 o'clock at night. And the community is very happy about that. So we want to just settle that in. We've got a new health service manager there who's working out really well, and she is part of the reason I think that we're being successful in recruiting people. So we'll bed down that model, and then, but we are still got advertisements out to recruit more staff, and if we can recruit more staff, we also know the number, and that escapes me, but we know the number that we need to actually have the hospital open 24/7.
Could you provide that on notice, the number?
Yeah, sure.
Yeah, that'd be great, thank you.
Milton Ulladulla Hospital, is that you, Ms. Skurlander? Provision of birthing services there?
I think that could be me, but it might also be a question that I need to ask the district.
Or Ms. Pearce, do you know about?
Could you confirm the question?
Since 2023, we've been promised birthing services at Milton Ulladulla Hospital, and there's a lot of women down there who are keenly interested to know when they can deliver there.
Yeah, I know we have discussed it here before. If you wouldn't mind, we'll take it on notice and get advice from the district as to the current status. Thank you.
Thank you.
That's all you had? Yep, okay. I'm trying to eliminate what I need to put on notice, but I still think, sorry, you're getting a few on notice regardless, or supplementary questions. The $400 million hospital maintenance announcement, is that new money, additional to sort of the normal asset sort of spend, or I think it used to be called the Asset Refurbishment and Replacement Fund, but now it's called something else, because we love to change names in government.
And acronyms.
Yeah, exactly. So is that new money, that $400 million, in addition to sort of what the normal spend would be that I'd assume you'd have on maintenance
It's
upgrades and things?
new capital funds.
Okay, and is that to be delivered over a 4-year period as well? Okay. And my understanding is the previous model was a 10-year fund, and this is a 4-year one. Is that right, or have I been given the wrong?
Mr. D'Amato might be able to
Yeah, that's correct. The old model was 10 years.
So why the change to move it from 10 to 4?
I think we also need to acknowledge in between where the additional funding secured 2 years ago, which is related to the critical asset management plan, so the CAMP. There was 250 million, so this complements that. So we don't have 10 years, but if I take into account the previous 250 and this 400, we're coverage for at least 6 years plus.
Okay, and I note before, Ms. Galante, you said that possibly some of this will need to go to MARTA. Is there a time frame of when you expect to have clarified which projects will be funded through this $400 million? Will that be publicly announced? What is the time frame for that?
Yeah, I can't preempt probably the announcement strategy, but certainly in the next couple of weeks we'll be finalising our priority projects for this first year, and it's probably going to be the first 2 years that the top priority projects in there. But what we're going to do is work it through in tranches so that each year we'll confirm and then allocate funds to be able to then deliver the projects within that year.
Okay, thank you.
I'll start with a couple of questions for Ms. Field. Firstly, has Murrumbidgee done any work to assess the need for a step-up or step-down mental health facility at Griffith Base Hospital to support the acute mental health unit?
Yes, so we have done over the last 2 years, there's been a number of a business case put forward. And we've been able to ascertain that data, to look at the data to see what was the need at Griffith, noting that we do have obviously a fairly significant inpatient unit at Wagga that flows through from Griffith. So at this point we have a submission in for that.
Okay, and that's a business case from Murrumbidgee to
the ministry.
The ministry.
Yep.
Okay. Can someone from the ministry tell me what the time frame is for that business case being looked at?
I think we might have to take that one on notice, sorry.
No problem.
Yeah.
That's all right. And then coming back to Ms. Field, you've probably predicted this question. When will surgical abortion services be available at Wagga?
Yeah, and thanks, Dr. Conn, a great question. We are working really quite, we've been working in the last 12 months. We've got with the district and a number of stakeholders. We're very, very close to be able to deliver surgical terminations at Wagga. I did say that if we were probably a month away or so, I'd be able to probably say that we could. So we're just in the process of putting in a proceduralist with theatre time. So we're very close, and we're hoping to have that very soon.
Okay, thank you. And can I just clarify, when you say you're in the process of putting in a proceduralist, you mean that person's been recruited?
It's a current staff member.
Okay.
Yep.
Okay. I'm trying not to get you to commit to a date because I know
No,
that that's
I can't give you a
unreasonable.
date. Yeah.
Would it be reasonable to expect that service to be up and running before the end of the year?
Yes.
Terrific, thank you. I've got a question about voluntary assisted dying. I think it's probably for Dr. Chand. I've been made aware of an issue with practitioner kits expiring before they're needed, particularly in rural and regional areas. So kits needed to be procured from Sydney or from Newcastle. Is this an issue that you're aware of?
I'd have to look into that. That particular issue has not come up. There is a sort of, so that expiring kits is not I am aware of an issue with the fact that the prescription may have a duration and the person may not have died in that duration. But I'm happy to follow up any particular cases, and if you've got any information, we really want to make sure that there's no stress for patients in this very difficult time. So happy to follow it up.
Thank you. I appreciate that. And look, I'm happy to write to you. The case that I've been told about was a patient being assured the medication was in stock at the local hospital for when she wanted to use it, and then when she did decide to use it, was told it was expired and a new kit was required. There was a delay because of a public holiday, and that patient actually died in the interim.
Yeah. So just to reassure you, we're happy to follow that up. We'd see that as a critical incident, and hopefully someone's put in an IM so we can look at the root causes of that. But we are looking at making sure that there is distribution of the stock of the products, and we have established a sort of satellite arrangement in Hunter, New England, again to make sure that we have got distribution of the products. So happy to take up any learnings from that case, and I'm sorry that that person experienced,
Thank you. I appreciate you looking into it. I'll stick with you, Dr. Chant, for vaccination.
Mm-hmm.
What's been the impact of the intranasal influenza vaccine?
So the impact has been pleasing. We would have hoped that it was more pleasing. We have seen a small increase, and we've also looked at whether there were people that got vaccinated that hadn't previously got vaccinated, because as you're aware, Dr. Conn, that this product is approximately 4 to 5 times more expensive than the injectable form. So it's a question of whether it contributes to higher coverage, and we know that our under 5s, 6 to under 5 is an area where PBAC has indicated cost effectiveness for the vaccine. So, and we struggle to get our target in our immunisation strategies 40%, and we've really struggled to get to that level. We know that's achievable because places like Canberra, no competition, but they get to those sort of levels of coverage. So on reflection, we think it has contributed. Some of the learnings from the program is that whilst this product was available and used widely in the Northern Hemisphere, and we did a lot in our messaging to try and establish that awareness with community, there was still a perception out there that it was a new vaccine. So that's a learning. We've also had feedback that it's potentially most beneficial in those 3 and 4-year-olds, just when they get a little bit older, and that the 2-year-olds sometimes can have that nasal sensitivity, so it's sometimes difficult. We've also had very practical feedback around when parents are taking all children in, the issue that being uniform in what vaccine they get in terms of injection is easier for parents to explain. So we've learned a lot of implementation issues, but long and short of it is we do think it's contributed. It's probably contributed somewhere around 8%. We're still got the data that we're evaluating. We think it's part of the mix, and we're hoping that if we continue this program, that we'll get a better sense that 1 year is probably not long enough to see and test its acceptability. Other states and territories have also implemented programs, so we've been sharing that intelligence of what's worked well and what has not worked well. In terms of our process for next year, we're currently in the process of briefing government to make a decision about the best way forward for next year.
Thank you. And I had a couple of other vaccines to ask about where the federal government is either partially or not funding vaccination. The first one's RSV, so I understand the federal funding covers Australians over 76 and Aboriginal and Torres Strait Islander people over 60, but it's recommended for people over 50. Has there been any consideration of funding RSV vaccination for people between 50 and 60 or 76?
Our general approach is to align and have a national immunisation program and have consistency. Obviously the states have stepped in and we've stepped in the flu, and part of that is to actually generate data and inform any cost effectiveness that PBAC may have. We also do it and for outbreaks, so for instance we've rolled out diphtheria vaccination and with state-owned. We've also purchased state-owned to deal with measles threat. We've stepped in with JEV when there was uncertainty about where that was headed, given the introduction of JEV. And MPOX is probably another example where we've bought state-owned. In general, our advice is to stick with the NIP process because PBAC assesses it for cost effectiveness. But clearly this gap between the recommended vaccines and what's funded under the NIP, we've actually heard from a lot of patients and clinicians that causes challenges for them. So happy to take that away and reflect on that, but that's been our general approach.
It's obviously been an extraordinarily busy winter for the health system. We've had, the extreme steps of the Health Minister and the Premier trying to prevent people coming to ED. Would that be...
Point of order. At no stage has the Premier or the Health Minister made an announcement of preventing people go to ED. That's just a wild statement.
I didn't say preventing.
You did.
To the point of
I'm
order,
happy
Chair.
to rephrase my question.
That's a debating point.
And say that statements were made
not to prevent people.
discouraging people from attending ED with non-urgent issues.
You said prevented.
I did not say prevented. If I did, I've already revised it to say discourage. Please stop wasting my time.
It's also not a point of order, Chair.
It's been an extraordinarily busy winter for the health system. Has that prompted a change in the approach to potentially consider additional state pools of vaccination?
So we've actually been doing a lot of work at vaccination and tragically our over 65 vaccination coverage is lower than we would like it. So we do actually see that even within the current guidelines for those patients that are at medical risk who have got access by both general practice or pharmacist can vaccinate, we're really underutilising available vaccines. So of course as a public health clinician I'm torn because I see the benefits of vaccination for a wider age group where it's recommended by ATAGI, but part of me also appreciates the cost effectiveness decisions we have to make in a sustainable health system funding model. So long and short of it is there's probably a lot we can do collectively to promote vaccination for even the groups that are unfunded under the NIP. And I'm pleased to say that we're working closely with our GP colleagues and our pharmacists to look at innovative strategies to try and support vaccination coverage. Obviously, we've also got dealing with a lot of misinformation at the moment. We've also doing a number of strategies in our health system to really recognise the important role our health system has in leading and vaccinating, and I just want to acknowledge some work that we're doing across with Mr. Matthew Daly from a health system performance perspective to look at really embedding immunisation as part of routine care, because we do have a number of touch points with patients. So we are collectively working on this process, and I think we all have a role in supporting the community to get the benefits from immunisation, and it is also a very strong equity issue when we look at the distribution of vaccination. There is much to be gained.
The last one on my list is meningococcal B. I know it was the preference of New South Wales Health and the Minister for the federal government to fund meningococcal B vaccination. I understand that that wasn't recommended by the Pharmaceutical Benefits Advisory Committee earlier this year. This is another one of those vaccines where what's available and funded doesn't match what's clinically recommended. Now that it is not being federally funded, at least for now, have you at least costed what it would take to do a state-funded meningococcal B?
We have costed what it would take and provided advice on that. It is a significant amount of money. I'll just have to find the particular brief, depending on the catch-up schedules. I'm happy to take that on notice, Dr. Conn, but certainly, and I'm just conscious of my previous comments that PBAC indicated that at the current price that the company was providing it didn't meet the cost-effectiveness thresholds, but it did acknowledge the importance of this vaccine, that it was effective and the safety profile was acceptable. So,
thank you. I'd appreciate the answer about the costings on notice. I've got a question for Justice Health. You would have heard that I asked the Minister some questions this morning about safety, security, occupational violence and other risks to staff. Without intending to overly stigmatise your patient population, I think we'd all understand that this is a particular concern in a Justice Health setting, and given the concerns that have been raised by staff and their representative unions about safety and security, are there any specific actions underway at Justice Health from a security perspective?
Well, there's obviously two settings that we have. So there's a forensic hospital, which is health run, so separate from the work that we do within the custodial setting. In the custodial setting, obviously, we rely strongly on corrective services and the youth justice officers as well to keep us safe. And so there's lots of protocols with them. And the violence or the exposure that our staff have within the custodial settings is probably lower than you'd expect. So that's kind of that. In the forensic hospital, we have obviously a really, really difficult cohort of people, and we have relational security, policy security, environmental security that we manage with that. We have been working really, really closely with Safe Work around doing psychosocial and safety work within the hospitals. We have a working group that we work with them very closely. We've got some really good feedback around that. And it's something that we take really seriously, obviously. Because of the environments that we work in, our staff are trained to manage violence and to manage aggression. But certainly in the mental health component of it, our first line is about relationships, is about understanding that person's safety plans, sensory intervention. Obviously, second line would be any hands-on approach that we'd have with anybody. So I think from the violence prevention perspective, I would say that Justice Health is probably leaders in that area. We also, from our workplace health and safety and from a health policy perspective, with the Anderson Review, with the requirements that health, we follow exactly the same as any other health service would and are held to the same standard in what we do with that.
The regular meetings you say you're having with Safe Work, which are good to hear about, how would success of that program be evaluated, or what would you see as a successful outcome?
Well, I think we measure our incidences, our staff, any work cover or any incidences of staff harm or patient harm, in fact. So when we look at outcomes from there, it's about reducing. We don't often reduce incidences where people are expressing aggression because of the cohort that we work with particularly, but where that can be minimised to progressing to any harm to anybody is an outcome for us, and that's around training and de-escalation techniques and such like. Things like we obviously are part of the PMES, and we look at our PMES results. We take them really seriously and do a lot of work with our staff around that. We have lots of different ways of getting feedback from staff. We do surveys, particularly in the Forensic Hospital, across the custodial network to see how staff are feeling, and keep our pulse pretty close, you know, and with our staff to know how they're going. But PMES, survey results, incidences, how they're managed, and obviously the ultimate thing we're trying to completely avoid is any kind of work cover.
Thanks. I appreciate the point you're making around work cover, and that's a better metric than number of instances.
Yeah.
Are you able to provide, perhaps on notice, some of the figures around
Sure.
work cover claims over the last couple of years?
Yeah, definitely. We can do that. I've not got them with me, but we can do that. We definitely have an eagle eye on that, and also time lost. That's really important to us. We know that getting people back to work when there has been an incident at work is really, really important.
Thank you. I've got a follow-up question about Queanbeyan from this morning. It might be for Mr. Sloan, if not.
Can I be dismissed? Can I go?
Yes, yes, you may. There were questions put to the Minister this morning around the GP obstetricians who've been stood down at Queanbeyan Hospital. I know that the Ministry understands the importance of continuity of care in maternity, particularly following the birth trauma inquiry. I know the Ministry's touted the success of implementing a midwifery group practice at Queanbeyan, but given that the GP obstetricians are also really critical for continuity of care, you know, they've got regular GP patients who would want their GP or the GP obstetrician to provide their intrapartum care, not a locum obstetrician flying in. What work's underway to address their concerns so that GP obstetricians can come back to work?
Ms Wood can assist, but
Please.
we absolutely respect women's choice. It's important that women have that choice in all settings. So.
And thank you, Dr. Con. We have been working very closely with Southern New South Wales since the issue was raised. So I think it is important to note we did put the midwifery group practice in Queanbeyan, and it is actually working well. And I think there have been challenges that have been identified, where GP obstetricians obviously one part, but the maternity team as well. So we did have a site visit on over 2 days in June to actually go through some of the concerns that were raised. And importantly, one of the things that we were very explicit on was staff wellbeing and psychological safety that were raised by both groups. One of the pleasing things that has happened of recent times, last week I think the Minister referenced, we have had a temporary obstetric lead that has gone down to really establish that medical leadership in Queanbeyan. He started last week. Our chief obstetrician was also down there last week. We have a very senior midwifery expert who's been down there as well. Pleasingly, where we did have a couple of midwives who had actually tendered resignations, they have rescinded those because the culture already has been significantly improved in that unit. So it is a complex circumstance that's being worked through very closely with the district, but we do have very good confidence in terms of the district's ability to work through what's necessary to ensure that the different options of service delivery are maintained at that site.
Thank you. I'm glad that you're across it at this level, and hopefully the GP obstetricians are the next clinicians to come back to work. We just have a little bit of overflow time, 4 minutes each. Or total? Each, okay. I've got a question about surgical robots in regional hospitals. Miss Pierce has made eye contact with me, so you can start.
Doesn't mean I'm going to answer it.
It was terrific to see funding in the budget for a surgical robot at Orange Base Hospital. I know this is something that the doctors had advocated for a long time. I understand that a robot at other regional hospitals, and particularly Port Macquarie Hospital, would be well utilised by the local surgeons in urology, general surgery, gynaecology, and prevent patients from having to choose between a trip to Sydney or a more invasive surgery locally. Has there been any consideration of a surgical robot at Port Macquarie?
I can't specifically answer Port Macquarie unless you can, Luke, but because Dr. Jean-Frédéric Levesque is the head of the Agency for Clinical Innovation, who's not here today.
So there's someone not here.
There's one person from New South Wales Health not here today. The ACI does have a process, Dr. Con, with respect to the robots and the application of them. You're quite right about Orange. 2 earlier comments I made with respect to colleagues at Dubbo as well. You know, one of the things that we really need to advocate for is the networking of some of these services. Not that we want people, you know, having to travel countrywide to receive the care that they need, but like many of the procedures that we have in our hospitals, volume is important, and volume as it relates to any surgical procedure is important. It's particularly important as it relates to robotic surgery. But Jean-Fred does have a process where we analyse and understand those needs. So as to Port Macquarie, I can't comment specifically, happy to take it on notice. One other thing I would add to, though, is that one of the recommendations from the Special Commission of Inquiry was around our need to have better statewide clinical services planning. It's a recommendation that we fulsomely support and advocated for ourselves, because there are opportunities for us to think about where things are best placed to suit the needs of the population. We understand very acutely, and I understand in particular very acutely for reasons I won't go into here, that access to robotic surgery and the prevalence of prostate cancer is high, and it is something that we are very aware of on behalf of our population.
Thank you. I appreciate you taking the specific part of the question on notice. I'd also be interested more broadly in the factors that are considered when assessing the need. And I suppose the example of Port Macquarie was of particular interest to me, knowing that there's already a surgical robot at the private hospital in Port Macquarie. So certainly you've got a local workforce well trained in using these, and obviously a significant patient population already accessing. You've got a two-tier problem in Port Macquarie.
Yeah, I mean, as you would know, many of our surgeons work across the public and private systems, and so on. But I do understand the point around access to that for public patients, which is also important, that public patients have access to that technology in addition to those who have private health insurance. But yeah, happy to provide more detail to you on notice in respect to how those decisions are made. It is not possible for us to have a robot in every hospital. I have to be very clear about that for many reasons. The volume reason that I've articulated, but you know, there is a cost issue, of course, and we have to think carefully about where we embed those resources.
I appreciate that. I hope there'd be more than one in regional New South Wales than just Orange.
Indeed.
Thank you. There's a short amount of time for Mrs. Mitchell.
Thanks, Chair. The provision of free sanitary pads and tampons at New South Wales Health Services hospitals, effectively. My understanding is that there is a memo that says they're meant to be available for patients who are unable to supply them. Mm-hmm. But we've had some feedback from advocates that this isn't consistent across the state. Sometimes they're with staff and they're not in like a sort of vending machine style, I guess I'm assuming, sort of in hospital. What is the policy on that, and how should they be provided to patients who need them?
I think you've articulated that policy well, Ms. Mitchell, so we certainly can reiterate that. I think that it is critically important that women have access to sanitary
products, is that
products,
what we call
that's
items?
The word. Sorry, I'm
pads
getting
and tampons. I don't know. What are we
bit
called?
tired.
Yes.
To products. It is absolutely critical that they have access. Any role that we can play in that, we will. Elizabeth, I don't know if you've got any more to add on that.
Just to reiterate it, and certainly Ms Mitchell, that is exactly what the policy states. It actually says that we must provide free sanitary pads and tampons to patients who are unable to supply their own.
Yeah, I guess there's just a disconnect. People
I can see what you're saying, I'll just make sure that is understood clearly, but there may well be different processes and that's unhelpful, so I'll find out for you.
Okay, thank you. This is probably a capital one again, back to Ms Galander. The Tamworth, the mental health unit that's been finished, and Banksia mental health unit is now, I guess, empty, for lack of a better term, or what I think they're being transferred over the patients to the new unit in August. There's been a lot of support from the local community to see that unit repurposed as a drug and alcohol detox facility. Is there any work being done on that, or what's the intention with that building?
It may be more one for
sorry. Yeah, that's fine.
We are aware of that suggestion. At the moment, we don't believe that building is fit for purpose for that. It would actually need quite a lot of capital investment from our first look at it. We haven't totally discounted it, but at the moment it's not something that we are rushing into. We've just got to get some of these other projects done. We are aware of, and we've had conversations and meetings with the local member about it, but at this point we don't think that building is fit for purpose.
Is there any work being done though on the potential of having a detox unit in Tamworth, even if it's in a different building?
So we just do need to have a look at some clinical services planning around that.
Okay. And then while I'm on Tamworth, this is a bit of a weird one to end the day with, but it's come from a member of the community, and I do have a photo which I can table. It's bird poo all over the windows at the end of July, and I'm not trying to do a show and tell, but it's as I said, it's pretty dirty and pretty filthy. It may have been cleaned since then, but I think it's a bit of an ongoing issue there. Can anyone tell me how you're dealing with the bird poo at Tamworth Hospital? Anything we're doing to keep it more clean? That came from a patient who was quite distressed.
It does. The district is continuing to implement a comprehensive pest management program to address the long-standing pigeon infestation issues that we have at Tamworth. The bird deterrent measures, including spikes, netting and other exclusion controls. We actually have, and I don't know who counts this, but we have reduced the bird population by approximately 300 in the period from June to August. But there is an ongoing management plan to do this. There had been previous reports of bird lice in 2023 that were investigated. Pest treatment was taken place, but it actually ended up being determined that the person with lice was found that the root cause from that was from somewhere else.
Would you mind if I'm allowed to, in the 30 seconds, Ms. McCosker, checking whether those windows have been able to be cleaned or since,
I will check on that because I don't know about the windows.
I'd be happy. Look, I've got a copy of the photo if you'd like to take it. It'll ending on a good note today.
The concern is well known and being addressed.
Thank you. Thanks, Chair.
Are there questions from the government?
No, thank you, Chair.
There being no questions from the government, that brings us to the end of the day. Thank you all so much for making the time to give evidence today and for the work you do.